Partha Chattopadhyay, existing professor of the Department of General Medicine, Midnapur Medical College. Professor Dr. Nandini Chatterjee, she is professor of SSKM and IPGMR, Kolkata, one of the most prestigious hospital and medical college in Kolkata. Then I introduce Dr. Sarojit Bonik, who is professor, Department of General Medicine, attached to Jalpaiguri Medical College. I request all the judges to start the proceeding of our first session, that is evaluations of the presentations of our PGTs. And there is time limit is 6 plus 2, 8 plus 2, 8 plus 2. And all PGTs are requested. There is a time slot that is very important. You should complete it by 8 minutes. If you spill over, then your marks will be deducted. Okay, over to judges. Thank you.
Thank you, Professor Kormakar. I'll request Dr. Piyush Gupta to come over to the dais. Please maintain your time. Every overshoot of time, every minute will deduct 2 marks.
Before you start the proceedings, probably you know that there will be, your assessment will be done in 100 marks that will be divided into 5 questions or other topics. One is time management, slide or poster quality, quality of presentation, clinical relevance, and facing questions both to audience and to judges. Okay, start.
Good morning to all of you present here. My name is Dr. Piyush Gupta, and I'm here to present my paper on the topic Assessment of Electrocardiographic Changes for Cardiovascular Risk Stratification in Metabolic Syndrome Patient. Metabolic syndrome is not just a single disease, but a cluster of interconnected physiological, biochemical, clinical, and metabolic factors that directly increases the risk of atherosclerotic cardiovascular disease and type 2 diabetes. Diagnostic criteria for metabolic syndrome is from National Cholesterol Education Program Adult Treatment Panel 3, which requires at least 3 of the following features to be present. These features are abdominal obesity, elevated triglyceride, low HDL cholesterol, elevated blood pressure, and elevated fasting glucose. Criteria for these features are present on the slide. In this flowchart, I am here to present that how insulin resistance is a central pathophysiological force behind this cluster. In this, the root causes are genetic predisposition and overnutrition and sedentary lifestyle that leads to excess visceral adiposity, which releases high free fatty acid, pro-inflammatory cytokines, reduced adiponectin, which causes insulin resistance in liver, muscle, and adipose tissue, which causes dyslipidemia, sympathetic nervous system activation, hyperglycemia, pancreatic beta cell dysfunction, which causes hypertension, and type 2 diabetes, which later leads to atherosclerotic cardiovascular disease. Patients with metabolic syndrome have 2 to 10 folds of higher risk of sudden cardiac death than those without metabolic syndrome. So, how do we identify highest risk patient early? Here, ECG comes in, which is very accessible, low cost, non-invasive, and the sensitivity is to help to detect subclinical myocardial changes before symptoms appear. In my paper, I have chosen 4 parameters, ECG parameters, that are QT interval, QTC, TPT interval, TPTE by QT ratio. QT interval was measured from onset of QRS complex to the end of the T wave. Normal range is 350 to 450 millisecond. But the problem with the QT is that QT varies with heart rate. Faster heart rate shortens QT, and slower heart rate lengthens it. So, to account for the heart rate variability, we use the correction formula. Most common one is Bézet formula, which is QT by under root RR. TPT interval is measured from the top of a T wave to where it returns to the baseline. It represents the time when the last part of the ventricle is still repolarization, the most vulnerable moment for arrhythmia. Larger the value indicates greater heterogeneity, which creates the perfect substrate for the re-entrant arrhythmias. But the problem with TPTE has a problem that it varies with the overall QT interval. So to normalize it, we calculate TPT by QT ratio, which expresses transmural dispersion as a proportion of the total repolarization. As you can see in this graph represents the prevalence of ECG changes in metabolic syndrome patient, in which QT prolongation shows prevalence of 32.5 among metabolic syndrome patient, which reflects overall ventricular repolarization time. QTC prolongation is prevalent among 37.5 patient, which is positively associated with interventricular septal thickness. TPT prolongation shows 42.5 prevalence among metabolic syndrome patient, which directly reflects transmural dispersion of repolarization. This transmural dispersion is substrate for re-entrant ventricular arrhythmias. And the TPT by QT ratio, which is prevalent among 38% patient, which is the most sensitive marker and reflect pathophysiological heterogeneity. In this graph, I am showing how the prevalence of metabolic component in ECG, in which central obesity is prevalent across 68 to 75 patient, with the mechanism of visceral adiposity increases inflammatory markers and autonomic dysfunction. Hypertension is prevalent across 72 to 80% patient, with the mechanism of hemodynamic stress from hypertension promotes left ventricular hypertrophy and electrical remodeling. Dyslipidemia is prevalent across 78 to 84 patient, with the mechanism of dyslipidemia promotes endothelial dysfunction and myocardial inflammation. And hyperglycemia, which range from 80 to 87 patients, with the mechanism of hyperglycemia causes direct myocardial ion channel dysfunction and oxidative stress. In this pie chart, I'm showing how ECG changes with the sex, in which male patient is highly prevalent, high prevalence of QTC prolongation and TPT by QT elevation also present. And in female patient, there's a great burden of QTC prolongation and TPT prolongation. This implies sex-specific ECG pattern that reflects differential hormonal, autonomic, and structural cardiac remodeling. So how do we stratify the risk? There is a strict risk stratification protocol in which there are four strata: low, intermediate, and high. In low, in which when QTC is less than 450 in male and less than 470 in female, TPT is less than 77, and TPT by QT ratio is less than 0.20. In the intermediate, we take 2 to 3 parameters which are abnormal, and in high, multiple parameters are prolonged, in which TB by TE by QT ratio is more than 0.20, which is very particular. So, if the patient is present with the high risk, those who are high risk patient, what intervention we should use? We use aggressive glycemic control, which target HbA1c less than 7, weight reduction program in which 1 kg loss associated with the QTC shortening, lipid management, statin therapy improve repolarization parameter, blood pressure control reduces transmural dispersion, and regular ECG monitoring is needed for one for the baseline after 6 months and after 12-month interval. So the key conclusion: ECG repolarization changes are strong phenotypic marker for high-risk metabolic syndrome. All four metabolic components cluster together in 68 to 87% of the patient with any ECG abnormality. Significant sex-based differences exist. Female shows higher QTC and TPT prevalence, while male shows higher QT and TPT QT prevalence. Sex-specific ECG risk stratification may enable precision decision approach in metabolic syndrome management. Thank you.
Any question from the audience? Though there are only few, still there is a column. Anyway, so of all the ECG abnormalities, which one was most important and more prevalent?
Sir, up till now, the most search one is QTC prolongation, but now TPT by QT ratio is now coming into the view. Now TP, ma'am, because that TPT by QT ratio shows us the repolarization time, because
So have you done a study of your own?
yes, ma'am, I have done
Okay.
study.
So from the presentation that you have shown, the judges are confused whether you are talking about your own study or a theoretical discussion about cardiac ECG abnormalities in all patients of metabolic syndrome. We are not looking for that. That is theory. We know that. What we were asking for is that what was your methodology to choose those people? How many was your, what was the actual result of your study? These conclusions, as you have written, are strong phenotype. What is the actual conclusion from your study? What was your sample size?
Ma'am, in my sample size, I have taken 70 patients with
No,
metabolic.
how did you calculate the sample size?
With the use of the, we have done the formula by which I have taken that 70 with the earlier study that was done on this study group. We deduced the formula. By that we.
What was the prevalence in that study?
Ma'am, in that study, the prevalence was that QTC prolongation is more in that in those studies, and in my study also, I have also seen that QTC prolongation is there. But to clarify that now TPT I have included because of new it is coming up upcoming, so I have also included in this study. But the
Okay, thank you. Okay, thank you.
thank you, ma'am.
Dr. Sunita Roy.
Dr. Sunita, your time starts now.
Yes, sir. Good morning, everyone. Today, I, Dr. Sunita Roy, PGT second year of General Medicine, MGM. My topic for the paper presentation is waist-height ratio versus body mass index for the prediction of cardiovascular complication in a people with diabetes at a medical college of Eastern India. This paper is co-guided by Dr. Uttam Kumar Paul, that is HOD sir of General Medicine, MGM, Kishanganj. Introduction, diabetes burden in India. 90 million adults in the range of 20 to 79 years are living with diabetes in India, and the adult prevalence is 10.5%. Among adults more than 45 years, prevalence up to 19.8%. Many cases remain undiagnosed, which is a hidden burden. Obesity is a risk factor and cardiovascular complication in diabetes. Obesity, especially fat distribution, increase risk of cardiovascular disease. In people with diabetes, obesity implies risk, heart disease, stroke, hypertension, etc. Cardiovascular disease is a leading cause of morbidity and mortality among diabetes. Early identification of high-risk individual can help prevent complication. Limitation of BMI, that is body mass index. It only measure overall body mass, that is weight relative to height. It does not reflect fat distribution, visceral versus subcutaneous fat. It cannot distinguish central obesity, that is abdominal fat, which is more closely linked to cardiovascular risk, may under or overestimate risk, especially in population with different body fat pattern. Why we consider waist height ratio? Because it's the waist circumference divided by height. It's a simple measurement of central obesity. It reflects fat distribution, that is abdominal fat, a better marker of cardiovascular risk. It is easy to measure, inexpensive, non-invasive, suitable for large-scale screening. It is maybe more accurate than BMI in predicting cardiovascular complication. Rationale of this study, cardiovascular complications are the major cause of death in people with diabetes. Central obesity is more strongly linked with cardiovascular risk. BMI does not measure central fat accuracy. Waist height ratio is simple, low cost, may predict heart risk factor. Needed to evaluate which measures is more reliable in diabetes patient in Eastern India. The aim of this paper is to compare the effectiveness of waist height ratio and BMI in predicting cardiovascular complication in individuals with diabetes mellitus. The objectives are primarily to assess the predictive power of waist height ratio and BMI for cardiovascular complication in people with diabetes. The secondary objectives are to find out the correlation between waist height ratio and incidence of cardiovascular complication in diabetes patient. Second was to ascertain the correlation between BMI and incidence of cardiovascular complication in diabetes patient. Third one, to compare the sensitivity and specificity of the waist height ratio and BMI in predicting cardiovascular risk among diabetic patients. The methodology, Study design is cross-section observational design. Inclusion criteria are adult age more than 18 years and above, diagnosed with diabetes mellitus confirmed by medical records. Third one is willing and able to provide informed consent for participation in the study. Fourth one is able to undergo anthropometric measurement and laboratory testing, regularly attending clinics for diabetes management. Exclusion criteria are pregnant women and those who have given birth within the past 6 months, individual with recent major surgery within past 3 months, patient with condition affecting body composition like ascites, presence of severe cognitive impairment or psychiatric disorder. Sample size by this formula calculated 109 is the study considered for sample size. Data collection by anthropometric measurement by height, weight, waist circumference, BMI calculation, and waist height ratio calculator. Clinical data by medical history, medication use, or lifestyle factors like smoking, physical activity, or dietary habits. Laboratory tests by blood pressure, lipid profile, and HbA1c level. Data analysis, descriptive statistics, mean, standard deviation, range for continuous variable, that is height, weight, and waist circumference, frequency and percentage for categorical variable, smoking status, presence of cardiovascular complication, correlation analysis, reversal operating characteristics curves to evaluate compare the predicted accuracy of waist height ratio and BMI for cardiovascular complication. The area under the curve value will use to determine the effectiveness of each metric. Multivariate regression analysis to control the potential confounders like age, sex, duration. Baseline characteristics, total studied sample is 109 adult with type 2 diabetes. The average age for participants was 55.1 years and about half were men. Out of participants, 29 were already have the heart disease and 80 were do not have the heart disease. Patients with heart-related problem were older than those without. 59.5 years versus 54.0 years. The difference is statistically significant. P-value is less than 0.05. Anthropometric indices, body composition and cardiovascular risk. Mean BMI is 25.2 plus minus 3.9 kg per meter square. Mean waist height ratio is 0.5 plus minus 0.05, suggestive of more participants were overweight with central obesity. Correlation and regression findings, both BMI and waist height ratio show a modest positive correlation with cardiovascular disease. BMI coefficient is 0.22 and waist height ratio coefficient is 0.23. Higher value were linked with more cardiovascular complication. BMI, the odds ratio is 1.13, which is borderline significant, and waist height ratio is odds ratio of 4.9 is a strong and significant risk marker. It's a ROC analysis indicate BMI and waist height ratio. The area under the curve for the waist height ratio is 0.71 and BMI is 0.6, which is more significant. This is the pictorial representation. Key findings, in adult with type 2 diabetes, waist height ratio was superior to BMI in predicting cardiovascular complications. Show larger effect size in logistic regression and higher ROC area under the curve. Highest the importance of central obesity in cardiovascular risk, supported by international studies like Browning, Lee et al., Sibai et al. Pathological central obesity, insulin resistance, dyslipidemia, inflammation leads to cardiovascular disease. Clinical limitation, clinical relevance, waist height ratio is easy to measure, just waist and height. Simple patient message, keep your waist less than half of your height. BMI is less intrusive, varies by ethnicity and may misclassify risk. Limitation is a cross-sectional design, cannot interfere casualty, modest sample size from single center, limited generosity. This does not compare waist height ratio with other indices like body roundness. Conclusion, in adult with type 2 diabetes mellitus attending in tertiary care hospital in Eastern India, waist height ratio was superior to BMI in predicting prevalent cardiovascular complication. Waist height ratio demonstrates strong association with cardiovascular disease, highly discriminatory ability, and more clinically useful cutoffs given its simplicity, low cost, and close relationship. Waist height ratio should be routinely measured in diabetes clinics, incorporated into cardiovascular risk assessment, particularly in Asian Indian population with high burden of central obesity. Thank you.
Okay. So I have 4 points. You have mentioned that you have taken only type 2 diabetic patients aged more than 18 years.
Yes, sir.
How you diagnose type 2 diabetes? You don't know whether is there any MODI or any other form of diabetes was included in your study, or you just excluded type 1 diabetes and taken the rest?
I just excluded type 1 diabetes and just taken the type 2 diabetes mellitus.
And how did you know if they are type 2 or otherwise? You didn't. Because there are many genetic, why I am going to tell this, because there are many genetic forms of diabetes which are inherently having increased risk for cardiovascular disease, and that might interfere with your study. Now next question is, if you have excluded type 1 diabetes, then why you have excluded type 1 diabetes?
Sir, because the cardiovascular disease is more common in type 2 diabetes because of the obesity, which is more common in type 2 diabetes than type 1. Type 1 patient is having mostly the lean, thin patient. So basically the cardiovascular complication I have to see in diabetes patients. So
No, your answer should be cardiovascular complications arises much earlier
early
in type 1 diabetes. Any complications, any macrovascular complications arises much earlier in diabetes, and that might confound your study timings. Third question is, how did you measure the complications? You have done a cross-sectional study. You have taken it at one point of time. Suppose ECG changes, echocardiographic changes, or any events. So how did you measure the complications?
So I have taken the two groups. The one who's having the cardiovascular complication previously by the medical reports I can see, ECG, coronary artery disease, dyslipidemia, or any stroke. The other group is the patient who is not having cardiovascular disease. So I have to compare both the waist-height ratio and BMI in both the groups and predict which one is better, BMI or a waist-height ratio.
So for those who are not having any past history of AMI, ISD, ECG changes or anything, have you done or tried to done any investigations like TMT, echo, or any other investigations like angiography to know whether they have any silent cardiovascular complications or not?
Yes, sir, I had done, sir. We have the two groups, the patient who's having cardiovascular disease and the groups do not have that. So in both the groups, I have done with the investigation like ECG, echo, TMT.
You have done all.
Okay. So can you tell us about the South Asian tendencies in connection with obesity and about the YY paradox?
Ma'am, the South Asian. Ma'am, we have the two parameters, WHO and Asians. Asians having the different parameters for that, like for the BMI also, we have decreased cutoff for the Asian.
No, that is not the question. What is the special characteristics of Indians
Central
which
obesity.
differs from Western population and for which different cutoff values are being established not only for BMI, but also we do not rely as much on BMI, which is your study.
Yes.
We rely on other anthropometric measurements. You have studied one of them. Would you want to tell us about some of the other anthropometric measurements?
Ma'am, the other, ma'am, waist height ratio. Ma'am, and the ankle brachial.
Okay, thank you. Okay,
Thank you, ma'am. Yes, sir. Okay, sir. Thanks.
Dr. Jigesh Sartana. Jignesh Sartana. Dr. Gurbir Singh. Dr. Gaurav Chauhan.
Oh, tale who is coming? Gaurav? Okay.
start now.
Good morning, everyone, to the esteemed faculty, seniors, juniors, and my co-PGs. Today, I'm going to present on combination therapy with norepinephrine and esmolol in septic shock, a clinical and prognostic evaluation. Septic shock is a critical condition characterized by circulatory failure, tissue hypoperfusion, multi-organ dysfunction. Despite standard treatment protocol, it remains a leading cause of mortality in intensive care units. Current management of septic shocks. The cornerstone of septic shock management include fluid resuscitation and vasopressor therapy, primarily with norepinephrine to maintain mean arterial pressure. Clinical challenges with norepinephrine, while effective, prolonged use of norepinephrine can lead to excessive adrenergic stimulation, resulting in tachycardia and increased myocardial oxygen demand, which may worsen patient outcome. The need for the heart control. Tachycardia in septic shock. Tachycardia is common in a septic shock patient and is independently associated with higher mortality and rates and prolonged ICU state. Limitations of norepinephrine include non-epinephrine improve perfusion pressure but does not address the elevated heart rate, which can contribute to cardiac dysfunctions. What is esmolol? Esmolol is a short-acting beta-1 selective blocker that can effectively reduce heart rate without significantly affecting blood pressure or cardiac output. Potential benefits of esmolol include by modulating heart rate, esmolol may help reduce myocardial oxygen consumption, improve left ventricular filling, and enhance organ perfusion. So we have our study aimed to evaluate the clinical effect and prognostic impact of combining non-epinephrine with esmolol therapy in a septic shock patient admitted to ICU. Methodology was conducted over 1 year at Mata Gujari Memorial Medical College, Kishanganj, included 25 patients with septic shock who received standard management along with esmolol for persistent tachycardia, heart rate more than 95 beats per minute. In study, the key findings were heart rate control. Baseline heart rate decreased significantly from 112 beats per minute to 89 beats per minute after esmolol administration, with p-value of less than 0.001%. Reduced vasopressor requirement. Norepinephrine doses decreased from 0.35 microgram per kg per minute to 0.18 microgram per kg per minute, with p-value of less than 0.1. It also improved the lactate clearance. Lactate level declined from 4.6 millimole per liter to 2.9 millimole per liter. SOFA score was also improved. SOFA score improved from 8.5 to 6.3 with p-value of less than 0.5. Survival rate, thus 28 survival rate was 72%, indicating favorable short-term outcomes. Safety profile. No significant adverse cardiac events were observed in the study population. Esmolol was well tolerated and did not lead to hypotension or bradycardia. So the conclusion of the study was the combination of norepinephrine and esmolol in septic shock patient patient result in improved heart rate control, reduced vasopressor requirement, better lactate clearance, and favorable short-term outcome. Recommendation: esmolol may be considered as an adjacent therapy in septic shock patient with persistent tachycardia after adequate resuscitation. Further direction, like larger randomized control trials was warranted to confirm these findings and establish standard dosing protocols. Thank you.
In how many patients you have tried this combination?
25 patients.
And are there any precautionary measures or any contraindications for this combination?
Yes, sir. There was some inclusion and exclusion criteria for the study. The inclusion criteria were adult patient aged 18 years or older, diagnosed with septic shock according to sepsis 3 criteria, requiring norepinephrine for hemodynamic support, able to provide informed consent or through legal representative, no contraindication to beta blockers. And exclusion criteria was patient with pre-existing bradycardia, heart rate less than 50 beats per minute, history of severe heart block or sick sinus syndrome, pregnant or lactating women, non-allergic or intolerance to esmolol, patient with terminal illness not expected to survive 24 hours, refusal to participate in the study.
So,
Researched other literature for acceptance and use in other centers.
Yes, sir. There was a randomized control trial which was done in 2017, which esmolol benefit in septic. So a study showed that although esmolol did not significantly reduce vasopressor requirement, but it did lead to lower C reactive protein level and reduced oxygen consumption, suggesting inflammatory and metabolic benefit. Another randomized control revealed that esmolol reduced heart rate constantly over 7 days, although it did not impact overall mortality, norepinephrine doses or organ dysfunction. In a 2025 pilot randomized study, earlier administration of esmolol post-resuscitation was feasible and lead to faster heart rate reduction without
Dr. Gaurav,
compromising.
you are supposed to memorize this, not read from it. You cannot do this.
Sorry, ma'am.
Acha, just
I-
another thing is that you have given esmolol for persistent tachycardia in shock, septic shock.
Yes.
Hypovolemic shock or after adequate resuscitation, you told.
Yes.
How do you adequately resuscitate the patient?
Sir,
What is the volume resuscitation protocol?
for volume?
What is adequate resuscitation? You have told you have
Yes,
given esmolol to tachycardic patient even after adequate resuscitation. What do you mean by adequate resuscitation?
Yes.
and so my one and last question, I think, is you have chosen septic shock patients who are on norepinephrine only.
Yes.
Now the question arises that the amount of norepinephrine, how much amount of norepinephrine at what rate they are getting, and for how long duration, and at what point of time you have introduced the esmolol infusion. This should be clearly mentioned. And secondly, whether these patients were on any other support like vasopressin or dobutamine or dopamine, because otherwise the scenario will be changed. If your patients were only on norepinephrine and still are BPA not controlled, the guidelines suggest that you should add vasopressin.
Sir, we use esmolol to prevent cardiac
No, what
complications
point?
because
After 12 hours, after 15 hours, at what point of time? That is the most important point.
within the initial 24 hours we indeed.
So you have started NORAD and you wait for a few
Yes.
hours, and when the heart rate is still high,
Yes.
heart rate is going up, then you have started
Yes,
esmolol infusion.
esmolol.
But does it not cause hypotension?
No,
because
sir.
of esmolol?
Is beta 1 is only control the heart rate, not significantly affecting the blood pressure.
But
As
what
short
we
acting.
learned that esmolol is given, infusion esmolol is given for controlling the malignant hypertension or like this, hypertensive emergencies, তাই না? এরকম তো আমরা পড়েছি না ছোটবেলায়? মানে বড়বেলাতেও পড়েছি। ঠিক আছে।
how
Now,
hard
your study is a unique study, no doubt about it. But what I suggest that your institute should take much more larger data and much more number of patients, and it should be a comparative study.
Yes.
Okay, thank you.
Thank you.
Thank you.
Thank you. Last presenter, Dr. Ripley Kaur. Any other presenter who was called and not present at that time? Have they come?
Not allowed. Once they call, they call. We will not allow anyone. Even they come now. Yes. But
A very warm good morning to everyone. Today, title for my presentation is A Study on Factors Associated with Non-Adherence to Antihypertensive Medications. Introduction. Hypertension is a common chronic disease that contributes substantially to global illness and death. A major challenge in achieving effective blood pressure control in patients' non-adherence to antihypertensive medications. Multiple factors influence poor adherence, including complex treatment regimens, financial constraints, limited awareness, psychological barriers, and gaps within the healthcare systems. Recognizing and addressing the determinants is crucial for ensuring sustained hypertension control, improving treatment outcomes, and preventing long-term complications. Understanding these issues can guide strategies to enhance adherence and overall management of hypertension. Research objectives. Aim. My aim in the study was to investigate the factors associated with non-adherence to antihypertensive medications among patients attending a tertiary healthcare center and to evaluate the effectiveness of counseling aimed at improving adherence and their subsequent impact on blood pressure control. Specific objectives: to determine the demographic, socioeconomic, and clinical factors associated with non-adherence to antihypertensive medications among patients at the tertiary healthcare center, to assess the effectiveness of counseling designed to improve medication adherence in hypertensive patients, and to analyze the impact of improved adherence through counseling on blood pressure control among the patient population. Materials and methods. My study type was cross-sectional observational study, and the study was conducted in the Department of General Medicine at MJ Medical College and LSK Hospital, Kishanganj, Bihar. My study period was over for a period of 18 months from June 2025 to November 2025. June 2024 to November 2025. Study population included patients diagnosed with hypertension and prescribed antihypertensive medications, attending the General Medical Department at MGM Medical College and NSK Hospital. My sample size, according to the prevalence and analysis of worldwide data for the global burden of hypertension, was 20.6% of Indian population. I used this formula for my sample size calculation, that was n is equal to z1 minus alpha divided by 2n whole square, in which Z was the level of, it was for 95% confidence, Z was 1.96, and alpha was there for the level of significance. For level of confidence at 95% confidence, it was 0.05, and prevalence was 20.6, and relative precision, that is epsilon, was 8%. So the sample size came out to be 98.17, and the final rounded one was 100. The inclusion criteria in my study was adult patients aged 18 years and older, diagnosed with hypertension for at least six months, prescribed at least one antihypertensive medication, willing to provide informed consent. Exclusion criteria: patients with cognitive impairments that affect their ability to provide informed consent, patients with secondary hypertension, patients unable to participate in the study for any reason. Methodology: instruction questionnaire was taken, and Morisky medication adherence scale was taken along with that, and the measurement for blood pressure was done by manual sphygmomanometer. This was a classification of hypertension, and 2 criteria was taken, and we followed this. ACC stands for American College of Cardiology, and AHA stands for American Heart Association. So in the guideline differences, we took for the normal BP ranges, that was normal less than 120 by 80 by mm of mercury, elevated was 120 to 129, and diastolic BP was less than 80. In hypertension stage 1 was 130 to 139 by 80 by 289, and hypertension stage 2 was more than or equal to 140 by 90. In this, the data I have used for the adherence, the scale that was the MMSA-8, that stands for Morisky Medication Adherence Scale, and this is a comprehensive tool designed to assess adherence to medication regimens among hypertensive patients. The 8 questions will be included that we'll see further, and the scoring was high adherence, score 8, medium adherence, score 6 to less than 8, and low adherence, score less than 6. The data collection procedure, patients was in-depth interviewed during their routine clinical visits, and the structure questionnaire was administered to collect data on demographics, socioeconomic status, and clinical history. Blood pressure was measured and recorded. The data collection analysis, in-depth interviews, focused group discussions of hypertensive patients were taken for exploring the socioeconomic status of non-adherence to antihypertensive medication. Field notes were taken during the interviews and discussions, and quantitative data were analyzed by using Microsoft Excel. Ethical considerations, informed consent was obtained from all the participants prior to the inclusion in the study. The study protocol was reviewed and approved by the Institutional Ethics Committee of MJ Medical College and LSK Hospital. Confidentiality of patient information was maintained throughout the study. Data was anonymized and stored securely. Participants were informed that their participation is voluntary and they can withdraw from the study at any time without affecting their medical care. So this was the interview that I have taken in my study, in-depth interviews, some of the examples that I have taken in the OPD and other doctors' DDR room. This is the Morisky Medication Adherence Scale 8, the 8 questions. First stands for, do you sometimes forget to take your blood pressure pills? Second, over the past 2 weeks, were there any days when you did not take your blood pressure medication? Third, have you ever cut back or stopped taking your medication without telling your doctor because you felt worse than you took it? Next, when you travel or leave home, do you miss your medication? Fifth, did you take your blood pressure medication yesterday? Sixth, when you feel like your blood pressure is under control? Seventh, taking medication every day is a real inconvenience for some people. Do you ever feel hassled about it? And the last one was, how often do you have difficulty remembering to take all your blood pressure medication? Results. After identifying the major factors responsible for non-adherence among the 100 hypertensive patients included in the study, I, as the treating physician, conducted structured and personalized counseling session with each patient. And this counseling focused on improving their understanding of hypertension, importance of lifelong medication adherence, and clarification of misconceptions. The results following counseling were highly encouraging. So before counseling, 45% of a patient showed low adherence, 35% moderate adherence, and only 20% high adherence based on the MMSA-8 scale, in which the graph I will be showing in the next slide. And after targeted counseling, high adherence increased from 20 to 48%, moderate adherence decreased from 35 to 32%, and low adherence significantly decreased from 45 to 22%. Now, what we conclude that high adherence increased and moderate adherence and low adherence has decreased. So this is the adherence level chart that was prior and that has increased to further. Now, age-wise improvement after counseling, in this table we see 18 to 30 years, in pre-counseling adherence was 55%, which led to 82% adherence, and there was 27% improvement. Same for 31 to 45 years, we have seen 27% improvement, and 46 to 60 years, 42% to 70%, that is 28% improvement. 60 plus years, 35% adherence to 62%, that accounts for 25% adherence. So although older individuals showed the lowest baseline adherence, they still demonstrated significant gains after counseling, indicating that behavioral reinforcement is effective across all age groups. The post-counseling adherence graph shows that. That's it. Conclusion with this.
Okay.
Thank you.
Yes. Yes, this was a very relevant and very nicely done study. And can you tell me there is one rule? Okay. Huh? What percentage of people have controlled hypertension? What percent of people are aware of their hypertension?
Ma'am, exact percentage that how much people have control and this I won't be aware of. This I have not studied that much up to that extent. But I know that the 20.1% was the prevalence of hypertension, and I took them, and then further with the effective counseling, I have that study, ma'am.
This is a cross-sectional study or a longitudinal study?
It's a cross-sectional study because at the time of the presentation, I had exposure as well as outcome. Exposure was that the factors that were associated with this, socioeconomic factors, demographic factors and all, and the outcome was that they are not adherent to it. So that's why I took as the cross-sectional.
How then can you measure the counseling effect?
Counseling effect, I took it over, sir, observational study, that with this observation that...
No. How many contact do you have with the patient?
Sir, 100 patients I have taken.
No. How many contact with each patient? How many contact?
Sir, 3 visits, 2 to 3 visits with each patient.
Then it cannot be a cross-sectional study. What type of study is this then? If you have had 3 contacts with the patient, so that means it is not cross-sectional. What type of study then it is?
Longitudinal, ma'am, then. This I'll correct. Thank you. Pardon, sir? Yes, sir.
So you took the prevalence of 20.1%, but in ICMR India data, it was in 2021, prevalence was 35%. Highest prevalence in Punjab and lowest prevalence in Meghalaya. So
Okay,
you
sir,
should follow the present data.
Okay, sir. Thank you.
Thank you, respected judges, for such an interactive session. We request all the honorable judges to collect the memento from the registration counter.
The thing is that first we should be clear what is a cross-sectional study. The cross-sectional study is one point we are studying the patients, and here what her study design was that she has met the patient over a period of time. So this is a prospective study. No, it's okay. Analytical study. This patient, the group of patients that she has taken, what is your point?
As a cohort study, she has to take the sample and she has to follow it up. and then he has to do it as a cohort study. But in my knowledge, there is no, I might be wrong, I can clarify, there is no thing called longitudinal study. Okay, she is, yeah.
It's not me. I'll explain to her. Longitudinal study, okay. আমি
उसमें सीधा पोस्टर पे आना है।
पोस्टर भी नहीं आना, पोस्टर जाना है, अभी पोस्टर भी होना है, पक्के बात है। हाँ पोस्टर, अच्छा ये आना है।
नाम मेरे को Yes. So for poster we will send the people.
We will talk about that, please.
Okay, sir. A very good morning to all. On behalf of the organizing committee of ICP-CON 2025, we, Dr. Suryansh Pratik, and
I, Dr. Sunita Roy,
extend a most respectful and heartfelt welcome to our esteemed faculty members, distinguished speakers, honored guests, delegates, residents, and students. We welcome you all to the second and the final day of ICP-CON 2025. It is indeed a privilege to gather in the company of such esteemed clinicians and scholars.
Conference such as ICP-CON holds significant importance as they serve as platform for intellectual exchange, evidence-based dialogue, and the dissemination of contemporary evidence in field of medicine. They allow us to collectively reflect upon our evolving challenges, strengthen our clinical acumen, and reform our commitment to excellence in patients' care. With these words, we take the honor of initiating the second scientific session of the day, which is Diagnostic in Transition, Clinical to Digital. I humbly request the Honorable Chairperson for this session, Dr. Atul Bed Sir, Professor, Department of General Medicine, MGMC, Kishanganj, Bihar. Dr. Vijay Kumar, Additional Professor, Department of General Medicine, AIMS, Patna. Dr. Anupam Khokla, Professor, Department of Anatomy, Medical, Mata Gujri Memorial Medical College, Kishanganj, to kindly come on the dais and take the proceeding forward.
And Dr. B.K. Singh, Professor of Department of General Medicine.
Kindly come upon the dais and take the proceeding forward.
So the first talk is
so on behalf of Department of General Medicine, MGM Medical College, Kishanganj, and ICP Bihar, Jharkhand, Bihar, West Bengal, we welcome you all again. And for the next talk, may I invite Dr. Harishankar Pathak sir. He is a well-known figure and he needs no introduction. He is a past president of ISCM also, and he is a member of governing body of API as well. So over to Dr. Harishankar Pathak sir.
Good morning, respected chairpersons. At the outset, I thank Professor P.S. Karmakar and the scientific committee for giving this opportunity to talk on a very basic, simple topic, but useful one for everybody. So, pulse is a wave of, we all know, pressure changes created by ejection of blood from the heart into the aorta and blood column and arterial wall to the periphery. Examination of the radial pulse is an important and essential part of the clinical examination of the patient. is not only important for examination of the cardiovascular system, but also for the systemic examination of the patients, because arterial pulse is one of the vital signs that must be checked with the general examination. We all know examination of the radial pulse provides physiological information regarding the work of the heart, the circulatory state and hemodynamics, that is blood volume, blood pressure and so on, condition of the arterial wall, the state of autonomic activity in the body at the time of examination, the mental state of the subject, and the state of body metabolism and temperature. This is a very simple thing. I'm not going to stress, but you must be sure that you are following the proper examination protocol as learned from earlier days, from the basic classes. We examine pulse under these headings: rate, rhythm, volume or amplitude, character of the pulse, condition of the arterial wall, radiofemoral delays, and other peripheral pulses also. We must count properly, not immediately after encountering the patient. In fact, at any clinical examination or during examination of the patient, while you are taking the history, you must your fingers, 3 fingers, over the radial artery, and that will produce a bondage between the patient and the physician, and by that time, patient will stabilize during history taking. So after that, we should start counting the pulse, and as per clinical protocol, we must examine the radial pulse and other pulses at least for 1 minute. The ideal time is 3 times, and the average of the 3 should be taken. At that or after that, if we have already examined the heart also, we must find out the pulse deficit also. At this moment, yes, at this stage we will discuss tachycardia. We all know tachycardia may be normally present in patients during or after exercise, after eating, if the patient is a bit rather emotional and not in a proper mental state. During excitement, we should also remember that pulse rate will be higher in infants and children during pregnancy and high environmental temperature. Physiologically, pathologically, tachycardia is always there in most of the cases in fever, in presence of anemia, thyrotoxicosis, beriberi, heart failure, and shock during hemorrhage or any other condition, and passage disease. In a febrile state, we expect temperature to rise by 10 degree per 1 degree Fahrenheit rise of temperature. If this is not maintained, that is, fever is there but pulse rate is low, we call it relative bradycardia. Suppose if you are encountering a patient with fever, with headache, vomiting, and we are getting relative bradycardia, what will you suspect at that moment? That is the index of suspicion. Any postgraduate? SRs and postgraduate trainees? Anybody? You are examining, you have encountered a patient with fever, headache and vomiting, and at that moment you are getting pulse rate to be low. What will be clinical suspicion?
The medicine PGs and
Probably
the
patient is
intensivists.
suffering from meningitis.
We have medicine PGs here, no? You should answer these questions, no?
Relative bradycardia is also found in patients with, classically in patients with enteric fever. Now, a patient was febrile, had a pulse rate of 120. After your treatment, patient's temperature has come down to normal. But pulse rate is still high, or rather increasing. What was before, after treatment 100, and after 2 days patient is afebrile, but patient's heart rate has shot up to 120, 130, 140. What will be clinical suspicion? Anybody? Young graduates, postgraduates? So, patients might have developed viral myocarditis. Or patients had a history of multiple joint pain. Fever has subsided, but patient has developed rheumatic carditis. So these are the clinical clues or clinical suspicion just at the time of examination of the pulse. This is our basic knowledge should be applied. So, I'm already discussed bradycardia found in athletes during old days. Medication is very important. We must take history about history of any. What drug will cause bradycardia in your clinical practice? Common drug which will cause bradycardia. This is very simple drug. I thought it to be interactive amongst postgraduates and SRs. Anyway. So beta blockers are the common drugs which will produce bradycardia. Pathologically, in mixed edema or hypothyroidism is very common. A patient face appears to be simulating a face of hypothyroid patient, gradual weight gain and other features. Along with that, he has got bradycardia. We must have suspicion. In a patient of jaundice, obstructive jaundice is a very common cause of bradycardia. In complete heart block, we will get very low pulse rate. Whether patient is on digitalis, though the use of digitalis today is very minimal. So I have already discussed this. Relative tachycardia is very important. Relative bradycardia is very, very important because during examination you will have some clinical clues about further workup and further diagnosis. Sinus arrhythmia is increase of heart rate during inspiration. This may not be abnormal in young children, very young age, but if it is present in older individuals, this is abnormal. What is rhythm? When we call a pulse to be sinus, rhythmic or regular pulse, when the interval between any two successive beats is always equal. You just correlate with your knowledge in your during what you do in the examination, clinical examination. If the interval between any two successive beats is equal, it is regular. If not, irregular. That is the basic thing. When it's not constant, the pulse is said to be irregular. The irregular pulse, this irregularity may come at regular interval. We call it regularly irregular. If irregularity is not coming at regular, we'll call it irregularity. And atrial fibrillation is a classical example of irregularly irregular pulse. for this, in this column, that is irregularity, if the if any pulse, this irregularity is maintaining a definite pattern, that is suppose one pulse, two pulses are, the interval is same. The third one is coming earlier and then followed by a long pause and a pulse. This is the classical description or example for extrasystoles. So extrasystoles will always follow a definite pattern. A normal volume pulse will be followed prematurely by a low volume pulse, and then a pulse which may appear to be of higher volume due to this compensative pause. This is the classical description or definition of extrasystole. If this extrasystole, two normal pulse, one normal pulse, then one irregular pulse, premature beat, we call it pulsus bigeminus. If there are two normal pulses followed by an earlier pulse, that is extrasystole, we call it pulsus trigeminus. So this regarding volume, it is the degree of expansion of the arterial wall during each pulse wave. In physiological conditions, the volume is normal and equal in both sides. Normal volume cannot be described, but can only be appreciated by palpating the artery of a normal individual. So this is your own clinical assessment, your own clinical knowledge by examining a number of patients.
Sir, may I take a moment to interrupt, sir? I think it's time for the next.
To find out what is normal volume pulse. This pulse volume is an indicator of systolic volume of the left ventricle, systolic function of the left ventricle. In this volume column, we have a number of pathologies. Pulsus paradoxus. What is that?
Sir, I think, sir, I think your time is over now.
No, just make it short.
We'll have to wrap up now.
We have thought of, we know we have got radio frequency, very important. So, these are the few examples of that is ECG presentation of a number of abnormalities. So this is the sequence of events in extrasystole, a bit that comes earlier than expected, followed by a compensative pause, and pulse deficit usually is less than 10. Atrial fibrillation, volume, under this column we have pulsus varvus, that is low volume pulse, high volume pulse collapsing, high volume is called pulsus magnus. High volume pulse we find in atrial rather aortic regurgitation with collapsing character. We call it water pulse.
Can you please remind him, because now we have to wrap up now, because we have already overshot by around 2 minutes now.
Before I conclude, I just I will mention a very important event which I remember. Previously, the ministers and health ministers usually used to visit different health centers and hospitals suddenly. So during one visit, the minister was passing through the patients. যদি সবাই বাংলা বোঝেন তাহলে ওনার ল্যাঙ্গুয়েজেই বলি, বলুন কেমন আছেন? হ্যাঁ ডাক্তার ভালো আছি। আরেকজন যে ভালো আছি আগে থেকে, কিন্তু আরেকটা কথা বলবো, কেউ আমাকে দেখেনি। তো উনি সঙ্গে সুপারিনটেন্ডেন্ট ছিলেন, ওনাকে ডাকলেন, কি আপনার ডাক্তারবাবুরা ভিজিট করেন না? তো উনি আনলেন, দেখলাম সব কটা রিপিট নোট দেওয়া আছে। তখন উনি বললেন যে আরে ডাক্তারবাবু তো এসেছিলেন। না, ডাক্তারবাবু এসেছিলেন, উনি আমার নাড়িও দেখেননি আর কলও লাগাননি।
Sir, please wrap up, sir.
So that is the feeling of the patients. So the importance of the examination of the pulse and examination of the patient is not only for our medical knowledge, for also for the patients and a socio-medical projection. Thank you.
We have already overshot around 2 minutes, so now, okay.
Okay, the next speaker, I would like to call upon Dr. P.K. Sharma with his topic Basics of Rheumatology. Dr. P.K. Sharma.
Hello. Dr. P.K. Sharma, is he here or not? So, I think he's not here.
Okay, the next.
Wait.
Okay. Doctor. Okay. I would like to invite Dr. Rupak Chatterjee.
Hello.
Okay.
Dr. Rupak Chatterjee.
From the National Medical College, Kolkata. Diagnostic in Transition, Clinical Role of AI.
Banik
in
sir, you are the
diseases
next
and
speaker, next to him.
Diagnosis. Role of AI in diseases and diagnosis. Dr. Rupak Chatterjee.
So, very good morning, respected chairpersons, faculties, delegates, and everyone present here. Myself, Dr. Rupak Chatterjee, and I'll be discussing on, briefly highlighting on artificial intelligence, its role in disease and diagnosis. So, as we all know, our healthcare industry is at the cusp of a technological revolution driven by artificial intelligence and other technological advances. So, it is very important for all physicians to have knowledge regarding this artificial intelligence and actually we can't avoid knowing this artificial intelligence because the pace at which healthcare industry is moving with artificial intelligence, if we are not conversant enough with this, then we might lag behind. So an important disclaimer, artificial intelligence was not used for preparing this PowerPoint presentation. So as we all know, traditionally the diagnostic process begins with history taking, clinical examination, gathering data, and constructing an intuitive assessment of the patient's condition. So these are the basic steps by which we diagnose a disease. So initial judgment is progressively refined through an iterative process of information gathering, which includes history taking from the patient, information integration, and followed by its interpretation. This refinement process involving hypothesis generation, fine-tuning, and validation usually culminates with a diagnostic decision that attributes a classification level to inform treatment. So this is the process that we first take the history, examine the patient, and then go to the diagnosis. But artificial intelligence changes this flow or pattern of diagnosis to some extent. But what? Artificial intelligence, but initially they gives us a working diagnosis, followed by you have to verify the AI's output to the case, followed by confirming on the basis of the discretion of the physician, followed by validation of diagnosis and treatment decision. So the very step-by-step diagnostic algorithm is changed by AI. So a few basic concepts of characteristics of artificial intelligence. It includes intelligent operation, pattern recognition, and dynamic and autonomic learning. So before this, we have to know some subfields of AI. One important subfield is machine learning. What is this? It uses basically study of algorithms, allowing computer programs for automatic improvement through experience. It includes supervised learning using labeled data, unsupervised learning by extracting information from unlabeled data, and also reinforcement learning by trial and error to maximize rewards. Another is deep learning. What is deep learning? It is basically a subset of machine learning which uses multi-layered neuronal networks to process large amounts of data. It is particularly effective in areas such as image and speech recognition, where it can identify complex patterns and make accurate predictions. Another is the natural language processing. This enables the AI system to understand and interact with the human language. In healthcare, this natural language processing helps to analyze clinical notes, extract relevant information from medical records, and support patient communication through chatbots and virtual assistants. Now, one important contribution of AI is in the field of drug discovery development. As we all know, the traditional drug discovery methods is a time-consuming process taking long decades, and billions of dollars are invested to bring a new molecule to the market. Now, what is the role of AI here? Now, AI accelerates this process by analyzing vast data sets already available to identify potential drug candidate and predict their interaction with high accuracy. So these machine learning algorithms, for instance, they can shift through millions of chemical compounds to find a promising candidate for future drug development. So the preliminary phase of drug development can be fastened and rather avoided with this use of AI. Now, deep learning techniques can also predict how these compounds will behave in the human body, leading to a significant reduction in time and cost associated with drug development. Now, precision medicine, this is an important topic. Now, what is precision medicine? It means tailoring medical treatment to individual characteristics of the patient. Now, this takes into consideration factors like genetics, environment, lifestyle, and thus offer a personalized treatment plan. AI algorithms, they analyze patient data to identify patterns and predict how the patient will respond to the different treatment modalities. Now, this predictive capability helps healthcare providers choose the most effective treatment for the patient, minimizing adverse drug reactions. Now, this precision medicine is particularly valuable in the field of oncology, where identifying genetic mutations can guide the choice of treatment and improve patient outcomes. Another important part of AI in patient management is improving medication adherence, reducing medication errors, and providing a real-time monitoring. AI-driven systems are available and already in the market, which can analyze drug interaction databases to identify potential interaction and adverse effects when multiple medications are taken together. Supporter caregiver well-being, this is also very important. By judicious use of artificial intelligence can alleviate the administrative burden on healthcare providers, improving their work environment and job satisfaction. Because tasks like data entry, appointment scheduling, billing, all this can be done by well-trained AI systems. And thus the healthcare system providers who are engaged with this task, they can be engaged in other works, and thus they can focus directly on the patient care rather than this task like data entry or like that. Now, public health and preventive intervention, AI has also a role in that. By analyzing the huge data records, the epidemic data, and epidemiological data of the trends of past records, they can also predict and help predict diseases outbreak, track health trends, and aid in public health decision making. So they can help in assisting authorities in effectively addressing potential health emergencies. So for example, there is a influenza or viral influenza outbreak, so they can analyze the data and they can predict that when then pandemic or epidemic can occur. So the health authorities can be aware and be warned ahead of time, and they can plan the health programs accordingly. Telemedicine and remote care, healthcare, this is an also important field where AI can be used. So summarizing AI in medical diagnosis, image analysis. Now, artificial intelligence can analyze medical images like X-ray, MRI, CT scan, retinal scans, often detecting patterns which are too subtle for the human eye to detect. Predictive analysis, by processing large data set, can then predict disease risk, as I've already mentioned. They can predict patient deterioration, treatment outcomes, and also personalized treatment, as I've already mentioned. Laboratory and pathological support, like analyzing pathology slides, blood samples, genomic data, to detect abnormality in cells, identify pathogens, and classify cancer types, AI has an important role. Now, clinical decision support, AI-powered software provides recommendation by comparing patient symptoms with large medical databases, suggesting the possible differential diagnosis, flagging important drug interactions, and this system acts as assistant. This is very important. AI-driven system, it should be noted that they should assist physicians and not be considered as replacement for clinical medicine for clinicians. So to summarize, the benefits of AI in health and diagnosis is faster and more accurate diagnosis, reduced workload for clinicians, improved disease early detection, personalized medicine, and enhanced access in underserved areas like the remote healthcare areas. But of course, there are some challenges and limitations. There can be bias in the training data, need for large and high quality medical data set is needed for AI to generate the diagnosis and the differential diagnosis. Lack of transparency in some AI models, which is referred to as a black box problem. Of course, there are some regulatory and ethical concerns, and integration with existing healthcare systems is of course a challenge. So this is a paper which we have published, a review article which had discussed in details about the AI in healthcare, the current trends and recent directions. So a very important and pertinent question, can artificial intelligence replace clinicians and clinical medicine? So what is your opinion? So in my opinion, no, it can help, assist, but not replace. Myself being from an infectious disease background, there are certain clinical signs which cannot be told by AI. For example, in a dengue patient presenting to the outdoor, presenting with a classical blanching rash or the classical Isles of White in sea of red, we can clinically diagnose dengue. And even before a blood diagnosis like dengue-1 antigen or IgM, we can diagnose and tell the patient with more than 55% sensitivity and specificity that the patient has dengue. Also the tourniquet test, a simple bedside test for dengue, it can predict the chance of development of dengue hemorrhagic fever. So also AI cannot replace these things. Also the diagnosis of a simple S-char, which points to the diagnosis of scrap typhus in an endemic area. So AI cannot replace this. So AI is always to assist in medical diagnosis to improve accuracy, but not to replace. So as some leaders say, artificial intelligence cannot replace physicians, but physicians using artificial intelligence can replace those who will not use AI. So thank you.
Excellent presentation,
Thank you, sir.
Dr. Rupak. And you have nicely summarized that the artificial intelligence may be as an add to the physician, not replace the
Yes, sir.
physician. One or two questions may be asked to the Rupak, if anyone.
Yes, sir. Yes, sir.
I want to know the medical legal aspect. Hello, medical legal aspect. During treatment, we took the help of the AI. So in the court of law, is it acceptable?
Yes, sir, that I have mentioned in my slide, that which I have mentioned, that there is a regulatory and ethical concern. But if the patient improves with AI, no one will see you, the doctor. But if there is a wrong diagnosis, then so there is an important regulatory and ethical concern which is there. And this AI, incorporation of AI in the clinical decision-making system is yet to be there, and rules and regulations are yet to be validated.
Rupak, wonderful presentation.
Thank you, sir.
As a teacher, a very important concern, the application of AI, or maybe even taking a step forward, ChatGPT, do you think it's a serious compromise on medical training?
Yes, sir, exactly.
Is there any regulation regarding this?
So I am not very sure about the regulatory bodies, sir, but this is a compromise because the basic skill which an intern should learn from the very beginning of his medical training, that is compromised with AI because our skills, the cognitive domain, everything is getting compromised with the use of AI. Our thinking capability, everything.
Don't you think it's a huge disaster?
Yes, sir. That's why in the beginning I mentioned the disclaimer, AI was not used for preparing the presentation.
Because people are writing leave applications on
yes,
ChatGPT.
Exactly. Even, sir, the discharge summaries we can see some juniors are writing. So this compromises, of course, sir.
Thank you, Rupak, for excellent
Thank you
deliberation.
so much, Dr. Rupak sir, for the excellent presentation. So now we have the next speaker.
Now I invite the next speaker, Dr. Samarjit Banik. Dr. Banik, are you prepared? Yes. And he will talk on the hands importance under-evaluated in clinical medicine. Over to Dr. Samarjit Banik.
So, good morning to respected chairpersons and my seniors and friends and postgraduates. My presentation is Journey Through Hand regarding clinical medicine, and let us start with this case. A 32-year-old female known to be E beta thal, having recurrent blood transfusion, and she had a history of 27 blood transfusions over last 1 year, presented to us with respiratory distress and was admitted in ICU for heart failure. Then the patient came to ward, and during routine round, we have discovered this. If we see the next picture, it will be more evident that patient having a discoloration of hand and also blackish hyperpigmentation, and patient was later on diagnosed to have hemochromatosis, secondary hemochromatosis with type 2 diabetes with CLD, and unfortunately she is found to have ANA positive and also having autoimmune hemolytic anemia. So this type of presentation is not uncommon, particularly in the setting of this region, northeast region of our country, where E beta thal and thalassemia is more common, and patients are coming regularly for recurrent blood transfusions. Now coming to this patient having a CLD, can any postgraduate volunteer this diagnosis? CLD with grade 3 or almost grade 4 clubbing. CLD with grade 4 clubbing almost. Can anyone? I can give a clue that patient is tolerating hypoxemia of around 75%. Patient is always hypoxemic, 75% saturation, and running and doing every household work with this saturation. This is a typical finding in hepatopulmonary syndrome. Now this prayer sign, yes, this is, we have to see in type 2 diabetes for diabetic neuroarthropathy. And this is table tap test, which the postgraduate should know in the bedside clinics in OPD. But it is not very much disabling. Now Dupuytren's contracture, we all know that it is more common in diabetes, almost nowadays we used to see exclusively in diabetes rather, can be found in other conditions. It has 3 grades, and almost 50% of diabetic patients might have at any one point of time this problem. Now regarding gouty arthritis, yes, we should know, postgraduates should know that gouty arthritis is mostly oligo or monoarticular, but in 10% cases it can be polyarticular, 10% cases it is found more in upper limb, and 10% it is bilateral. So hyperuricemia and gouty arthritis follows this 10% rule, which postgraduates should know. And this is this sort of finding. At a glance, this might mimic dermatomyositis, but this is not dermatomyositis. This is cutaneous amyloidosis. However, amyloidosis can happen in dermatomyositis also, but these findings are typical of cutaneous amyloidosis. Now coming to this case, 65-year-old male tea garden worker presented to NBMC OPD with memory loss, fatigue, palpitation, jaundice, who was a vegetarian, non-alcoholic, and there was no history of any blood loss or any recent fever or transfusion. Patient having these sorts of tongue pigmentation, and this is the hyperpigmentation as you see in that case. And this is due to vitamin B12 deficiency, where hyperpigmentations of knuckles and hyperpigmentation of oral mucosa is a very common finding, and this is not also uncommon in these tea garden belts because of the malnutrition, worm infestation, and also many other confounding factors. So again this patient presented with digital gangrene, and we have to look for the digital gangrene in lower limb also if this is there. And this is typical finding. Digital ulceration are common in your rheumatological conditions. Now left-sided picture, can anybody volunteer, any postgraduate? Left-sided is hyperparathyroidism, primary hyperparathyroidism, where there is osteolysis, shortening of digits. And right side is acromegaly, acromegalic hand, thick hands, thick fingers, white fingers. These are acromegalic hands. Now coming to dermatomyositis, we all know the clinical manifestations and skin manifestations of dermatomyositis, and we have to know the particular signs, and we should remember the recent diagnostic criteria. I am not going to read out to bore you in this morning, but we should know all these signs, and we have to be very vigilant regarding the prognosis and the treatment outcome of the patient. And these are the lung findings, and these are the classic cutaneous manifestations. These are characteristics are heliotrope rash, mechanic sand, and all other things. This is a picture of your any postgraduate? Systemic sclerosis. So these are all systemic sclerosis. This is acral DLE. Acral DLE is not so common, but it can be seen in males also, and it is highly prevalent in those SLE patients who are smokers. We should remember who are smokers. This is ACLE. ACLE lesion present as depigmented patches simulating acral vitiligo, and this patient occasionally misdiagnosed as vitiligo by our many colleagues. And this is Rowell syndrome with erythema multiforme lesion with acute cutaneous lupus erythematosus, and there might be annular erythema mimicking Rowell syndrome. So we have to remember that SLE has 3 types of dermatological manifestations: acute, subacute, and chronic. And postgraduates should remember that dermatological manifestations of SLE is a long question in their theory paper. This is again gout. Now, we should know this digital dactylitis found in many rheumatological conditions, planosynovitis, bony destruction, and deformity and functional loss. And as the ophthalmoscopy is concerned, nail fold capillaroscopy should be known to postgraduate medicine trainees, because this gives many clues regarding the involvement of nail and regarding the diagnosis. And this is available in all rheumatology textbooks. We should know the dilated capillary, microhemorrhages, tortuous capillaries, and even a good quality magnifying glass also can diagnose many things if you don't have the capillaroscope in your department. And there are some indications like SLE, dermatomyositis, Sjogren's, undifferentiated systemic sclerosis. We should try it. Even in every patient presenting with Raynaud's, we should start trying this nail fold capillaroscopy. This is a present nail changes in psoriatic arthritis concurrent with psoriatic skin lesions, and we know that psoriasis can have many skin disease. Now this is diagnosis. This is just simply a farmer who is busy with his work in every day and for many years. This is a typical farmer's hand. And coming to the neurology, we should know how to examine for pronator drift. We should know Hoffman reflex, Wattenberg sign. These are important signs in neurology, and these are frequently asked in the final examination. And neurology long case is mandatory nowadays for the postgraduates. Now coming to the tremor, we should know differentiating the important tremor: Parkinson's tremor, essential tremor, rubral tremor, and cerebellar disease. You see that this tremor on the left side and this tremor on the right side, it is clearly so differentiating the, this is your Parkinson's. Dystonia, involuntary sustained or spasmodic muscle contraction, occasionally seen in the neurology wards, and usually it is usually slow. The patient will, if you catch the hand of the patient, you will feel that the patient having a slow, sustained, repetitive patterned this movement. And writer's cramp, yes, it is not also very uncommon. Abnormal posturing and movement of the hand or forearm during tasks requiring skilled hand use. Wrist drop can be due to human lesion. It should not be, we should not think that it is only for element lesion. And alien hand syndrome is a phenomenon in which one hand is not under control of the mind, the person control of the hand, and it acts as if mind is not of own. It occurs in interhemispheric motor disconnection due to lesion in the mid-body of corpus callosum. So we should look beyond the nerve. If we look beyond the nerve, there are some many dermatological manifestations of hand. In leprosy, there might be arsenic toxicity or what I have shown earlier, subacute combined degeneration. This is lead poisoning, and you see the bluish discoloration of the nails. This is due to your silver poisoning. Silver, actually, he works in a jewelry shop and makes silver ornaments, and this is his nail pattern. And so take-home pointers: examination of hand are essential for better diagnosis, and we should have a nail capillaroscopy in our, as well as ophthalmoscope in the hand of the PGT, in the PGT's pocket, to diagnose the nail changes in rheumatology, which are not uncommon. If we see, we can discover. So every postgraduate should know how to do nail capillaroscopy, and what there are not many findings, there are limited number of findings which a postgraduate should know. Thank you for your patient hearing.
Thank you, sir. It was indeed a beautiful presentation, extremely important from clinical medicine point of view, and especially helpful for the interns and the general medicine residents. We have around a minute. If there are any more questions from the audience, otherwise we can conclude this session. Only one question,
Hello,
sir.
Hello, sir. Thank you for a beautiful presentation. Sir, you have told in type 2 diabetes, around 50% of patients have repeat on contracture in their lifetime. So, repeat on contracture is common in type 2 diabetes, but not to extent. Most of the studies have showed that it is around 15 to 20%, and some studies showed around 30%.
No, what is found in literature that in uncontrolled diabetes, uncontrolled type 2 diabetes, it can go up to extent of 42%. In uncontrolled diabetes, not for all. Thank you, sir.
So we close the session. Now session is being concluded. Thank you.
Thank you very much. We extend our heartfelt gratitude all the esteemed faculty speakers of this session for their insightful and enriching presentation. We also sincerely thank our Honorable Chairperson for their valuable time, guidance, and for conducting this session with such grace and academic rigor. We request the faculty speakers and the Honorable Chairperson to receive their memento from the registration desk. We shall now proceed to the next important session of the day, titled Endocrine Immune Interface Session.
For the further session, we will request to pay attention to time limit of 10 plus 2 minutes. I respectfully call upon the Honorable Chairperson for this orientation, Dr. Vandana Kumari, Ma'am, Associate Professor, Department of General Medicine, Mata Gujri Memorial Medical College. Dr. Sudipta Shah, Associate Professor, Department of General Medicine, Raiganj Medical College, West Bengal. Dr. Pranav Dev, Assistant Professor, Department of General Medicine, Mata Gujri Memorial Medical College. Dr. Arun Kumar Bandopadhyay, HOD and Professor, Department of Ophthalmology, Mata Gujri Memorial Medical College. Dr. Nandita Chattopadhyay, HOD and Professor of Department of Pediatrics, Mata Gujri Memorial Medical College. Kindly come upon the desk and take the proceeding forward.
Good morning, respected doctors. So, in now, I will like to request Dr. Mary De Cruz. She is a senior consultant physician at Kolkata. She will be discussing in brief about euglycemic ketoacidosis in CRM disorders. Madam, please.
Next session. Next year পরেটা 11:15 session. No. Maybe 3.
এটাই তো
Yeah, fourth one.
এটা
Good morning, chairpersons, and thank you to Dr. Partho Karmakar for his kind invitation. I'll be speaking on, can I make it full slideshow from beginning? So you will be wondering what this is. This is actually a prescription in Chinese. My niece was in China, and I got a call from her that I'm very sick in the hospital and I don't know what they are doing. So I didn't even know at that time she was a diabetic, not being in touch for so long out of the blue. So I asked her, just send me your prescriptions and what are they doing? And so she sent me all these. And finally, I couldn't understand what all that was, some tests. I said, okay, now you send me your prescription or treatment, what is going on, the first page. So this is what she sent. And as we use AI, I contacted in one group that if anybody knows Chinese and this area, this hospital, can you get back to me? Luckily, one of the doctors whom I met in a conference had studied in China. And so she sent me a detail of a doctor to whom I could speak to. And of course, I also used AI as I put this in through Meta AI, and I got a translation of this document on the left. So it said acute kidney injury, UTI, consultation for pregnancy, which was not there. Okay? Infection, renal insufficiency, high blood lipids, and the surgical procedure or treatment for severe pyelonephritis. Then they made a discharge diagnosis: acute pyelonephritis, acute kidney injury, high blood lipids, electrolyte disorder, and abnormal liver functions. So this is how you function in another country. It was terribly alarming because she was put on a sensor and a pump, and the sensor was continuously showing high sugars, and yet she was experiencing low sugars. So she was totally confused. Luckily, I was able to speak to the doctor, and then this was the HbA1c showing when she was on the sensor. So today's topic is euglycemic ketoacidosis. It is real and it does occur. So it is a rare but serious complication of diabetes where a person has ketoacidosis, but the hallmark of ketoacidosis, which is hyperglycemia, is not there. It is characterized by metabolic ketoacidosis, ketonemia, normal or near normal blood glucose levels, usually below less than 250. And it can occur in both type 1 and type 2 diabetes. It is a rare condition, and its true incidence is likely underestimated because of the diagnostic challenges. It is estimated to account for about 2.6 to 3.2% of all admissions for diabetic ketoacidosis. And the frequency has been notably increased because of the use of SGLT2 inhibitors. Among those patients, the incidence of ketoacidosis is about 0.1 to 0.8. While the absolute risk is low, it's significant contribution to the millions of patients taking this drug. Incidentally, my niece was put on a dapagliflozin, which of course eventually was stopped. So the features of a classic DKA and a euglycemic DKA, the blood glucose in classic is higher than 250. In euglycemic ketosis, the blood sugars are normal or near normal, but definitely below 250. Insulin levels in classic DKA are markedly low, but in euglycemic ketoacidosis, they are low but not absent. Diagnosis is often straightforward in DKA with high sugar levels and ketosis, but in euglycemic ketoacidosis, it can be easily missed. Common triggers for DKA are infection and missed insulin doses, while in euglycemic DKA, it is SGLT2 inhibitors, fasting, and a surgery. So the challenges are the absence of a high blood glucose, which can lead to diagnosis. Symptoms are non-specific, nausea, vomiting, abdominal pain, leading to a misdiagnosis of gastroenteritis, pancreatitis, or an upper glomerulonephritis too. It's crucial for healthcare providers to consider euglycemic decay in any patient who presents with any of the above symptoms, regardless of their blood glucose levels. It is essentially a state of carb starvation, and though the blood glucose levels are normal, the cells cannot use the glucose for energy due to a relative insulin deficiency, and the body switches fat for fuel, producing ketones as a byproduct, and this buildup leads to the metabolic acidosis. The pathophysiology here is that there is an insulin deficiency. The counter-regulatory hormones come into play with resultant lipolysis, glycogenolysis, gluconeogenesis, and proteolysis, resulting in glucose production and a hyperglycemia not exceeding 250 mg%, ketogenesis resulting in ketoacidosis, and because of the presence of SGLT2 inhibitors in most of the as seen on the right, there is an inhibited renal reabsorption leading to glucosuria and a negative fluid balance. So the primary driver is an imbalance between insulin and the counter-regulatory hormones that I mentioned, mainly glucagon. Low insulin levels prevents glucose from entering the cells, and a high glucagon promotes breakdown of fat and production of ketones. This creates a perfect storm for ketoacidosis, even though there are normal blood sugars. What are the triggers? The triggers, and we need to keep in mind, are the SGLT2 inhibitors, a fasting or a very low carb diet. You know, patients today are on high protein diets, neglecting the carb content of their diet. So we need to look into what dietary fad they are following. If there's a surgery, if there is an infection during pregnancy, alcohol abuse, and reduced insulin doses. So these are the triggers. Sodium glucose transporter inhibitors that lower the blood glucose by allowing the kidneys to remove sugar from the body through the urine, and common used in India are canagliflozin, dapagliflozin, and empagliflozin, and the use has been associated with an increased risk of euglycemic diabetic ketoacidosis. How they promote the increased glucose excretion, it causes the body to lose glucose through the urine, also making them susceptible to lower urinary tract infections, increased glucagon secretions, mainly resulting in ketogenesis, and there is volume depletion due to loss of glucose and water in the urine, and this can lead to dehydration, which also triggers euglycemic diabetic ketoacidosis. So if we know that during the history, if we ask them for intake of SGLT2 inhibitors, we could probably reach the diagnosis earlier. The other precipitating factors are pregnancy. It can lead to insulin resistance and increased ketoacidosis, surgery and acute illness. Fasting and low-carb diets can deplete the body's sources of glycogen stores, leading to state of starvation. So the signs and symptoms are similar to those of classic DKA, but without polyuria and polydipsia. So you may have nausea and vomiting, you have abdominal pain, you have shortness of breath, fruity scented breath, fatigue and weakness, and confusion. These are all very vague complaints, and so we need to be alert to this diagnosis. The diagnosis is based on the following lab. There is blood glucose less than 250, arterial pH of less than 7.3, a serum bicarb of less than 18, a positive urine or serum ketones, and an elevated anion gap. So treatment essentially is fluid resuscitation or intravenous IV fluids to correct the dehydration, insulin to stop the ketone production and allow the body to use the glucose, Dextrose administration may be required to prevent hypoglycemia, and electrolyte replacement, especially potassium, may be needed and needs to be monitored. So we need to educate our patients, especially those taking SGLT2 inhibitors, to stop the medication in case a surgery is planned or before a planned period of fasting, as exists in many religious periods of Ramzan and during other fasts. Maintain an adequate hydration, recognize the signs and symptoms of UDKA and seek medical attention immediately. Avoid very low carb diets. We know diets are now being focused on because of not only SGLT2 inhibitors, but also GLP-1s that are now being taken for weight loss. We need to monitor the diets. So to conclude, euglycemic ketoacidosis is serious, potentially life-threatening complication of diabetes, but if alert and detected early, it is good. It is characterized by ketoacidosis without significant hyperglycemia. The use of SGLT2 inhibitors is associated with increased risk of UDKA, and it is not that any one particular SGLT2 inhibitors, all are a class effect, high index of suspicion, and prompt treatment with fluids, insulin, and dextrose is essential. Thank you so much.
So any question from the audience?
Thank you, madam, for beautiful presentation. I want to share one thing. If we combine AGL2 inhibitor with GLP-1 receptor agonist or DP4 inhibitor, the risk of euglycemic decay is slightly reduced because AGL2 inhibitor increases glucagon, whereas GLP-1 receptor agonist suppress glucagon. So there is balance. So combination of AGL2 inhibitor and DP4 inhibitor to some extent reduce the risk of euglycemic decay.
Thank you, madam, for the nice presentation. Now I will like to invite the next speaker, Professor Partho Chattopadhyay, sir. He is a senior physician and presently Professor, Department of General Medicine at Mednipur Medical College. Sir is an excellent clinician and speaker and is practicing rheumatology for a long time, and we will be listening from him seronegative RA, how to differs from seropositive one. Sir, thank you.
Thank you, Chairperson sir, for your nice introduction. For the next few minutes, I'll be talking on seronegative rheumatoid arthritis. And I'll be going through this, what is SNRA, epidemiology, pathogenesis, whether there is any diagnostic difficulty with SNRA and SPRA, severity of disease, differential response to therapy from SPRA, and take-home message. Now, RA, as we all know, is an autoimmune chronic symmetric inflammatory polyarthritis of diarthrial joints. There is systemic inflammation, often complication of other organs like lung fibrosis, scleritis, and lymphoproliferative disease. There is significant cardiovascular risk in the form of atherosclerosis, strokes, and myocardial infarction. But the problem is that up to 50% of RA patients has bone loss of osteoporosis, and majority of these occurs within the first few months of diagnosis. So the best patient outcomes he got if the treatment is started within the first 12 weeks of presentation. With goal-directed medical therapy and treat to target, we only can achieve 20% complete remission, and 40% do not respond in spite of advent of biological demands and targeted synthetic demands. Now, RA can be divided into few subtypes according to seropositivity, like SPRA and SNRA, that is seropositive and seronegative rheumatoid arthritis, or according to timeline, like preclinical RA, early RA, rheumatoid arthritis proper, and late onset rheumatoid arthritis. This is particularly important because this has some similarity with SNRA. The age of onset is more than 60 years of onset, acute onset of symptoms, but the male-female ratio is 1:1, with frequent involvement of large proximal joints, especially shoulders and knees. There is also prominent Barson involvement, which may resemble polymyalgia rheumatica or RSCP, ACP, and more of these LODA patients are seronegative, and there is osteoarthritis and osteoporosis more common. Difficult to treat RA is defined by more than 2 biological DMARDs or TS DMARDs failure after treatment of CS DMARDs per guideline. There is early age of onset, female gender, seropositivity, and delayed treatment initiations are risk factors. Fibromyalgia, fatigue are common, and they can be divided into PIRA and NIRA. Now, according to ACR EULAR 2010, we need at least 6 score with the negative serology for both RF and ACPA. And if the RF and ACPA, you can see from the chart, the RF and ACPA, there is 3 score can be assigned to them. With the loss of this, the SNRA has to have more joint involvement at diagnosis to have a diagnosis of RA. So ACPA and RF are key crucial mediators for inflammatory response. Both ACPA and RF are crucial indicators of joint prognosis, treatment outcomes, and risk of extra-articular complications. Now, the CD4 plus T cells, they are critical role in RA pathogenesis with increased production of inflammatory cytokines, chronic inflammation, and bone destruction. Th17 cells, that is a subtype of CD4 type cells, increases secretion of TNF-alpha interleukin 70s, which cause arthritis and bone degradation. And Th17.1 cells, these are resistant to regulation by Tregs therapies involving CTLA4 is incomplete in them. Interleukin 21 producing peripheral T cells are crucial in recognizing citrullinated peptides in SPRA, and IL-21 is relatively less in SNRA. Is the SNRA prevalence is rising? According to ACR EULAR 2021 criteria, the criteria is less sensitive for diagnosis of SNRA vis-a-vis SPRA. In all literature, we can find the prevalence of SNRA as being 20 to 30%. SNRA is rising because of increased age, dysregulation of inflammation, defective innate immunity causing mostly seronegative forms, decreased smoking, causing decreased citrullation and decreased formation of ACPA. There is changes in the gut microbiome, increased occupational exposure to crystalline free silica, which can produce SNRA. Because SNRA has negative for rheumatoid factor and ACPA, which are both drivers of bone destruction, SNRA is a milder disease. There are contrary reports according to that. SNRA has got increased inflammatory activity at diagnosis than SPRA, so there is delay in diagnosis, so the window of opportunity is lost before the bone is having osteoporosis or osteonecrosis. Radiographic progression of SNRA and SPRA is pari passu, and the treatment response is somewhat decreased in SNRA. Radiographic damage has been reported in 20 to 40% of SNRA. So SNRA is not a mild form of the disease and requires intensive treatment similar to that of SPRA, but there is no guideline to treat the SNRA in a different form. The clinical characteristic, female to male ratio is 3:1, older age of onset 60 years. This is less common in smokers. The erosion subscore in SNRA is increased in carpal, PIP, and distal ulna, less common in metacarpophalangeal joints. Joints of the feet are virtually spared. There is increased involvement of the large and carpal joint in SNRA than in SPRA. There is decreased synovitis and more tenosynovitis, which is a hallmark of SNRA. And very important diagnostic point is inflammation of the extensor carpi ulnaris and finger flexor, particularly the third finger, which is considered the hallmark of SNRA. Presence of erosion and modified weight score at diagnosis significantly affect the radiographic progression of SNRA. Now, coming to the diagnostic difference between SNRA and SPRA, modified sharp score, MCP2 damage, MCP3 damage, and MCP5 damage is low in case of SNRA, but high in case of SPRA. Synovitis is rare in SNRA, but more in SPRA. Tenosynovitis and extrasynovial involvement is more frequent in SNRA than SPRA. Regarding pathogenesis, there is a whole lot of genetic and other informative marker. HLA-B08 and DRB01 is high in SNRA, whether DRB104 and 10 is high in SPRA. Regarding short nucleotide polymorphism, there is difference. there is also difference in microRNA sequences. This is a landmark study in 2025 July. There is comprehensive and advanced T-cell cluster analysis. They showed that T peripheral and Tregs ratio was markedly higher in SPRA, underscoring an effector-dominant immune imbalance. And TCL21, an activated Th1 type T peripheral cell, was strongly associated with SPRA aggressive profile. Regarding this, there is validated differential T-cell cluster. These have discriminative power, achieving an accuracy of 86% with a sensitivity of 85% and specificity of 80%. Regarding the biopsy of synovial cells, the synovial lining CD68 positivity, synovial C84 T cells, synovial C831 T cells, these are all very frequent in SPRA and not very frequent in SNRA. Synovial monocytes and macrophages and plasma cells are frequent in SNRA, and PD1 plus T cells are frequent in SPRA. Now, there are much more antibody profile other than the rheumatoid factor and anti-citrullinated peptide peptides, that is anti-carbamylated protein antibodies, anti-peptidyl arginine D-4 and anti-SA antibodies, which can reach up to 90% specificity in case of SNRA. So, if you analyze SNRA patients who are negative for rheumatoid factor anti-citrullinated polypeptide, up to 20 to 25% patients can be positive with these antibodies. And there is a 2021 seminal paper. They have identified a high degree of specificity with a homology with other autoantigens recognized by autoantibodies present in seronegative RA patients. These newly identified autoantibodies, although present also a percentage of SPRA patients, may be considered as novel serum biomarkers of SNRA, which lacks the presence of RA and or ACPAs. This is another landmark paper in Frontiers by Bauchen Lee et al. The important points are the IL-4 level, which is a key immunological discrepancy between SNRA and SPRA. The IL-4 gene polymorphism correlated with disease severity and as well as ACPA. Th17 Treg imbalance with vital immunological distinction between SNRA and SPRA. SPRA exhibits higher inflammatory cytokine levels than SNRA and PSA. The lymphocyte subset ratio and cytokine overall distribution in SNRA closely resembles that of psoriatic arthritis. Immune cell subpopulation between SPRA and SNRA, again, total B cell, T cell, CD4 plus cell is more common in SPRA, with Th1 cell is high and Treg cell is definitely low in SPRA, which is opposite in SNRA. So the Th17 by Treg ratio is altered in SPRA rather than in SNRA. Inflammatory markers, there is a whole gamut which are more commonly associated with ACPA and is more frequently associated with SPRA. Response to therapy is again, there is a differential response, that is methotrexate has got limited response in SNRA, TNF good response, second TNF inhibitor good response, but anti-CD20 biologics and anti-CD80 biologics are limited role in SNRA. JAK inhibitors, the jury is still out. This again slide regarding comorbidities. There is a set of comorbidities which is more common in SNRA than SPRA. Cardiovascular risk is lesser. Anti-IL-23, IL-17 axis modifier biological has got no effect in either of them. Methotrexate plus TNF inhibitor has got less inhibition of SNRA. Anti-IL-6 drugs not very effective but effective in SNRA. Immune checkpoint inhibitors and asthma asthma biologicals can more commonly present with SNRA than SPRA. And SNRA shares many things with psoriatic arthritis. In a study with a 23-year follow-up, 60% patients initially classified as SNRA turned out to have SPRA over time. So to summarize, the SNRA and SPRA has got a whole gamut of other differences regarding biologics. Innate immunity is more commonly involving the SNRA and adaptive immunity more commonly involving the SPRA. The take-home message is SNRA is an inflammatory rheumatic condition, difficult to classify uniquely. There is distinctive genetic features with increased involvement of innate versus adaptive immunity, distinctive immunopathologic features with decreased synovial involvement and increased tendinitis. There is different prognosis and responses to therapy. Prospective and control studies needed to delineate an increasingly accurate picture of this form of RA. SNRA seems to share numerous pathogenetic and clinical features with SPA. Better differentiation is needed. Thank you for your patient hearing.
Thank you, sir, for the nice presentation. I will request the audience if they have any question to ask, sir, on this topic.
False RA positivity you can get up to 30 to 40% in Indian population. There is a study from SDPGI Lucknow. I can remember there is 30 to 40% RA in healthy population. Yes. Yes. No, accordingly, if you have alpha positivity, but patient is asymptomatic, the risk of developing RA over the next 10 years is almost 80%. But similar cannot be said about RA. The patient is asymptomatic RA positivity, you should look for other things. If the patient has got inflammation of synovitis, then you can investigate for other things. It is actually in 2010 ACR criteria, it is quantitative because more than 3 times elevation, it has got number 3, marker of 3. And low titer elevation is 1. Prognostic significant therapy is again associated with titer. The titer may come down with prognostic, but it is not recommended for follow-up. Yes.
Sir, I have a question. Sir, clinically, because you have shown many antibodies, clinically how to suspect seronegative RA only just by the joint involvement or anything else?
Yes, very important question. As I have shown in my slide, the metacarpophalangeal joints are much more commonly involved in SPRA, and these are relatively less commonly involved in SNRA. SNRA has got carpal, distal ulnar, involvement and more large joint involvements in the hand. Feet are almost never involved, and there is involvement of tenosynovitis and other extra-articular manifestation rather than prominent synovitis. So these are few points which you can suspect that this is probably SNRA and not SPRA.
Okay. Thank you, sir.
Just one question, just one suggestion, rather question. In comorbidities, and here is another one thing, information that Dr. Partho Chatterjee and myself was working in the same hospital before I retired from the Sagodatta Medical College. And he's a very nice physician, very active also, dynamic. And just I want to highlight one thing, that like diabetes, now the rheumatoid arthritis and the associated other problems are involving the eye. Okay, and this is long term, but nowadays it has become very crucial that for all uveitis patients, we go for this testing, this joint pain and other things. So rheumatoid arthritis patients, whenever you examining, so I think it will be better if you send, just take a few questions that whether the patient has got any problem with vision or not, or otherwise red eye history, so that they can be referred to the eye clinic.
Absolutely, sir. Yeah. Because they also in 2021 guideline, they have also advocated hydroxychloroquine in low risk SPRA patients. So in that case, annual eye checkup is mandatory. But if hydroxychloroquine is not there, I think sir has rightly pointed out, annual checkup, ophthalmological checkup is mandatory in case of once the patient is diagnosed with SPR or SNRA. Thank you, sir.
Next speaker is Dr. B.K. Singh, Associate Professor, NMCH, Sasaram, Bihar. He will speak on epigenetics and diabetes.
Thank you, chairpersons. At the outset, I thank scientific chairman Dr. P.H. Karmakar and the whole organizing committee, especially Dr. U.K. Paul and all organizing committee for giving me opportunity. And Bihar chapter is one of the part of this ICP joint venture, and as an convener of ICP Bihar, I welcome all of you in this first ever Bihar and Bengal ICP-CON conference. My first slide. Slides. Session 3. This is session.
Session
3.
Second. Chalo.
How many of you knows epigenetics? Okay. So, the study of heritable and reversible changes in DNA expression without changes in the genetic code is epigenetics. All the information in your body is accumulated in as genetic code, and we cannot change the code of DNA as such, but we can change the DNA expression without changes in the genetic code. That is epigenetics in nutshell. And epigenetics mediated differential gene expression can explain the heterogeneous function of different cell types in the body despite them all carrying the same genetic information. Means you have a differential manifestation, differential DNA expression in different tissues. So these are the two important points. If you can see this hall and the lights, the electricity is coming in this particular wire of the electricity, wire the electricity is running. But unless otherwise you cannot switch on or switch off the switch, then the light cannot be go up. Means the switch is the epigenetics, and that switch can be off or on according to the situation. So what are the importance of epigenetics? Epigenetics play an important role in the transmission of diabetes from one generation to other. It can be heritable. Epigenetic changes are all implicated in the basic pathogenic mechanism of type 2 diabetes, and the hyperglycemia-induced permanent epigenetic modification of the expression of DNA are responsible for the phenomena of metabolic memory. And epigenetics influences the development of micro and macrovascular complications, and they can be used as a biomarker in the prediction of these complications. And epigenetics has expanded our understanding of the action of existing drugs, such as metformin and other development of a new therapeutic agents. So epigenetics is very important part in future medical treatment of diabetes. You all know the chromosome is how this chromosome is made up of the DNA and This DNA is a double helical structure, and one important point is the CPG island. The CPG is the part where the DNA methylation takes place. I will not go in the details. And this CPG parts get separated, and that they form the messenger RNA get attached, and this messenger are going to the cytoplasm where the translation takes place, leading to protein formation. The basic fundamental is that any information from the genetics comes to the cytoplasm, and there is a formation of the protein. And similarly, the insulin is also formed through this genetic informations. So the transcription and translation is the part of this genetic protein formations. So what are to classify the epigenetic changes? What are the epigenetic changes in the classification? There is a direct epigenetics and another is the indirect epigenetics. The direct, what the direct patient or the person receives from this by the exercises or other lifestyle modification that can that can create an epigenetic change that is known as the direct. And epidirect is an epigenetic change where the fetus gets intrauterine environment of the mother, and that will create an impact on this fetus is the indirect changes. And similarly, the sum of the epigenetic changes can be inherited from the ancestors. So to classify it, the direct and indirect, and this indirect is the intrauterine changes and the inherited from the ancestors. The mechanism of epigenetic transcription and translations, there are three parts which is very important is epigenetic mechanism. One is the methylation of the DNA, second is the histone modification, and third is the regulation of microRNA or non-coding, we may call it the non-coding RNAs. These non-coding RNA are very important, and transcription means there is a messenger RNA formations. This messenger RNA formation have the two parts. One is the methylation of DNA and histone modification. You all know that DNA is binded around the histone a protein around it, and if this histone protein is slightly changed or modification is there, then you can have this transcription process in that particular. So you can see in this, if the CPG particle or the DNA is methylated, the protein, the transcription activations in the gene leads to the protein formation. If it is demethylated, there is no protein formation. Similarly, the histone modification, acylation or deacylation may lead to transcription or non-transformation. Similarly, you can see this histone modification in this case. This DNA is binded around this histone molecules, and the histone the modification in this histone molecule by the phosphorylation or the acylation may change the process of this DNA and leads to the formation of a transcription. And similarly, the role of the microRNA during the transcription phase, where the this ribosome get attached with this messenger RNA, this small non-coding mRNA, microRNA can get attached, and they can halt this transcription process or epigenetic changes. So in type 1 diabetes, autoimmune destruction of beta cells involved, genetically epigenetic regulatory immune pathway, and DNA methylation can change the HLA region. You all know the HLA is take parts in the type 1 diabetes, and the T cell regulator genes like FOX, P3, and IL-2RA. Some environmental triggers, that is the viral triggers in the early life infection, can induce epidemic march in the and promote the immunity in type 1 diabetes. In type 2 diabetes, is strongly influenced by the metabolic environment and making epigenetic mechanisms central. The beta cells dysfunction, the methylation changes in the PPARG, C1A and PDX1 and INS, causing impaired insulin synthesis and secretions. And insulin resistance can be due to the adipogenesis like PPPAR gamma pathway, inflammatory genes, the TNF-alpha and IL-6, and the muscle glucose uptake, the glucose transporter 4 promoter methylations. And similarly, there is an effect of obesity, that is a chronic overnutrition leads to the global methylation changes in adipose tissue. There may be the altered microRNA like microRNA 375 and microRNA 29 families, and low-grade inflammation mediated through epigenetics activation of the macrophages can lead to the effect on the obesity. The epigenetics and pathogenesis of type 2 diabetes, you have already discussed that insulin resistance and the impaired insulin secretions is the cause of this type 2 diabetes mellitus. Epigenetic changes in the insulin resistance and insulin secretion to the diabetes formation. Entering program, it is a very important part is that the development of health and explains how fetal environment sets long metabolic response. In intra-eternity, the patient is fetal epigenetic changes may lead to the type 2 diabetes. The genes affected are IGF-2 and H2019 and clock genes are may be responsible. You can have this a beautiful example of thrifty phenotype hypothesis. When these children are postnatally, studies showing that the increased prevalence of diabetes in adulthood when there is a history of poor maternal nutrition or diabetes in the mother during gestation. Just take 1 or 2 minutes. The 30 phenotype hypothesis, when these children are postnatally exposed to abundance of nutrition, they are at risk of developing of type 2 diabetes mellitus, obesity, and metabolic syndrome. And Yagnik describes that Indian babies are born with low birth weight but are found to have a higher visceral fat than their English counterpart, are predisposed to the insulin resistant and type 2 diabetes mellitus in later lives. And transgenerational epidemics, the parental and maternal obesity, can modify sperm and ovum imaging and may lead to this type 2 diabetes mellitus. The epigenetic bio, very important, the potential clinical biomarker like DNA methylation signature in the blood, microRNA in the CM are 126 and 375, and methylation in parental state. And that may lead to the early diagnosis and prediction of complication and even the personalized risk stratifications. The epigenetics and complication of type 2 diabetes, the hyperglycemia induces metabolic memory, and you know that metabolic legacy have effect, long-term effect on the metabolic complications. And these are the complications like endothelial dysfunction, microvascular complication, macrovascular complication, and diabetic. Even after glycemic control improve, these epigenetic changes maintain inflammation and fibrosis. Already discussed metabolic endothelial dysfunction, macrovascular complication, microvascular and diabetic retinopathy is an important cause of blindness in non-proliferative retinopathy to proliferative retinopathy. And this microRNA 126 regulatory expression, the vascular endothelial growth factor 1. This all macro, and diabetic cardiomyopathy. So epigenetic therapy is the center stage but promising research-oriented is promising effect. SDANC inhibitor. You all know the inflammation is one of the cause of SDANC. So DNA methylation in place, microRNA-based therapy and nutritional like folate and vitamin B12 deficiency may influence methylations, and lifestyle modifications, so partial reversibility of diabetes-related epigenetic changes. And one drug which is coming up, the epabetalone, a new drug acts by blocking histone interaction with DNA. This action has been shown to prevent and rise the inflammatory protein, so may be blocked. So to conclude is that there is a substantial evidence to support the role of epigenetics in the pathogenesis and complication of type 2 diabetes. Epigenetic modification starts at the uterine environment and continue throughout the life of individual's life and heritable. Adverse environmental conditions such as food habits, sedentary lifestyle, circadian rhythm, and maternal malnutrition or maternal obesity interact with the individual gene, leading to various states of type 2 diabetes. Research is being conducted to develop epigenetic biomarker and newer drugs. Future diabetes care may induce epigenetic diagnostic and personalized therapy. Thank you very much for your patient hearing.
Thank you, sir, for the nice presentation. Any question from the audience?
No question at all. Whenever investigation, the detection of micro is still in the experimental stage. There is no such, but these two microRNA, this 126 is being very much in pipeline, and we may get this test in 2 to 3 years. Inflammation. Yes. The environmental factor had definite role in the epigenetics, and in this environment, even if you do exercise, yoga can influence your epigenetic changes and lead to the difficulty. Yes. If air pollution and lifestyle modification, this have been act on this epigenetic changes.
Just one question. So how to differentiate between this epigenetics induced diabetes and the
epigenetics induced diabetes? Epigenetics has role to have this diabetes.
Yes.
It is evolving. If you do exercise, what is happening in your, why there is a decreased incidence or prevalence of type 2 diabetes after exercise? The exercise induces some changes in the epigenetics level, and that decreases the inflammation. And that decreases inflammation leads to the decreases insulin resistance, may lead to the decrease in the prevalence of diabetes. That is one of the pathogenic mechanism. And by knowing the microRNA which is present in the cytoplasm or even the serum, if you detect that particular microRNA which is responsible for so you can control this inflammatory process or release or decrease the insulin secretion through this, either controlling this microRNA. MicroRNA get attached with the messenger RNA, and they influence the effect of messenger RNA by protein formations. So this microRNA can change your therapeutic level, therapeutic changes in this treatment of diabetes mellitus. And even not in diabetes, the microRNA is already involved in many of the even cancer and other treatment also.
Thank you.
Thank you.
Thank you, sir, for this wonderful session. We will now like to facilitate the Dr. Professor B.K. Singh, Associate Professor, NMCH Sasaram, and Convener, ICP Bihar Chapter. He could not make it yesterday due to unavoidable reasons. May I request Dr. Professor S. Karmarkar, sir, Dr. Professor Atul Vaid, sir, and Dr. Deep Mala, ma'am, to come and do the honors.
Actually, we missed Dr. B.K. Singh, one of the most respected professor. He couldn't make it yesterday in our inauguration program, but felicitation is one day late for that reason. Okay.
First of all, I really thanks Dr. P.S. Karmakar and Dr. Atul Vaid. So please give him a big round of applause to the organizing committee. अरे यार ये नहीं हुआ ये किशनगंज के लायक ताली नहीं है जोर से ताली बजाइए सर एक रामधारी सिंह दिनकर की कविता है to our two great leader and अतुल वैद्य and all यू के विश्वास है कौन विघ्न ऐसा जग में टिक सके आदमी के मग में है कौन विघ्न ऐसा जग में टिक सके आदमी के मग में थम खोल खेलता है जब नर पर्वत के जाते पाँव उखड़ मानव जब जोर लगाता है पत्थर पानी बन जाता है ताली बजाओ भाई
Thank you, sir, for your excellent words. Now I will request Dr. Umakanto Mahapatra, Professor, Midnapur Medical College. He is also a senior endocrinologist, and he will be giving a lecture on approach to goiter. Thank you, sir.
Thank you, Chairperson, sir, for introduction. Good morning, everybody. At first, I would convey my thanks to the organizer for giving me the opportunity to discuss approach to goiter. Goiter is an abnormal enlargement of thyroid gland larger than healthy individual residing in iodine sufficient areas. Clinically, thyroid gland is considered to be enlarged when lateral lobe of thyroid is larger than terminal phalanx of the thumb, the patient being examined. Radiologically, volume is greater than 30 ml on ultrasonography. Prevalence varies from 4.7% in USA to 28.3% in Africa, with a higher frequency in women and elderly, depending on iodine status, characteristic of the study participant, presence or absence of endocrine disruptors, and the methods of screening. Using USG as screening method, the prevalence varies from 30 to 50%, even with a higher prevalence around 68% on high resolution USG. Prevalence in India was 2.7% in women and 0.5% in men in 5th National Family Health Survey between 15 to 49 years. Iodine deficiency disorder is most common cause of goiter worldwide, affecting more than 200 million people. But in 2013, only 111 countries had sufficient iodine intake. Autoimmunity is most common in iodine sufficient areas. Genetic abnormalities in thyroid hormone synthesis, endocrine disruptors, and drugs may affect thyroid gland. Smoking increases the risk of goiter, but alcoholism and long-term statin use reduce the risk of goiter. In pregnancy, goiter is physiological, but it is pathological during puberty. So goiter in puberty should be properly evaluated. In approach to goiter, first is differentiation of goiter from the midline swelling. Then what are the characteristics of the goiter? Are there any feature of hypo or hyperthyroidism? Are there any symptoms of compression? Are there any signs of symptoms of malignancy? So targeted history should be taken regarding iodine status, medication history, and prior exposure to radiation. Look for scar, movement of the goiter during swallowing. Determine the goiter extent, size, consistency, and tenderness. Presence of bruise on thyroid gland suggests Graves' disease. Look for Pemberton sign, and positive Pemberton sign indicates retrosternal goiter. Is it diffusely enlarged or a solitary nodule? Diffuse enlargement with firm consistency and palpable pyramidal lobe suggests Hashimoto thyroiditis. Diffuse enlargement with soft consistency and feature of hyperthyroidism indicates Graves' disease. Multiple nodules with feature of hyperthyroidism in an elderly individual suggests toxic MNG. Is it enlarging rapidly? Hemorrhage, anaplastic thyroid cancer, lymphoma, and metastasis are the possibility. Any personal or family history of autoimmune disease suggests either Hashimoto thyroiditis or Graves' disease. Pain may be due to subacute thyroiditis, hemorrhage, Riddle's thyroiditis, anaplastic carcinoma. Regional adenopathy suggests either thyroid malignancy or lymphoma. Hoarseness of voice indicates the involvement of recurrent laryngeal nerve by carcinoma, and compression of trachea, esophagus, and great vessels indicate either large goiter or retrosternal goiter. If there is clinical feature of hyperthyroidism, the possibilities are Graves' disease, subacute thyroiditis, toxic MNG, and toxic adenoma. TSH producing pituitary adenoma, congenital activating TSH receptor mutation, and resistant to thyroid hormone are rare possibility of hyperthyroidism. Presence of symptomatology for more than 3 months, presence of orbitopathy, acropathy, and dermopathy such as Graves' disease. In absence of these features, subacute thyroiditis should be excluded from therapeutic point of view. Investigation of choice, thyroid scintigraphy. If the facility is not available, either go for TRAB antibody or wait for 6 to 8 weeks, during which thyroid function will be either normal or will go to hypothyroid state in case of subacute thyroiditis. Presence of hypothyroid features suggest Hashimoto thyroiditis, dysharmonogenesis, iodine deficiency disorder, or endocrine disruptors. Are there any feature of suggestive of malignancy? But signs are not specific for malignancy. Absence of the feature suggests but do not prove benignity. Initial investigation for diffuse goiter is TSH. If TSH is suppressed, investigation of choice is thyroid scintigraphy. If there is no uptake, it is subacute thyroiditis. Heterogeneous uptake, toxic MNG, and diffuse uptake suggest Graves' disease. Nodule is a discrete lesion within the gland with different contour and consistency than the rest of the gland. Radiologically, nodule is a focal region of differing parenchymal ecotexture. On USG, prevalence varies from 0 at 15 years to 50% above the age of 60 to 65 years. Nodules are generally benign, but 7 to 15% is malignant. Incidentally detected nodules on CT or MRI carry the same risk of malignancy, but on nodule on FDG PET have higher risk of malignancy. History that suggests malignancy in a nodule are radiation in childhood, family history of thyroid or other malignancy. Risk of medullary thyroid carcinoma is increased in familial MTC and Mentu syndrome. Rapid growth, compressive symptoms, history of vocal cord palsy, cervical adenopathy, firm and fixed to surrounding tissue increase the likelihood of malignancy. First, TSH should be measured. A low TSH suggests toxic nodule. Investigation of choice again is thyroid scintigraphy. FNA is not indicated because of low risk of malignancy. If TSH is normal or high, USG should be performed. TIDARS was introduced in 2017 by American College of Radiology, modeled by BIDARS for BEST. TIDARS on USG is assessed by composition, echogenicity, margin, shape, and echogenic foci of the nodule. Cystic, almost cystic or spongiform is assigned with 0 point, 1 point for mixed, and 2 point for solid or almost completely solid lesion. 1 point for hyperechoic or isoechoic echogenicity, 2 point for hypoechoic compared to thyroid parenchyma, and 3 point very hypoechoic compared to stem muscle. Taller than wider is assigned with 3 points, 2 points for lobulated or irregular margin, and 3 point for extrathyroid extension. 1 point is assigned for microcalcification, 2 points for peripheral or rim calcification, and 3 point is assigned for punctate echogenic foci. At all points of all category to determine TIDARS level. American Thyroid Association recommends FNA for nodule of more than equal to 1 centimeter with high and intermediate suspicion, more than equal to 1.5 centimeter with low suspicion, and more than equal to 2.5 centimeter with very low suspicion sonographic pattern. But American College of Radiology is consistent with other guidelines for recommending FNA for high suspicious nodule of more than equal to 1 centimeter, but the threshold for mildly suspicious and moderately suspicious nodule are 2.5 centimeter and 1.5 centimeter respectively, higher than the cutoff advocated by American Thyroid Association. This is because of there is significant lack of concordance between sonographic and pathogenic sizing with a tendency of higher measurement on ultrasonography. Advantage of ACR titers over other systems are titers does not include subcategories, making the system easy to understand and apply. A prospective evaluation concluded that titer system has the highest area under ROC curve for identification of the risks of the nodule. Aim of FNA is to identify clinically relevant thyroid cancer that benefits from therapeutic intervention. For nodules with more than 25 to 50% cystic component, difficult to palpate, or posteriorly located nodule, USG guided FNA is preferred. Result is categorized into 6-tier Bethesda system. Aspirate without requisite number of cells is Bethesda 1 or non-diagnostic. Repeat USG guided FNA produce diagnostic cytology in 75% of solid and 50% of cystic nodule. Bethesda 2 or benign nodule, recommendation is against surgery unless there are compressive symptoms. Levothyroxine therapy had no effect or only modest benefit in reducing nodule volume. Serial USG is recommended 6 to 18 month interval, but repeat USG guided FNAC is recommended for nodular growth more than 50% increase in volume or 20% increase in volume at least 2 dimension with a minimal change of 2 millimeter. Recommendation for Bethesda 3 or FLASH is repeat FNA after 3 months. BRAF, red PTC or PPR gamma PAX8 mutation is associated with thyroid malignancy in 100% of cases, whereas RAS mutation is not specific for malignancy and have 74 to 87% positive predictive value. 167 gene expression classifier has been proposed as a rule-out test due to high sensitivity and negative predictive value. Lobectomy is recommended for Bethesda 4. 7 gene mutation panel is used to rule out test because of high specificity and positive predictive value. Molecular classifier using mRNA expression reported 96% negative predictive value for cancer with potential to avoid surgery in those with negative testing. Lobectomy is recommended Bethesda 5 or indeterminate cytology, but total thyroidectomy is preferred for specific mutation, sonographically suspicious large nodule, familial thyroid carcinoma, or history of radiation. For Bethesda 6, total thyroidectomy is recommended, but surveillance is an alternative in very low risk tumor at high surgical risk or shorter life expectancy. Cell-free DNA integrity index and non-invasive marker of cancer will be promising marker in evaluation of thyroid nodule in recent future. So in conclusion, goiter is an abnormal enlargement of thyroid gland. Iodine deficiency is most common cause of goiter worldwide. Goal is to diagnose biologically significant cancer while exposing fewest number of patients with benign or indolent disease to unnecessary testing as well as surgery. Smaller nodule of less than 1 centimeter can be conservatively followed with repeat ultrasonography in 1 to 2 years. An integrated approach of clinical ultrasonography, FNA, and molecular testing may be able to improve outcome in thyroid nodules. Thank you very much for your patient hearing. I will be happy to have your suggestions, comment, or query. Yeah. Thank you, sir. It's a very important question. But remember it, only non-specific symptom with biochemically normal thyroid function test does not need treatment. So, sir, what you have told, it is a basically subclinical hypothyroidism. There is few indication of treatment of subclinical hypothyroidism. So, if TPO antibody is positive, you have to treat. If there is goiter, you have to treat. If the patient is planning for pregnancy or pregnant, in this 4 scenario, you have to treat. Otherwise, we have to explain and counsel the patient about the symptomatology and look for other cause of this symptomatology. Yes. Sir, selenium, thank you, sir. Selenium study is ongoing, but the result is not conclusive. Some studies showing effective, study are some showing less effective, study are short duration with a small number of patients. So we have to wait for large study for a long duration. Thank you, sir, very much.
Thank you, sir, for the nice presentation. And if there is no further question, we will conclude the session here. Thank you.
Thank you, everyone, for this enlightening oration. We extend our sincere gratitude. We request the esteemed faculty speakers and honorable chairperson to receive their memento from the registration desk.
We now move into another engaging and insightful scientific session titled Clinical Medicine, Principle, Practice, and Public Health. We kindly invite our distinguished chairperson for this session, Dr. Anita Datta, ma'am, ex-HOD, Professor of Department of General Medicine, NRS Medical College, Kolkata. Dr. Vishwakant, sir, HOD and Professor Forensic Medicine, Mata Gujri Medical Memorial College. Dr. Rituparna, ma'am, Associate Professor, Department of Radiology, Mata Gujri Memorial Medical College. Dr. Nandita Chattopadhyay, HOD and Professor, Department of Pediatrics, Mata Gujri Memorial Medical College. To kindly come upon on the dais and take the proceeding forward. Dr. Anita Datta, ma'am, ex-HOD and Professor of Department of General Medicine, MGM Medical College, Kishanganj.
A very good morning to all the dignitaries on and off the dais, respected faculty members and delegates. So we will now proceed to our sessions. I request our Professor and HOD, Department of Radiology, Mata Gujri Memorial Medical College, Professor Dr. Rizaul Karim sir, to please come upon stage and deliver his speech on POCUS.
I can move the slide now. Okay. Thank you. This is actually a huge topic, point of care ultrasound. The time is short, so I will browse through. If you have any question, we'll take up later on. You know, point of care ultrasound, nowadays, 20 years back or 30 years back, nobody would have imagined that ultrasound machine will be helping the clinician in instant diagnosis. Though there are many debates about that, we'll come to that later on if I find time. But let us try to understand the basic principles of point of care ultrasound being performed by the clinicians, particularly the medicine people. So this is a goal-directed bedside ultrasound performed by the clinician to answer specific questions, yes or no questions. The purpose is rapid tries. It is not complementary to a full diagnostic evaluation. It is a focused procedure, and the main purpose is, of course, rapid tries. So before we go into the details of the protocols and procedures, you have to understand what kind of machines you have to use it. The choice of probe is very important. You know, there are different types of probes, curvilinear probe, phased array, linear probe, and nowadays volume probe. There are many probes, of which for POCUS, the best probe is, of course, the phased array probe, that is conventionally known as the cardiac probe. Then curvilinear probe and the linear probe are also complementary. You know, before you start the study, You have to understand depth, gain, focus, TGC, orientation, etc. To tell you very briefly about this, when you try to understand the study, you have to understand the depth of the lesion. And based on that, you can adjust the depth. There is a, if you see the machine there on the left hand side, you have a panel and you will see the depth there and the frequency there. So you have to choose the right frequency to see the right depth, and the gain, means the brightness or blackness, has to be also adjusted if you want to see it nicely. You know, standard focus application, everybody knows, that is known as the first protocol. And there are many other protocols nowadays in the developing phase. Actually, every department has a protocol of its own. Medicine has some protocol, cardiology has some protocol, the surgery people have some protocol, and anesthesiology have a different protocol. So all these protocols are there. We'll come to that later on. But the basic thing is that we start with FIRST. FIRST is nothing but an imaging assessment in trauma, okay, by ultrasound. So what do? We take the ultrasound, you know, these are the indications. First indication, ultrasound examination indications, hemodynamically unstable patient for TRIAS. There are another group, means your patient is stable but you still want to do a FIRST. But most of the patients that is taken care of by FIRST is for those people who are hemodynamically unstable. So what do you want to see? Before we go into the procedure, you know, you have to have some patient preparation. The patient has to be in a particular position. Most of the positions that you do is a supine position. But if you see, suppose you are suspecting a transection of the pancreas, or you are thinking that there is some trauma which is very devastating, in that case, slightly prone position, semi-prone position is also accepted. And that is a very unique technique of particularly seeing the pancreas. The sequences are basically we start the study from the right upper quadrant and then go into the lower quadrant, and you can see the subgyphoid area to see the cardiac, the heart, and then go to pelvis. You can see the lungs also. There are different protocols for lung. I am coming to that later on. So these are the step-by-step evaluation of FIRST. And what are the questions that you want to actually address? You know, you want to see whether there is two things you have to see: whether there is an injury, whether the heart is performing its function, whether the patient is hypovolemic, whether there is a collection anywhere in the serous spaces, in the peritoneum, in the pericardial spaces, or in the pleura. So accordingly, you have to place your probe in those positions. We are showing some of the positions, like if you want to see the right side, where do you want to put the probe? Usually the probe is placed as indicated here. You can go to the mid-clavicular line, but in our department, we always start the study by seeing a view where you can see the kidney and liver together. Why? Because we want to see the hepatorenal pouch of Morrison, which is a very important space for any abdominal collection. So on the right side, if you want to see, using the liver as an acoustic window, identify the lung, liver, hepatorenal pouch of Morrison, the diaphragm, the long axis of the right kidney, and Morrison pouch, you know, this is the space between the liver and the kidney, so that will come. And also in that view, we will be able to see the pleura. You can see this is the pleura, okay? And you know, you will have a mirror image artifact if the lung is normal. And you will not be able to see the spine. The spine can be seen. If you see, this is the kidney, and spine you can see, but in the chest you don't see the spine. Similarly, in the left upper quadrant also, you will focus the spleen and the kidney together, and the diaphragm will be seen, and you will be able to see the lungs also. In the pelvis, you know, the probe position is very important to see the pelvis. Most of your patients, when come to the emergency room, the bladder may not be full. If the bladder is full, very easy to see the urinary bladder and the collection in the pelvis. But if the bladder is empty, sometimes even for a very, you know, I have seen people who have long experiences, they mistake a a cyst in the pelvis with the urinary bladder. So it's very important to see a full bladder. That's why the study has always to be, done before you catheterize the bladder. Whenever the patient comes, you put all the tubes, one in the nasopharyngeal tube, another in other tubes, in the venous tubes, and then catheterize the bladder. So don't catheterize the bladder if you want to do a POCUS. And the probe position is very important. Whether you want to see the long axis or the short axis, there is an indicator in the probe. If you see the long axis, the probe will be anteriorly placed. And you have to tilt the probe slightly so that we can see the symphysis pubis and the lower part. So in males, identify the bladder. Immediately posterior to the symphysis pubis, prostate, seminal vesicles, and the rectovesical pouch in the longitudinal view. The rectovesical pouch is where the fluid will accumulate in the male pelvis. In the female, of course, the uterus will be seen, and behind the uterus, the pouch of Douglas, where fluid usually accumulates. I have already told about this, that you have to see the bladder. A full bladder is like this, and uterus or prostate, whatever is present, depending on the patient's, whether it is male or female. And the fluid will be seen in these areas, either in the rectovesical pouch or in the pouch of Douglas. This is a very important view, because our whole purpose of the POCUS examination, whether you get a functional heart or not, and whether if the heart is functional, then whether there is any strain, if the heart is not properly functioning or it is properly functioning, that you have to assess. So that can be done in various views. The most common view is a subxiphoid view. Means you place your probe here, and your the probe direction of the probe will be towards the left shoulder. So you'll be able to get this kind of a view where the right ventricle is our most important structure that has to be seen. Why? Because if there is a collection in the pericardium, what happens is the right atrium and the right ventricle is most commonly affected. The right ventricle may completely collapse. The left atrium may the right atrium may completely collapse. This is usually in trauma patient. This is very important to see whether the right ventricle is failing, and accordingly you will guide the, you will guide the procedure, and you can do the triage also. This is a another view of heart where you will be able to see the aorta, left atrium, right ventricle. Lung also can be similarly assessed. For assessment of the lung, you have to see whether the lung is sliding or not. When the lung is sliding, you will see the ants moving like this kind of a picture you will be able to see. And you can go for an M mode also, because we are short of time. I am slightly rushing through. Fluid collection will be seen like this, okay? Means you can see the liver and this is the kidney. So the hepatorenal pouch, you have fluid, and apex of a part of the liver will be also be seen. The left side also similarly, surrounding the spleen, perisplenic collection will be visible. And in the pelvis also, there is fluid collection in the pouch of Douglas or in the rectovesical pouch. I want to show you how you will be able to diagnose pneumothorax. When you are doing the study, if the lung does not slide, so there will be a point where you will be able to distinguish the sliding lung and a non-sliding lung, which is known as the lung point. If lung point is present, means you don't see the lung not sliding, and another area where sliding is present, so that indicates pneumothorax. That is almost 10% specific sign of pneumothorax. So this is how we do lung study. Similarly, abdominal air can also be diagnosed. Normally, if you see only peritoneal, one single peritoneal line is seen. If you see multiple peritoneal lines like this, so this is a sign of pneumoperitoneum. So with this, I think rest of the protocol, we don't have time, But actually, you see this, how we divide the patient. If the trauma patient comes and if it is unstable, your first is positive, go to the operating room. If the first is negative, then go for CT scan. In the stable patient, if you have you do a first, if it is positive, you go for CT scan. If it is negative, then go for serial estimation. So with this, I am concluding the examination. Only one thing that I want to say is who will do the first. This kind of study who will do? Whether the clinician will do or the radiologist will do. In India, there is no protocol. Only problem is we have some legal bindings that you cannot perform ultrasound unless you have a PCPNDT, you have to be approved by the PCPNDT. That is a great problem, but I think government must consider this. The clinician has to take the decision. They should take the lead. And whenever radiologists will be required to perform the study, that can always be done as a second opinion, but the first opinion should lie with the clinician. Why? Because there will be inordinate delay. If the patient is sent to a radiology room and they will investigate and examine, so that will take a lot of time. So we always advise that focus should be done by the clinician themselves, and then when, when a second opinion is required, the patient can be shifted to a radiology room, but there are legal bindings. I hope maybe in future government will consider this, that a ridiculous rule like PCPNDT should be abolished. Thank you very much.
Thank you, Professor Karim, for your lucid presentation. Just one thing to ask, as there is no time, there's one thing to ask. You have told it very correctly that first the clinicians should be in the forefront for focus. Yes, and it also is very helpful in ICU. Like, is there any role of POCUS, definite role of POCUS in diagnosing fetal abnormality when you are doing a pelvic ultrasound?
Ma'am, for diagnosing fetal abnormality, POCUS, I don't think it will be a very helpful study because there is a focus study. You need a full radiological evaluation or ultrasonographical evaluation for diagnosis of the fetal study. Fetal medicine has now developed tremendously. And even the obstetrician are doing those scans, and we in the radiology department also do a lot of scan. And we find a lot of congenital abnormalities, minor and major, sometimes which also dictates termination. Those cases are also there. So I don't consider that POCUS will be very much useful for these situations. I think POCUS will be mostly used by the clinician for guiding whether fluid therapy is required or not, whether actually there is pneumothorax, whether there is pneumoperitoneum, whether the heart is collapsing, whether the ventricles are properly functioning or not. I think these will be the best thing for POCUS.
Mainly helpful in clinical diagnosis
of
the clinicians.
Yes.
Okay. Thank you very much.
Thank you.
Thank you so much, sir, for your presentation. And as sir mentioned, this is primarily for clinicians, but I hardly see any PGTs from medicine department right now. Anyway, so we will now go to the next presentation by Professor Dr. Ashish Shaha, ex-HOD, Department of General Medicine, Mata Gujri Memorial Medical College, and his topic is consent in clinical medicine.
Respected delegates, respected chairpersons, and most probably the only one or two PGTs is there, no? So my topic is consent in clinical medicine. It is very important for the day-to-day practice from the physicians, for surgeons, and also for any radiological investigator also. This is. Next, what is the definition? Definition is a consent is a method by which the patient voluntarily agrees to accept the proposed action, decisions or conditions with sufficient understanding and without any coercion. Means proposed treatment, proposed investigations, proposed radiological procedures, and any surgical procedures. In legal and medical research context, consent includes disclosure. It provides relevant information about the situation to the patient. Understanding, it ensures a person comprehends that information. Voluntariness, making sure that there is no pressure or undue influence during consent. This is very important. Sometimes some patients, some doctors, assistant may tell that you should sign it sooner because it is very important for you. This should not be. And capacity confirming that the person is capable of making an informed decision. What are the types of consent? One is informed consent, that is regularly required for the thesis purpose and also some intervention purpose. The entitlement of a conscious patient is in sound mind to decide whether or not to submit to a particular purpose of treatment proposed by a doctor. Implied consent. It is a consent given automatically by the patient by virtue of its action, like approaching to a doctor to a consultation. Because like that, if one patient wants to go to any cardiologist, or suppose Dipanjan or Dr. Mahapatro, this is implied consent. They must go to that the doctors. Blanket consent, this is now invalid. Third party consent, this is very important. This is legal when an adult responsible person given consent for a patient who is unable to give consent or in favor of minor or close relative of unconscious patient. What are the stages of consent process? It ensures competence, that is, the patient can take in, analyze and express his or her view. Check the details of the patient. Make sure that the patient understands who you are, whether you are doctor or doctor's assistant or nurse or technicians, and what your role is. Discuss the treatment plans with sensible alternatives. So if you do a cholecystectomy, whether it is laparoscopy, whether it is open, whether it is associated any other procedures like ERCP, it should be disclosed. Discuss the type of anesthetic proposed. Give the patient time and space to make the final decision. At least he or she will discuss with his family relatives what type of procedures he or she should require, what is feasible to him or her, that should be discussed. Check the patient's understands and has no more question. At the end of the total discussion, you have to ask the patient any question from you. If he or she will say, yes, this is my question, what is the adverse effect of this drug, what is the contraindication, whether I can take this drug, this you have to ask. Such informed consent must be obtained in presence of a witness who should fix his or her signature prior to every procedure. This is very important, another important point. Valid age of consent. According to Section 90 Indian Penal Code, consent given by a child below the age of 12 is invalid. A patient between 12 to 18 years with sufficient understanding can provide effective consent. A patient above the age of 18 with sound minds, absence of any cognitive impairment, can give effective consent. The pregnancy of minor women cannot be terminated except the consent in writing of the legal guardian. What is invalid consent? This is another very important, these are the points very important. It is obtained, if it is obtained by fraud, misinterpretation as to the nature of the procedure, under undue influence by any persons, threat of violence, if the consent is taken when the patient was under sedation, like thumb printing, that if the researcher fails to provide proper information, fails to disclose the procedure sufficiently, if the consent is given by a person or below the age of 12 or patient with cognitive impairment, if the procedure performed by a doctor is different from the one against which the consent was given. You have taken the consent for laparoscopy procedure, and you have ultimately you have done the open. This is legally invalid. In that case, consent is invalid. You have to take the consent for both. If the physician is different to whom the consent is given. You have given consent to one physician, another patient is giving the treatment, that is invalid consent. Consent in case of emergencies. If the patient is under shock or sedated or has no capacity to understand the emergency situation, in that case doctor can operate lawfully without any consent, as it may be life-saving. So medical rather than legal consideration are of given great importance in the life-threatening situation. So in that case, you need not take the consent of from the patients. You have to take your own decisions. In that case, you can from the court also. You have to take this urgent. In above cases, restricted absolute necessary procedure, but elective procedure should not be referred. If there is a fracture of the hand, you can wait. Then you have to take the consent from the patient. Written opinion should be taken that emergency surgery is necessary without consent. In case of unconscious patient, if possible, written consent should be taken from the next to kin. If the patient is unconscious, so you can take the consent from his son or daughter or any nearest person. If the next kin or near relative is not found, in that case written permission must be taken from the hospital in charge of or police or judicial officers. Refusal of consent by the patients for the treatment. Patient has right to reject a specific treatment or full treatment or select alternative form of treatment. Even this alternative procedure has risk of even death. Doctors who takes the defense that consent was given must prove absent of consent. If the refusal involves the welfare of the minor or unborn baby, this is very important. The court can override the parents. This means that the court prioritizes the minors or unborn baby's well-being above the parents' parental right and act as an ultimate protector. If the patient refuses to treatment, the consequence of the refusal of treatment should be explained to the patient in front of the witness, and he or she must sign in the document of refusal along with that witness. Even the patient, his or her relative signs refusal of document, neutral witness must sign the document. So 3 signs is required. The concerned doctor can even refer the patient elsewhere if he refuses or withdraw his or her consent. Following points to remember: absence of valid consent from along with improper documentation are commonest cause of which doctor may lose the case. That is why case is going on, different types of cases. Consent must be person specific and procedure specific. Blood transfusion requires separate consent form. Signature of the spouse must be required along with signature of the patient in case of sterilization procedure. Though it is legally not required, but it is highly desirable. Person should give consent in own handwriting so that validity of the consent is not questionable later on. Never delegate the job of obtaining consent to the junior staff or others. So doctor himself will take the consent. Patient consent in OT staff are taking the consent. That is not good. Patient's consent form along with the case records of him or her should be kept in the safe custody for future if there is any case. In case of 2 or more procedures are required, consent of each procedure should be taken. If you do the ERCP, you have to take the consent. You have to do the colonoscopy, you have to consent. If there is a change in the planned procedure, it should be priorly informed to the patients, and consent form for the new plan should be signed and witnessed. In absence of valid consent, doctor should be liable even if the procedure went fine and the patient is actually benefited from it. Patient can do the case in future. Why you have done it? If the medical practitioner violates the essential criteria of the informed consent, he or she should be liable to be removed from the role of medical counsel of an Indian Penal Code, may fine or even imprisonment. Legally valid consent does not offer immunity from medical negligence, another important point. So he or she should be very much careful during in his treatment. Importance of informed consent, respect of autonomy, trust and transparency of the promotion. It will strengthen the trust between the patients and healthcare providers, prevention of coercion, patient safety enhancement. If any patient know the risk of outcome of the procedures of treatment, in that case, he or she will better equipped and identify the adverse effect of or any complications of this procedure. Legal protection. Informed consent provide legal protection and reduce the disputes between the patients and healthcare provider by documenting patients understood and the risk and benefits of the procedure of treatment. Patient is agreed to the proceed to perform the procedure and treatment. So informed consent, ethical basis of the research. In the clinical research, this is crucial as it helps to make the ethical study design, as it will help to ensure and explain the participants for the following: awareness of the experimental nature of the study, potential risk and benefit and complication of the study, their every right to withdraw himself or herself from the study, that is drop out, and there is no harm to the patient, rather it may good to the future, and empowerment of the patient's care. So take home message, ethical principles, consent of clinical medicines. Consent must be voluntary, informed, understood, capacity based. It must be procedure specific, person specific, proper disclosure of the benefit, risk, alternatives. Documentation is critical. In emergency, only life-saving procedure may be done without consent. Elective must be deferred. And last slide is the ethics and legal importance. Informed consent protects patients' autonomy, promotes trust and prevents coercion. Even valid consent does not provide immunity for the negligence. So in that case may be done. For minors, unconscious patients or lack of capacity, legally acceptable surrogate consent is required. Patients have full right to refuse the treatment. So always obtain consent yourself, never delegate, and ensure witness of the procedures. This is for the PGTs. Knowledge is like pearls deep in the ocean. You have to dive into it to fetch the pearls to make an ornament of knowledge. Okay?
Thank you. Thank you, Professor Shah, for a wonderful and very lucid presentation. I have one small question for you. As you have mentioned, for an unborn baby, for the benefit of the unborn baby, the parents' opinion may be overruled by the court. Yes. Okay. Taking it forward, for a born baby to 12 years of age, if the doctor considers that a particular anything to be done, which is for the benefit of the child, but the parent does not agree.
Then you have to go for the judicial.
Okay, but at that point of time, when it is life-saving.
Life-saving, in that case, patient can stay, doctors.
And patient says, and the parents say no.
In that case, doctor have to take decisions or have to sign the refusal consent and send them.
Then they can proceed with it? Okay, thank you. Yes, there's a question there from the audience.
No, but in case of emergency procedure, if it is life-saving, you can proceed with the consent of the doctors or legal officers.
So my question is, if there is a controversy, parents are saying no, doctor is considering that this particular thing needs to be done.
Patient's life-saving procedure, you have to do. Otherwise, if the patient dies, in that case, again, opposite action may be taken.
But these
controversy.
Say, for example, there is a 11-year-old child with perforation peritoneum. Brought to the emergency, it is an emergency condition. The doctor, the surgeon wants to operate, the parents are refusing to.
In child.
In the child. Because he's an 11-year-old child.
You have to explain everything about the.
Everything has been explained, but the parents are not ready for the surgery. The doctor, considering it's a life-saving surgery, takes the child for surgery, and the child dies in the surgery, God forbid. Now what?
Yes, that may be a patient. If the patient dies, if the patient dies and parents not given the not given the consent, in that case, doctor Doctor may, you have to answerable to the court regarding that. You have to answerable to the court.
In the best interest, the doctor should not be proceeding with the.
That should be, and referral procedure is best.
That is your medical notes that I wanted to do this.
Yes.
Guardians did allow.
And you have to face the consequence in the court.
Your notes will save you.
Yes. Yes. Patient may die, and you have to make the note. That is the very important documents.
But sir, I did not want to comment, but now with whatever little experience I've gathered over the last 2 years, doctors are saved tremendously by their notes.
Yes.
The problem is the lack of BHT notes. If the notes are there that I wanted to do this, was not able to do this, was prevented from doing this, the doctor is never punished.
Minute to minute, the document should
The
be done.
notes are something which we should tell our juniors to document.
Yes, yes. Note is
Ekdam.
more important other than what is you have done. The patient does not.
Because,
patient
sir,
does not know, but document is more important.
So now that we are facing and we are examining BHTs in the council, even rewriting on the notes are causing trouble to the doctor.
Yes, it is different.
Rewriting, different pen color, all these are causing problems. So give proper, honest, detailed notes. Patar par pata note. Joto beshi notes, toto bhalo.
Sir, may I ask one question? Sir, may I ask you one question?
The doctor in charge, he will proceed. He or she will proceed. But in that case, head of the department or head of the institution should also sign it. Then I think it will be more beneficial to the doctor, isn't it?
But everybody answerable to the court. Why you have signed?
That too.
So
that's
HOD or head of the institution will sign when he will see or she will see that proper documentation is present.
Yes, that's true.
That is very important.
Over the years in clinical practice, in such precarious situations, from a clinician's point of view, it is always very good to involve as many people as possible.
All the people will be attached when he or she will see that documentation is present from the primary doctor.
Exactly.
All the investigation procedures.
And you all remember, sorry, Ashish, you all remember last year's case when, before doing the postmortem, no consent was taken from the party. Yes. That you all remember. And what were the consequences that you also
You
remember?
can tell it in Bihar, but not in West Bengal.
Sir, in last 15 minutes, what you have told, it is very difficult to practice. Okay, sir, I want to know one thing. In OPD practice, suppose we examine the patient and advise admission. But patient refused, now, no, sir, I will not admit myself. So then
if
what?
you write the advise admission urgently, in that case, whether patient be admitted or not, that is patient's responsibility. Your duty is over.
No, yes, sir. Suppose little doubt, patient can be admitted. It is better to admit it in this situation.
No, better to admit is wrong word.
Suppose
better not.
So
you
patient
have to admit it urgently. You have to write.
Urgent situation is separate. Suppose patient having fever for 7 days, 10 days like that, it is better to admit the patient. So I write advice admission. But patient said that you write some medicine, I will be...
That is verbal, but not documented. No. তুমি লিখতে পারো নাও লিখতে পারো, but advice admission, that is most important. All the document, all the verbal.
No, sir. Definitely, sir. I'm telling the situation, 7 to 8 days fever. I advise for admission. The patient told that I will not be admitted. You write that medicine, investigation. I will come.
That is up to them.
So then what I will do? I first advise admission.
Lastly, you have to write the admission.
So does it require any signature?
Ideally, patient and his relative should sign it. Two sign.
Patient and patient relative.
Patient and patient relative, close relative. Close রিলেটিভ লাগবে, একজন ওই যে পেশেন্ট পার্টি বাড়ির লোক, পাশের বাড়ির লোক হবে না। সুমন।
Thank you very much. This had really raised a controversial issues and very energetic. Everybody's pre-lunch waken up. Thank you again. So we go on to the next session.
I now request Dr. Arnab Bhattacharya, Assistant Professor, Barasat Medical College, Kolkata, to come up on the stage for his talk on gut microbiome and systemic illness.
Good afternoon, everybody. Today, the topic is gut microbiome and systemic diseases, which is a complex at the same time, very fascinating topic. As you all know, that human body harbors a great deal of microorganisms. Together, they are known as microbiota, and microbiota with its genome is known as microbiome. Now, of all the places in human body, intestine harbors the most, and of all the bacterial taxa found in nature, 5 are most prominent. They are the Actinobacter, Bacteroides, Proteobacteria, Firmicutes, and Fusobacterium. Again, there are virus, fungi, and archaea. And of all the places, intestine harbors the most, and stool is the most easily obtained sample for studying these microbiota. The microbiota and the microorganisms found on the stool, though sometimes the bacterial noise present in the stool overwhelms its importance as an surrogate marker, but it is still the most easily obtained sample, and sometimes slide change আমি করব। হ্যাঁ, my slides are very few, sir, madam. So the microbiome found in the stool are almost similar to the microbiota or the microorganisms found on the biopsy specimen. But sometimes the bacterial noise present in the stool overwhelms its importance. And this is not a new concept. As about 2.5 millennia back, Hippocrates once said, all disease begins in the gut. This is a picture taken from Harrison, and as there is a great deal of diversity of human microbiota as per genetics, age, diet, lifestyle, sites, use of drugs, and circadian rhythm, as this picture shows that in the gut stool there is a predominance of Bacteroides, whereas in the buccal mucosa there is a predominance of Firmicutes. Regarding age, microbial exposure occurs at the neonatal life, but and the adult microbial population attained at the age of 3 to 4 years, and there is a decrease in Bifidobacterium. As also in the geriatric age group, there is a decrease in Lecanospiraceae group, which is predominant in the younger population, and the increase in Bacteroides. Regarding diet, also there is a difference between because these diets are also the nutrient, not only for the human beings, there are also nutrients for the bacteria. Gut microbiome present, that is commensal gut microorganisms. So it is found that whenever there is a vegetarian diet, there is a predominance of Roseburia, Ruminococcus, those organisms, whereas for diet predominant in non-vegetarian persons having subsisting on non-vegetarian diets, there is a predominance of Bacteroides in gut microbiota. And use of drugs, almost any drug can change the gut microbiome. Almost any drug, as is found in a ciprofloxacin study, that with a course of ciprofloxacin, there is almost 1/3 of gut bacterial taxa is lost. Though ciprofloxacin is rarely effective against gut anaerobes. But so this shows that there is an interdependence of different kinds of bacteria. And this varies with circadian rhythm also. Now there is a functional balance between this gut microbiome and human health. Together it is known as holoband. And this balance is known as, this balance when lost, it is known as dysbiosis. And there are different concepts, different studies, and Human Microbiome Project, that is the largest microbiome project in the world, and they have shown different kinds of diversity of these bacteria. So and they have tried repeatedly to identify a specific commensal bacteria with a disease. But there are controversies. So there a generalized concept can be approached, that is, whenever there is an inflammation, there is a predominance of Enterobacteriaceae over Lacunospiraceae group. And second is that there is a loss of diversity of this organism. This diversity is again of two types. One is alpha diversity, one is beta diversity. Alpha diversity is studied in a single sample of the bacterial population, is studied in a single sample, and beta diversity is the studied the same bacterial population is studied in different samples. So it is it is more related to the microbial relatedness to the disease. And there in obesity, in different this loss of diversity is found in different kinds of diseases, such as in obesity, which is a new pandemic, and there is a loss of alpha diversity. In IBD, inflammatory viral disease, there is a loss of both alpha and beta diversity of the commensal mycobacteria, that is Clostridium type 4 and type 14. That is, examples are Faecalibacterium, then Lacunospiraceae group. And in case of Crohn's disease, it has been proved there is a more history of more exposure of entero-invasive type of E. coli. Then the short chain fatty acids, these are very important, and which are produced by the action of gut microbiota on complex undigested polysaccharide fiber, and they are important for the nutrition of colonic epithelium, as well as they induces colonic T regulatory cells that suppresses inflammation. So disturbance of this kind of the microbiota may produce colitis. Then there is infection of Vibrio cholerae group. There is overwhelming majority of the pathological bacteria, and in Clostridium difficile infection and fecal microbial transplant, it has been proved that fecal microbial transplant from a healthy donor or from a of a person of a desired phenotype, if transplanted to a person suffering from recurrent consular difficile infection, it may prevent the infection. Actually, it is shown experimentally that Clostridium silens can prevent growth of Clostridium difficile infection. Then in HIV infection, there is an alteration of microbial flora, and the alteration or the loss of diversity stays even after the administration of antiretroviral drugs. That proves that there may be a memory effect of the previous high viral load, which may act as a surrogate marker for the disease. And in oncology, there are positive and negative effects, such as some of these gut microbiome, commensal microbiome, such as Faecalibacterium, Bifidobacterium, they can induce the checkpoint block inhibitors, that is anti-PD-L1 therapy. And at the same time, this is the positive effect. Negative effect is that in case of pancreatic ductal carcinoma, the drug used gemcitabine which is being metabolized by gamma proteobacterium, as well as in hematopoietic stem cell transplantation. It has been proved that it has been not proved, it has been experimentally shown that presence of Bloesia like bacteria may prevent graft versus host disease. Autoimmunity, regarding autoimmunity, there are two graphs that has been also copied from Harrison. It clearly shows that as over a period of 50 years, 1950 to 2000, as there is a decrease of incidence of different kinds of infection, there is an increase of different kinds of autoimmune disease such as type 1 diabetes, multiple sclerosis, asthma, and Alzheimer's disease, and Parkinson's disease. Actually, this proves that early exposure of human microbial, early exposure of this microbial exposure is needed for the homeostatic mechanism of gut, of the immunological mechanism of our body. As the time is limited, so I'm going to the last slide. This is where these are interventions. One is fecal microbial transplant. I have already explained about that thing. That is the first therapeutic regime regarding this approach. But there are ethical considerations. There are side effects such as abdominal fullness, bloating, and etc., which may subside within 48 hours. But there are ethical considerations, and the dosage is not limited. So there may be mechanical problem as well as safety problem with the use of this, because the dosage has not been actually interpreted till now, actual dosage. So we have tried to use prebiotics, that is live organisms. But the problem is that with the prebiotics like Lactobacillus Saccharomyces boulardii, though used successfully in different studies in IBS or H. pylori irrigation or IBD, but they are more used due to their safety profile, not because of the fact that they have got a causal relation with the disease. Then the probiotics I have already said, that is the nutrients for this bacteria. That is one such is complex undigested polysaccharide fiber, very common is isopkul husk, and the green vegetables and isopkul husk. And there is another thing called postbiotics. Postbiotics is the material or metabolites of these commensal beneficial microorganisms, sometimes using yogurt or kombucha-like drinks. So here I should stop. Thank you for your patient hearing. Okay.
So you've talked about dysbiosis, where there is an imbalance or alteration in the gut microbacteria. Sir, is it possible that it is always symptomatic or it manifests as a disease?
Sometimes it manifests as a disease, that I have told you.
Yes, sir.
No specific approach cannot be said. So there is a generalized concept that whenever there is loss of diversity of these organisms, there is a disease. Such as in Vibrio cholerae, what happens, I have not explained, during the disease state, there is a high prevalence of Vibrio cholerae and other gut commensals are reduced. But in the recovery stage, it has been found that the recovery of the gut microbiota occurs chronologically, not abruptly. So this is the so actually for this to be therapeutically active, I have not said these to be therapeutically active, we will have to take the help of AI, and we will have to prepare a microbial toolbox depending on different kinds of omics, that is metabolomics, metagenomics, transcriptomics, and so in that case only we can use this therapeutic process specifically for a disease, and I think that will be more acceptable to the patient because they are more natural than the conventional drug therapy.
Yes, sir. Actually, my question was is it possible that a person is having dysbiosis and does not have an overt disease, that it is subclinical or it is asymptomatic? Because
they may present as IBS, not IBD.
Yes. So because this is particularly pertaining to medical professionals who are exposed to chronic stress, and just like you said that circadian rhythm alteration can also result in an alteration in the gut bacteria. So maybe many of us are already having dysbiosis and we are not able to detect it.
Sometimes you will become irritable. That is the gut-brain axis is there.
Yes, sir. That was the
only
point of
12 minutes
question.
are there, so I cannot explain all that.
Stressed, depressed, but still well dressed.
Yes.
So,
And sir, regarding prebiotics and probiotics, so recently there has been an argument that most of the prebiotics that we are consuming, they are getting destroyed by stomach acid. So what actually is reaching the
That
colon?
is an obstacle, gastric pH, stomach
Yes.
pH, that is an obstacle. That's why I say that they are more used because of lactobacillus, saccharomyces bacillus, they have no specific causal relation with the disease. They are more used as because of the safety profile, generalized safety profile, not because of the such as one I have said that it has been proved experimentally that only Clostridium difficile can be prevented by the growth of Clostridium seed. This type of causal relation has not been established for other diseases. So we are more. So that's why the concept of prebiotics is there. That is probiotics, prebiotics. One thing is sure that the complex undigested polysaccharide that has been acted upon gut microbiome at the colonic site, they are helping. That is esophageal husk. That they from these short chain fatty acids which are important for colonic epithelium and also the immunological function of the colon. That may prevent colitis. That has been proved.
So, Dr. Bhattacharya, thank you for beautiful presentation. I have one query. So, in the era of evidence-based medicine, so healthy individuals should regularly take probiotics.
We can use that. Different studies say that there is a success, but we can use. But we are still don't know which probiotic prevents which disease. That's why it's better to use prebiotics. That is esophageal husk. That is nutrient for the bacteria. That probiotics, whether the microorganism actually reach your intestine, it's not possible. Yeah. So the let's better use only esophageal husk or green vegetables.
Big thank you to all the speakers for their enlightening talks. So this session is over, and I request the PGTs to please announce the next session. Yeah.
Thank you very much. We extend our sincere appreciation to all the distinguished speakers for this session, for their valuable contributions, and to our honorable chairpersons for their guidance. We are grateful to each one of you for enriching the scientific discourse. We request all of you to move to the registration counter and collect their mementos.
We now move into another engaging and insightful scientific session titled Dr. Dilip Kumar Pal Memorial Young Scientist Award. I humbly request the Honorable Chairperson for this session, Dr. Bijon Chand Datta, Professor and Principal of Mata Gujri Memorial Medical College, Dr. Uttam Kumar Paul, Sir, Professor and HOD of Department of General Medicine, Mata Gujri Memorial Medical College, Dr. Deepmala Ma'am, HOD of Department of Microbiology, Mata Gujri Memorial Medical College, to kindly come up to the dais and take the proceeding forward.
We will now like to felicitate Dr. Swami Banerjee, Consultant Transfusion Medicine, Bangalore Medical Service Trust, Bangalore, Karnataka. May I request Dr. Atul Bed, sir, to come and do the honor.
Dr. Professor Atul Bed is Organizing Secretary of ICP-CON. I am requesting Professor Atul Bed to felicitate Dr. Swami Banerjee, who will be awarded. Dr. Soumi Banerjee, new blood group antigen detected at Bangalore Center. She is one of the member of that research team. You all hear from her experience regarding this. Thank you.
Thank you so much to the organizers for this incredible honor and for this opportunity. So I am Dr. Soumi Banerjee. I am a consultant at Rotary TTK Blood Center, Bangalore. And I will be talking to you about the novel blood group antigen that we have reported from an Indian patient at our center, which has subsequently been named CRIB, C-R-I-B, and the Indian context of rare blood group donor registries. So as physicians, all of you are extremely familiar with the blood and blood components from the stages of prescription and beyond. So I thought it would be a helpful context if I begin with what happens at the level of the blood bank, as in how do we manufacture these components and what are the steps that we take to identify rare blood groups such as this one and others. So at the blood bank, we handle blood in the following steps. First is, of course, collection. To collect blood, we motivate voluntary blood donors, and we collect blood from them in 350 ml or 450 ml closed, sterile blood collection systems. You would note that I did not mention blood collection bags. I've called them systems because currently they appear as double, triple, quadruple, or even penta bag systems. As you can see in the top picture here, there is a blood bag, right? This is known as the mother bag. This is the one that has the anticoagulant in it, and this is the blood bag that would be used during the collection process. And if you can see the transparent connection line here, connects it to a second bag, which is known as a satellite bag. So this is a double blood bag system, so there is only one satellite bag. For triple bags, there would be two, for quadruple, 3, and so on. We collect the blood from the donor at the blood collection camps in this mother bag and do not touch the satellite bags at that stage. We do, however, label them with the same barcode to indicate that they are coming from the same donor. Once we take all these collected units back to the blood bank, we move on to the processing phase. So the processing phase consists of, first, component preparation, second, immunohematological testing, as in ABO and RHD typing, and a test called IAT, which will become relevant later, and transfusion-transmitted infections, which are hepatitis B, C, HIV, syphilis, and malaria. So these are infections that can be transmitted from one person to another through blood, so we are mandated to test all collected units for these 5 pathogens. Like I mentioned, the separation step is done by something known as centrifugation. After centrifugation is done, this is how a blood bag would look like. This is how the mother bag would look like. The heavier RBCs would settle at the bottom, and the plasma with platelets and other components would be on the top. After this, we put these bags into something known as an expressor, which literally punches this bag and pushes this plasma into the satellite bag that you have seen at the top, which means that the RBCs remain in the mother bag and the plasma moves on to the satellite bag. At this stage, we seal and separate these 2 bags, and they are stored in their respective conditions. After all the processing is over, we move on to storage. So one of the major advantages of preparing components as opposed to containing the blood as whole blood is that every component of the blood, such as PRBCs, platelets, FFP, and cryoprecipitates, have extremely specific temperature and shelf life conditions for optimal storage, which would ensure that once transfused, they perform the best in vivo. This is not possible if we continue to keep the whole blood in just a single bag. If we separate them into different components, not only do we handle the needs of multiple patients from one unit with specific requirements, we also are able to store the respective components at their most optimal storage conditions. So after all of this is over, we are ready to issue it to users such as yourselves. So for issuing, we request that every blood request should be accompanied by the patient sample. We confirm the ABO and RHD type and all the demographical details of the patient that are provided in the samples as well as the request. And then we choose the suitable blood group and the component from our inventory. At this stage, we perform a test known as cross-matching. It is relevant for the packed red cells and FFP. This is essentially a test that helps us ensure that the blood that we have chosen, blood or blood component we have chosen, is safe to transfuse to this particular patient in vivo. It is essentially patient's blood sample mixed with donor sample and checking for any reactions. By reaction, I mean agglutination. If there is no agglutination, it is deemed as compatible and safe to transfuse. If there is a reaction, then it is known as incompatible. It can range in severity from 1+ to 4+, 4+ being the most severe, and that means it is not safe to transfuse, and we need to go for further evaluation. At this stage, I would like to take a sidetrack into the very basic principle of immunohematology, which is antigens and antibodies. So there are antigens that are present on the RBC surface, and there are antibodies that are present in the plasma. The rule of thumb here is that antibodies can form against antigens that are missing in a person. This is the rule which is the fulcrum for the entire field of immunohematology. So as you can see here, when we refer to someone as blood group A, that means that they have the A antigen on their RBC surface. That's what determines their blood type. What do they don't have? The B antigen, so they have anti-B in their plasma. Similarly, people with blood group B are called B because of their red cell type, that is the antigen type, which is the B antigen. However, they don't have the A antigen, so anti-A is what is present in their plasma. So in case of the ABO system, and only in case of ABO system, these antibodies are naturally occurring, as in an A person is expected to have anti-B in their plasma. For every other blood group system, as I will talk about later, presence of an antibody against an antigen only happens if this person is sensitized to that antigen through mechanisms such as pregnancy, transplant, or transfusion. Otherwise, this is not expected to be present naturally in their serum. So what do we mean by blood group antigens? As you can see, this is a schematic of an RBC, and I have highlighted the ABO and the RHD system that we have talked about so far. But if you see closely, there are several other antigens and antigen systems that are present on the RBCs. Like you can see Lutheran, NOPS, Duffy, Cromer, etc. So there are innumerable of these antigens, and they're grouped into categories known as systems. And every person has some antigen in each system. For example, the ABO antigen system consists of the A and the B antigen, and every person will have some antigen in that system, either A or B or both, which is called AB, or none, which is O. So we commonly test for ABO and RHD. If there is any other antigens that we are testing for, that process is known as extended phenotyping. And sometimes we may need to use molecular techniques to perform effective extended phenotyping. And it's very important to remember that the inheritance of these antigens are independent of each other. For example, you can have one person who is A positive. They may be negative for M, positive for K, and negative for small c. Another A positive person may be positive for all the others. So you can imagine how many possible phenotypes, permutation, and combinations are possible in the entire human population. The International Society of Blood Transfusion, or ISBT, they have defined 371 red blood cell antigens that are grouped into 48 distinct blood group antigen systems. And there are 27 antigens that have not yet been assigned to specific systems. So antigens that are present in over 99% of a population is called a high frequency antigen. This will become relevant later, like I mentioned. So antigen prevalences, and therefore what you would call as high frequency, can vary across ethnicities. Something that is a high frequency antigen among Caucasians may not be so among Asians. Now, if you have a person who does not have this high frequency antigen, they come within the 1% of the population with that phenotype. And as a patient, they are doubly challenging because they can develop an anti-high frequency antibody because 99% of the population have that antigen. So if they receive a transfusion, there is 99% of the chance that their donor has that antigen, and therefore they have developed, the patient can develop an anti-high frequency antibody. And if that actually does happen, then we will not be able to find cross-match compatible blood from the population because, again, 99% of the population has this antigen and will be incompatible. In that case, we will need a high-frequency antigen-negative donor, who, again, are only 1% of the population. So as a donor, these people are extremely precious to us. Now, when I'm talking about the development of antibodies and causing incompatible cross-matches, the process that I'm referring to is known as alloimmunization. Allo means foreign, as in you develop or you are immunized to something that does not occur in your body normally. So let's say the patient lacks a RBC antigen. In this case, I'll take an example of capital C. So the patient is capital C negative. Their AB1 RHD type is A positive, and since we don't type patients or donors normally for anything other than AB1 RHD type, we don't know that this patient is C negative. Now this patient can be exposed to the C antigen by pregnancy, transfusion or transplant from a C positive person. In this case, let's take into consideration that the patient has received a transfusion from a C positive donor who was A positive, mind you. So we received a request for an A positive donor, we have cross-matched and issued them an A positive unit. What we did not know was that the donor was C positive as well. So now, an anti-C, there is a possibility that an anti-C antibody can form in the patient's body because the C antigen is foreign to them. This will not affect the patient's own RBCs because they are C negative, but they will remain in the circulation, and in some cases they may even reduce in titer and become undetectable with time. However, when there is a next exposure to C positive RBCs, it can cause hemolytic transfusion reaction or HDFN or hemolytic disease of fetus and newborn, even though the donor may be A positive with an unknown C positive status. What is very essential to remember that all of this is always a possibility and not a surety. So when do these antibodies become a cause of concern for us is when they are clinically significant. And we call an antibody clinically significant if they are able to cause hemolytic transfusion reactions or hemolytic disease of fetus and newborn. If they are not capable of causing any of these two entities, we do not need to worry about them, even though they may be in the patient's circulation. Major clinically significant antibodies are AB and RHD, which is why they are tested commonly. And there's a whole host of minor clinically significant antibodies, which we do not test for routinely because they are minor clinically significant. They become relevant in cases where there are multiple transfusions and thereby multiple chances of exposure, such as malignancy, beta thalassemia, etc. So with all of this in mind, I would like to summarize whatever we have talked about so far. First is, blood type is more than your AB and RHD type. And matching AB and RHD type will not ensure compatibility, which is why we have to perform a cross-match test to identify any rogue antibodies that may be there in the patient's serum. Antibodies against other RBC antigens can interfere, which again are detected through cross-matching. Antigen negative people can give blood to antigen positives, but not vice versa. And the risk of antibody formation and difficulty in getting suitable unit will keep on increasing with more number of antigens that are negative in the patient's phenotype. So in case of autoantibodies, which are entities that are associated with autoimmune disorders such as SLE, the antibodies are directed against the patient's own cells, which is why least incompatible blood may be an option. However, in case of alloantibodies, as in the antibodies that are directed against antigens that are not present in the patient's own cells, we will need fully compatible antigen-negative blood. It is the only option. So with all of this in mind, we'll move on to the current case that we are talking about. So she was a 38-year-old female who was diagnosed with atrial septal defect and adult congenital heart disease, and she was posted for a surgery. Pre-operatively, it was requested that blood be arranged for any intraoperative transfusion requirement. At that stage, her hemoglobin was 9.7. The hospital blood center received her samples, found that her blood type was O negative, but they were unable to find any compatible units. At this stage, since we are a reference lab, they send the samples to our center. We performed cross matches with over 20 units and nothing was compatible. We collected samples from 20 different family members from their ancestral home, which was 250 kilometers away, and none of the family samples were compatible either. There were no atypical phenotypes that were identified on typing for 13 antigens other than ABO and RHD. And the patient sample also showed something called pan-agglutination, which is a positive reaction with all identification panel cells. It is at that point that we suspected that the patient probably has an antibody against an antigen that is present in most of the population, as in an anti-high frequency antigen antibody. So now at this point, since we did not have any other mechanisms to resolve these kind of discrepancies, we forwarded all the 21 samples, 20 of the patient family members and 1 of the patient herself, to International Blood Group Reference Lab, Bristol. And we also updated the surgical team on the same, and they performed the surgery without any transfusion needs. So at IBGRL, they performed targeted gene sequencing to identify a homozygous missense mutation in exon 6 of CD55. This mutation leads to the loss of a novel high prevalence antigen, thereby confirming our suspicion that there is some high frequency antigen that is missing in the patient. The sequence type was not available in the GenSig database, which means that it was a novel antigen, and they identified that it belonged to the Cromer system. And these are the antibodies that may be associated with hemolytic transfusion reaction, hence their significance. Now, when all of these findings were presented at ISBT Milan in June 2025, the working committee recognized this antigen as the 21st antigen of the Cromer system. The Cromer system already had 20 antigens. This was the 21st antigen. And they named it CRIB, or CRIB, CR for Cromer, I for India, and B for Bangalore. So this case was the impetus for us to develop a rare donor registry at our center. So rare blood groups are phenotypes that have a prevalence of less than 1% in the population. It can result from people lacking one antigen that is present in almost everybody, or they may be lacking multiple antigens, resulting in the net phenotype having a prevalence of less than 1%. So mass extended phenotype can help identify and maintain an inventory of donors with such rare blood types so that we can help a patient when there is a need. The problem here is that due to fragmented blood transfusion system, challenging cases such as this are usually managed with alternatives to transfusion. Their initial presenting complaints are managed and they are discharged, which is why standalone blood centers such as us, we lose patients to follow up as soon as those complaints are addressed. There are also several financial and logistical constraints in forwarding samples to us, and then we go ahead and forward it to another lab. So that takes a lot of time and also some financial issues. So in this instant, however, this entity, this lab entity of pan-reactivity with a negative DAT is something that needed detailed investigation into the cause, and a strong referral system that expands across multiple countries with advanced IH labs is also very, very important in resolving such cases. So in all of these cases, there are multiple options to meet transfusion needs. First is hematinics, of course. Second is minimal blood loss surgical and anesthetic techniques, so you do not need any transfusions at all. Third is something called autologous transfusion, where we collect blood from the patient themselves and we transfuse it back to them during their intraoperative need. Rare donor registries such as ours, however, this is not applicable for novel blood groups since we don't even know what kind of blood group we are looking for to transfuse. And family donors, because phenotypes such as this often occur as clusters in the family, which is why we tested the family to see if anybody was compatible with the patient. They were not in this case. So in India, these are the rare blood groups that we commonly encounter. I mean, I know this is an oxymoron to say rare blood groups and commonly encountered, but this is the most comprehensive list of it all. First is, of course, Bombay phenotype that we are all familiar with. The second, if you will see that there is a D with two dashes written on both sides of it, so this is known as D double dash. Third is known as Indian, IN, B negative. And the others I'll not bore you with, but this is the entire comprehensive list of difficult cases. So at BMST, what we do is we type all our donors for ABO and RHD type, of course, and then we identify donors with high recall probability, as in donors who will actually come back when they are invited to come and donate. In these donors, we type 13 more antigens in-house. Then we maintain the records for the same, and we forward these samples to National Institute of Immunohematology, Mumbai, for 13 more antigens, as in 26 antigens are typed for in these donors. We identify the rare donors with phenotypes with less than 1% prevalence, and we inform them, we counsel them, we induct them into the registry, and we recall them in need, and we follow up with them whenever necessary. I will just give you all a second to go through the atypical cases. Just have a look. I will not be boring you with the details of the same. These are the atypical cases that we have found and handled. And in most cases, we've been able to provide compatible, cross-match compatible blood from our registry for most of these patients. The penultimate one is Bombay. We had 4 donors in the very recent past. We had something called JK null. This is a phenotype that is commonly found among Indians as well. So this was a family that was in Kerala. Duffy null was one in an African patient that had come for international medical tourism, and the others. So the takeaways that I would like to end with are, first, in case of any difficulty in arranging compatible blood for patients, you must look into the cause, because there may be some significant underlying abnormality that have the potential to complicate subsequent transfusions and pregnancies. Rare phenotypes may also occur as clusters in families, and therefore it is very imperative for the family members to be tested and aware of the implications as well. And when in doubt, please consult a TM specialist or an advanced IH reference lab such as ours, and we'll be very happy to help you with resolution of such discrepancies. Thank you so much.
Yes, Dr. Shoumi Banerjee, you and your team have done an excellent job. This is Dilip Pal Memorial Young Scientist Award. Professor Dilip Pal was urologist, professor of urology at IPG-MER. He liked all the medical students, including UG, PG, and postdoc. Everybody must do research. But Dr. Shoumi Banerjee is the team member of a research team. She had here told her experience, so again a big clap for her. Now I am standing.
And this is a so important topic, and I have seen very low attendance for the postgraduate student, and all postgraduate students must know this topic across all branches. It is not specific to one branch, all branches.
All branches, yes, everybody. I now request most vibrant chairperson scientific committee, Professor P.S. Kormokar, to present her with the medal named in the Dr. Dilip Kumar Pal. Yeah. A photograph. Yeah. Take this photograph. Name Shoumi Banerjee name is written there in the middle.
It's my proud privilege to offer the medallion to Dr. Shoumi Banerjee. She has been rewarded for a noble blood group. So we are really proud of her work. Dr. Bed, please come on the dais. So as Dr. Uttam Pal was telling, that these sort of researches are to be spread among our young budding physicians as well as other doctors from different disciplines. Okay, thank you.
Yeah.
Thank you very much, ma'am.
We shall now proceed to the next session of the day, that is panel discussion on the topic hyperuricemia. I respectfully call upon the Honorable Chairperson, Dr. P.S. Karmakar sir, Professor.
The moderator of this session, Dr. Pradyut Sinamapatra, is busy in judging the poster session. So better to go to the program of our next oration, late Punam Chand Bed. May we start? If Dr. Vijay Kumar is ready, we can prepare. As you were wanting that. Luck is with you.
We now move into the another engaging and insightful scientific session titled Oration Late Poonam Chandra Bed. I respectfully call upon the Honorable Chairperson, Dr. Professor U.K. Paulso, HOD, Department of General Medicine, MGM Medical College, and Dr. Professor M.L. Jain. Dr. Professor Atul Besa, Professor, Department of General Medicine, MGM Medical College, and Kishanganj. To please come upon the dais and lead the proceeding.
So, good afternoon, everybody. So, I call upon Dr. Vijay Kumar, Additional Professor, Department of Medicine, AIMS, in this oration program. So, this oration is late Shri Poonam Chand Baid oration. And it will be done by Dr. Vijay Kumar, Additional Professor, Department of Medicine. And it's a strange coincidence that I am a chairperson in the oration felicitating Dr. Vijay Kumar, and it is named after my own grandfather.
Yeah. Thank you, Chairpersons.
Yeah, and he'll be felicitated by Professor Uttam Paul, sir. And Professor P.S. Karmakar, sir. Professor P.S. Karmakar, sir, please be on the stage to felicitate Dr. Vijay Kumar.
So thank you, Chairpersons. At the outset, I would like to thank the whole organizing team led by Professor Karmakar sir and Professor Atul Baid for inviting me and for giving me this opportunity for this prestigious oration. I am really overwhelmed and thankful to you. In next 15 to 20 minutes, I shall be discussing the advantage or the role of GLP-1 receptor agonist beyond glycemic control. Now today in the era of diabetes and obesity, we call it diabesity, we are more concerned, or rather there is a paradigm shift from glucose-centric approach to weight management control regarding the management of diabetes. So in next 15 to 20 minutes, I shall be discussing the advantages or the beneficial effects of GLP-1 receptor agonist beyond glycemic control. You can see the sequence of events. As we all know that diabetes is a chronic and progressive disease, and it usually starts before the onset of classical symptoms of diabetes. Usually the impaired glucose tolerance or glucose or insulin resistance usually starts years before the development of symptoms or the development of manifestation of overt diabetes. Then in due course, sometimes at the onset of diabetes, diagnosis of diabetes, usually some sort of microvascular and macrovascular complications are usually established. So it is a chronic and progressive disease characterized by progressive loss of insulin secretion, and as beta cells fail, both postprandial and fasting glucose control deteriorate. Fasting glucose usually deteriorates late, and postprandial glucose usually deteriorates earlier. So thereafter, the incretin effect also usually starts diminishing, and that is the main target for our incretin mimetics or incretin-based therapies. This is the popular octet, ominous octet of diabetes for pathophysiology of diabetes. That is impaired insulin secretion, increased hepatic glucose production, impaired appetite regulation, decreased glucose uptake, increased glucagon secretion, of course the decreased incretin effect during the course of time, increased lipolysis and increased glucose reabsorption. So we are targeting our therapies based on this ominous octet. How we target? Like for impaired insulin secretion, we have in our armamentarium GLP-1 receptor agonist, then glitazones, DPP-4 inhibitors, and sulfonylureas. For increased hepatic glucose production, we have in our armamentarium again metformins, glitazones, and DPP-4 inhibitors besides GLP-1 receptor agonist. So you can see that almost all the octet are being addressed by GLP-1 receptor agonist moreover. So as we all know that it is a health care problem of mammoth proportion, you can see that out of 536 million diabetic across the globe, we are having around 20% in our country, around 101 million. So similarly, out of the 464 million pre-diabetic, around 20% we are having in our country. So obesity, pre-diabetes and type 2 diabetes are a disease continuum usually. Usually in the due course of time, the earlier there is a insulin resistance, sensitivity decreases, resistance increases, beta cell function, usually it gets diminished, and then after insulin resistance, the overt symptoms of diabetes usually appears. So we can see that in due course of time, beta cell failure is there, and the postprandial, followed by fasting glucose starts rising after the beta cell failure. Earlier, there is a hypersecretion of insulin to overcome the insulin resistance. Later on, due to beta cell failure, there is decreased insulin and development of type 2 diabetes. So out of 10, 8 people living with diabetes are usually obese or overweight. And in India also, we are not an exception. 1 out of 3 Indians who are having diabetes are usually obese or overweight. So importance of weight reduction in type 2 diabetes is very imperative, and it improves insulin sensitivity and preserves beta cell function. To achieve beneficial effects on glycemic control, 5% weight loss may be required, and for each kg of weight loss, there is a 0.1 point reduction in HbA1c. So that is the magic of weight reduction in the management of type 2 diabetes. So to improve the management of type 2 diabetes and its complication, we have to apply the multifactorial approach like glycemic control, lifestyle modification, diet and exercise for weight management, blood pressure lowering by ACE inhibitors or ARB, whichever is preferable in the situation, and of course dyslipidemia control is usually also required, and these are the ADA recommendations for the target. Now, only glucocentric approach is usually not enough, because the age of 360-degree care requires a therapy with cardiometabolic approach and with complete metabolic care. So as the ADA 2022 guideline, reinforcing weight and CV-centric approach in type 2 diabetes is usually required, and the evidence of to ensure the strategies, we have to lower the BP, lipid lowering, antithrombotic agents, smoking cessation, besides CV risk factor screening and surveillance are usually required. And these are the evidence of benefits of weight loss. You can see that we have, based on different therapy, we can rather prevent diabetes or we can remit diabetes. So the GLP-1 therapy, it has a definite mechanism of action, but it has multifaceted advantages, multifaceted approach in the management of diabetes. Needless to repeat or needless to emphasize that GLP-1 is a peptide comprised of 31 amino acids. It is a member of incretin family, secreted predominantly from the L cell in the gut, but also from the brain, and released following food intake to regulate the glucose levels. Its invention is quite interesting. Gila monster, a species of venomous lizard, it usually eats only 4 times a year. And when fasting, it shuts down the pancreas, stopping its insulin secretion. When it's time to eat, it restarts pancreas with exendin 4 in its saliva. And exenatide is the synthetic version of this exendin 4 derived from the saliva of this venomous Gila monster. Structure and function, structure and source of origin we have discussed. There are so many GLP-1 based therapies or exendin based therapies, but we have to emphasize on dulaglutide or albiglutide because they have intermediate duration of action. Some are having small duration of action and some are having long half-life also. But the importance is that GLP-1 like peptide 1 receptors in the brain, they control food intake and body weight also. But those GLP-1 receptor agonists with large molecular size, they usually do not cross the blood-brain barrier and may not access satiety center, thus show less weight benefit in clinical studies. So we have to think whether short-acting or long-acting GLP-1 receptor agonists are required, but usually dulaglutide, semaglutide, liraglutide, they are the preferred option for weight reduction because they usually do not cross the molecule with large molecular size, they usually do not cross the blood-brain barrier and thus may not access the satiety centers. So a smaller molecule size GLP-1 receptor agonist gain access to the area, and from there activation of area sends projection to other part of the brain, offering more weight benefits. This is a, so in overview of the most prominent GLP-1 mechanism, glucose dependent increased insulin and lowered glucagon, almost gastric emptying, lowering of body weight, and there are so many cardiovascular risk reductions. So the incretin effect diminishes over time in people with type 2 diabetes, and this is how usually it diminishes, and that's why the GLP-1 receptor agonists are usually required, and type 2 diabetes progresses over time, leading to insulin resistance and undesirable effects in multiple organs. So these are the several parts where GLP-1 secretion and receptor expression is there. In L cells of the gut, neurons in the hindbrain. They are also expressed in lung, heart, pancreas, kidney, and GI tract. The synthesis release metabolism usually after ingestion of food, GI tract, they usually release the gut hormone incretins. They are usually degraded by DPP-4 and rapidly inactivated to GLP-1. That's why we usually either advise DPP-4 inhibitors or receptor 1 agonists. So GLP-1 usually they reduce the appetite and craving, improve control of eating, reduce energy intake, and of course reduce body weight. So it has multiple positive effects on the beta cell. Besides the reduction in insulin resistance, they have also effects on beta cell apoptosis. So effective option for holistic approach in type 2 diabetes management, we can see out of all the options, GLP-1 receptor agonist, they have the high efficacy for reduction in HbA1c. They have low hypoglycemia risk. They are very high effective in weight reduction. And of course, the cardiovascular benefits are more. So out of these, all the available options, GLP-1 receptor agonist is quite selective for all the desirable effects in terms of efficacy as far as HbA1 reduction is concerned, in terms of hypoglycemia risk, in terms of weight effect, or in terms of cardiovascular benefit. They have also the proven benefit in different trials. It has been observed that they have definite cardiovascular benefits. So out of 8 core defects or out of 8 ominous octet, GLP-1 receptor agonist targets usually 6 out of the 8. So besides that, there are exceptional cardiovascular benefits of GLP-1 receptor agonists, not only in the disease of pipes, but in the disease of pumps also. They have direct and indirect action on heart and blood vessels. They increase vasodilation, plaque stability, and increase the blood flow across the coronary circulation. The cardiometabolic effects of GLP-1 receptor agonists are innumerable. They usually affect on multiple organs, on pancreas, heart, brain, stomach, and liver. And several meta-analyses of different trials of GLP-1 receptor agonists, they have shown decreased reduction of major adverse cardiac events. They decrease the risk of myocardial infarction. They decrease the risk of a stroke. They decrease the risk of death from CV causes. They decrease the risk of hospitalization due to heart failure. And they decrease the risk of adverse kidney outcomes. Mechanism of CV benefits are multifactorial. We are not going into the detail. And the cardiovascular outcome trials from type 2 diabetes therapy, they have also shown 3-point major adverse cardiac event reduction. So GLP-1 has multifactorial or multi-step reduction in major adverse cardiac events. They have also renoprotective benefits due to various mechanisms. They directly affect, they have anti-inflammatory effect, reduce usually oxidative stress, hemodynamic effects, inhibition of rash, and increased natriuresis. They have demonstrated efficacy in A1C reduction. The variety or the gamuts of trials in favor of a GLP-1 receptor agonist, they have demonstrated efficacy in HbA1c reduction. They have demonstrated efficacy in weight reduction based on different trials, be it Alexa, be it Leader, Sustain, Excel, and different trials are usually going on. GLP-1 therapy reduce the A1C. All the GLP-1 receptor agonists, they, depending on their effects, they usually reduce the A1C, they reduce the body weight, and time to first event analysis of a stroke and its subtypes. In different trials, it has been shown beneficial in reduction of stroke events as well. Now, as per the latest guideline of ADA 2023, as GLP-1 receptor agonist is usually affecting out of 8 ominous octet, they are usually beneficial on 6. So ADA 2023, they have also emphasized the role of GLP-1 receptor agonist on the management of diabetes for efficacy of weight loss, and particularly in persons with comorbidity like heart failure, CKD, or other cardiac comorbidities. So in people with heart failure, CKD, established CVD, or multiple risk factors for cardiovascular disease, the decision to use a GLP-1 receptor agonist or SGLT2 inhibitors with proven benefit should be independent of background use of metformin. That is the recommendation of ADA 2023. So when choosing glucose-lowering therapies, we should choose regimen with very high to very high dual weight and glucose-lowering options. Semaglutide is one of them. The ESC guidelines also favors for the management of cardiovascular disease in diabetes, and they usually advocates the use of GLP-1 receptor agonist. So in patients with diabetes and atherosclerotic cardiovascular disease, treatment with GLP-1 receptor agonist and or SGLT2 inhibitors are recommended to reduce CV risk independent of glucose control and in addition to standard of care. Various international and local guidelines have changed their response to recent data from newer drugs, and we are now moving with a paradigm shift from glucocentric approach to personalized and CV risk focused approach. So this is the upstream of the approach. We have to be weight centric, we have to be glucose centric, and opportunity lies in the intervening upstream to address the key pathological drivers. So these are the innovations in GLP-1. Now we are having dual agonists, and turning point from, we are changing from liraglutide to semaglutide, with these two molecules leading and pioneering the projects in the GLP-1 portfolio. And this is the development of liraglutide and semaglutide. The most recent innovation is, of course, semaglutide. So in summary, we can say that the expanding landscape of GLP-1 receptor agonist in different allied conditions is very beneficial, and the global and national burden of type 2 as it is increasing and is complicated by inadequate control and multiple comorbidities. So diabetes with high body weight is an emerging syndemic leading to adverse patient outcomes. Adopting an upstream approach towards weight management in type 2 diabetes can lead to multiple clinical benefits, and GLP-1 receptor agonists fit into the current treatment guidelines with superior A1C reduction, clinically relevant weight loss through appetite suppression, proven cardiovascular benefits, and providing the option of tight cardiometabolic risk factor control early in the course of treatment. Thank you for patience hearing.
Thank you, Dr. Bijoy Kumar, Additional Professor, All India Institute of Medical Science, Patna, for your lucid and excellent speech. Now, I am requesting Secretary Scientific Committee, Dr. Professor Dibmala Das, for presenting the medal for this late Poonam Chand Boyd Memorial Oration. Yes, sir. Boyd, sir, come. Yeah. Sunita, you announce.
Thank you so much, sir. With this, we now break for lunch. Kindly enjoy the meal and please remember to return to this hall as the scientific program will continue further with more engaging and academically stimulating sessions. Thank you so much.
Sir, please come to this room after lunch as early as possible. We will try to finish within time or before time. If you cooperate
And the panelists for this session will be Dr. P.S. Karmakar, who is a professor in Department of General Medicine, Mataguji Memorial Medical College, Dr. Atul Baid, who is also a professor of Department of General Medicine, Mataguji Medical College, and Dr. Gautam Bhattacharya, who is the HOD and professor of Department of Orthopedics, MGM, and Dr. Rishabh Mukherjee, who is assistant professor of General Medicine, AIMS, Kalyani, West Bengal.
So good afternoon. Looking at the audience, I think everybody is busy, either having the lunch or having the mid-afternoon nap. Good for that. And gout actually is associated with meals, and there are a lot of myths and misconceptions around it. So I've got 4 wonderful panelists with me, and we will just breeze through some of the aspects of gout, the practical aspects. So I'll start with Dr. Atul Baid. How does gout present?
Right. So good afternoon, everybody. Good afternoon, sir. So regarding the presentation of gout, I'll keep it purely clinical and physician's OPD based. So it can present in 2 ways. The first way in which it can present is an acute gouty attack or acute gouty arthritis, as we call it. The classical presentation is seen in a middle-aged man, almost invariably, and it will present as an acute onset monoarthritis that will typically involve the first metatarsophalangeal joint, or podagra as we call it in day-to-day terms. And it is exquisitely severe. Within 24 hours, the pain reaches its maximal intensity. And when we examine the affected joint, it is red, swollen, and tender. And so there is a red flag that many a times it can be confused as septic arthritis, or a septic arthritis can be confused as a gouty arthritis. So in the initial stages, this acute monoarthritis is recurrent, and between the attacks, the patient may be clinically asymptomatic. And when the disease progresses, it can move on to become either oligoarthritis or polyarticular arthritis. So that is the acute form. In chronic form, like chronic tophaceous gout, as we may call it, there is deposition of the sodium urate MSU crystals, monosodium urate crystals called tophi, and the typical sites where it gets deposited is the olecranon or the pinna, even over the Achilles tendon. And concomitantly, because of hyperuricemia, the patients may be having either a uric acid nephropathy or urolithiasis. So that's how it presents.
That's right. So most of the time, the clinician is presented with an acute attack, and rightly pointed out that it's usually a monoarthritis. Does it really occur in young ladies and children? Dr. Rishabh, can you just have your opinion? I mean, we have seen asking for uric acid reports even in middle-aged ladies and children, thinking that any arthritis is gout. How common is that?
Predominantly, it is not very common to encounter it in women of reproductive age group and in children, because reproductive age group women, they have high levels of estrogen in their body, which is typically urocosturic, and it tends to naturally reduce the levels of uric acid in the body. However, if children are getting affected with hyperuricemia, then it is secondary causes and genetic defects have to be ruled out until and unless proven otherwise. So we can divide it into forms where there is excessive production of urate. It could be due to myeloproliferative neoplasms, lymphoproliferative disorders in young children. It could be due to rare monogenic defects, X-linked disorders like Lesch-Nahan syndrome. where is deficiency in the enzymes. Along with that, there could be deficiency in glucose 6-phosphatase enzymes. Along with that, drugs. Drugs like very commonly used thiazide diuretics, sometimes drugs like cyclosporine, tacrolimus, low dose aspirin. These are some of the offending agents that we have to rule out.
Right. So you mean to say that it's quite uncommon in young ladies, premenopausal ladies, as well as in children. And if we ever find hyperuricemia in a lady, we should think about a secondary causes, most commonly either metabolic, drugs, or kidney disease.
Chronic kidney disease.
And in a child, you have appropriately pointed out that most of it is genetic, and that's quite rare. And they have other presentations as well. I mean, Lashnehan would not just present with a hyperuricemia, with all those self-mutilation and etc. So most often, although it is asked for a test of uric acid in young ladies and children, it is not warranted for. Coming on to the next point, that do we really diagnose gout clinically or otherwise? Professor Kormokar?
Good afternoon, everybody. So there, as moderator already started with, there are so many myths are there, and he will touch upon only the practical points on hyperuricemia. So far, diagnosis of gout is concerned. So this diagnosis is clinical, not at all biochemical. So sometimes we do make mistakes, from all disciplines. So we do make, except the rheumatologist. So we do make mistake, all disciplines. Whenever we see that there is hyperuricemia, and if we found even above, highest limit is 7 in male, and it is 7.5, coming around 7.5 and 8, we start therapy. So thinking or making patient panicky that he will develop gout, so you should start, anti-hyperuricemic agent. So that is not the fact. So gout is always a clinical diagnosis, and that Dr. Bed has already explained to you. So always bank upon the clinical history, whether it is monoarticular acute arthritis or not, whether there is any nephrolysis, something like that. Otherwise, gout is not a biochemical diagnosis. You can say it is asymptomatic hyperuricemia.
So you mean to say that a high uric acid doesn't mean gout? And
is not equivalent to gout.
Is not equivalent to gout. And I think you also mean to say that in an acute gout, you might get the uric acid, which is quite normal.
Yeah, absolutely. Absolutely.
So in both ways, gout and hyperuricemia are not synonymous.
Yeah.
And I think you would agree with me that the gold standard of diagnosis is crystal deposition. And people would ask for a synovial fluid aspiration. And who else than Dr. Bhattacharya would address the issue? But do we really require a synovial fluid aspiration for uric acid crystal or something else?
Actually, aspiration of synovial fluid is not always necessary, as you see in podagra, where from you will take the fluid. There is no fluid there.
Right.
So when it is something, a bigger joint like ankle or knee, which are less commonly affected, but affected. Any joint may be affected in gout. But the thing is that the subject was hyperuricemia. Hyperuricemia is not synonymous with gout, because almost 25% of normal people have hyperuricemia, because probably of Western style of living, eating meat products, eating drinks, taking drinks, and your dietary mishabits. And your, even in children, if they take fructose-rich drinks and high sugar drinks, colas, etc., they have hyperuricemia. Obesity and hyperuricemia, these are the two sins that are common nowadays in children, and those are because of the food habits. So hyperuricemia is different from gout.
No, sir, what I mean to say, when actually you need a synovial fluid aspiration for gout?
I am coming to that. Actually, when you get the synovial fluid and you suspect that there is some differential diagnosis, no, knee swelling may be some other reasons also. Podagra is, everybody knows that it is due to acute gout. But knee swelling may be due to some other, septic arthritis is one of them. So you need to examine the synovial fluid. And on examination of the synovial fluid, you will find it is cloudy, yellowish. It is more cloudy and more yellowish in case of septic arthritis. There is rise of your number of neutrophils, but not as high as septic arthritis. And best part, if you get the uric acid crystals it is negatively birefringent on polarized light microscopy. I have not seen this thing. I have not heard anybody to have seen this thing, because two different light beam coming from two different 90-degree direction, and there are two rays of light, one advanced ray and one ordinary ray, and one gives yellowish tinge and one gives bluish, giving a birefringent appearance. So negative, if it is negatively birefringent, it is definitely gouty, or it is your uric acid crystal. But if it is positively birefringent, then it is calcium pyrophosphate crystal, which is called pseudogout. This is like that.
That's right. So practically speaking, a synovial fluid aspiration for a uric acid crystal is not done, 95% to 99%. And everybody would agree, practically no one has done it. We have done it for few patients. We have a polarizer microscope in our department. But then it's more of academic interest rather than practical diagnosis in most of the situations. And the synovial fluid is mostly necessary to exclude, as both of the panelists have said, Dr. Vaid and Dr. Bhattacharya, to exclude infection. Because at times, if it is not podagra, if it is a large joint like an ankle or a knee, you might be confused. The patient is febrile, it's red, hot, tender, swollen joint. So it's mostly to exclude synovial infections. Coming on to the treatment of gout, can Dr. Vaid just elaborate a little bit on how do we approach treating a patient of gout?
An acute gout?
No, start with a chronic gout. In the long term, the therapies that we...
Okay, so in long term, the treatment is actually pharmacological. We have to
Actually, why I started with long term is that that's the area in which most of the physicians are interested. Whether to continue, which drug, and that's why.
So it's mainly pharmacological. We have to start, apart from the non-pharmacological, that is, we have to restrict the purine-containing diet, and if there is a concomitant metabolic syndrome, we have to treat that. Lifestyle modification. Weight reduction is very, very important in chronic cases, because even 5 to 10% of weight loss can actually also decrease uric acid levels. Coming to the pharmacological treatment, right now we have two options: allopurinol, traditionally used, and other, which is now the newcomer in the armamentarium of hyperuricemia, that is febuxostat. Between allopurinol and febuxostat, I would personally go with allopurinol. The primary reason being its cost and easy availability. So start with allopurinol, start with a lower dose, then go to a higher dose. And febuxostat I would reserve for only those patients either who are intolerant to allopurinol or who develop an allopurinol hypersensitivity syndrome. It is classically associated with hypersensitivity. Or if the patient does not reach the target uric acid level with the standard dose of, highest tolerable dose of, highest tolerated dose of allopurinol. And that's when we start febuxostat.
Absolutely correct. Although I think febuxostat is most commonly used in today's time, not based on evidence, but based on convenience and familiarity. We do not object that, but practically speaking, allopurinol still now, as per the guidelines, is the first drug to use. There is definitely a chance of hypersensitivity. I would like to know from all four panelists, how many hypersensitivity cases have you encountered with allopurinol?
Never.
Never. Dr. Bhattacharya, sir? Right, right, okay.
I didn't see. I have not experienced allopurinol.
And I believe all of you have started with low dose allopurinol. Any one of you just wanted to do a genetic testing for HLA-B01?
Routinely not, sir.
5.8.
For allopurinol hypersensitivity?
Yeah.
Routinely not, sir.
Routinely not. Yeah, that's not recommended because that's only recommended in the ethnic group of Hans Chinese. So for all of us, routine testing for HLA-B58 is not recommended. And the chance of hypersensitivity is always there, just as it is for any other drug, which is the area in which allopurinol is actually preferred. Dr. Vaid, any comorbidity in which allopurinol you would prefer?
The patients, I think, with renal impairment?
Cardiovascular.
Cardiovascular, okay. Because
in renal, you might actually choose more of febuxostat.
Febuxostat, correct.
It causes more cardiovascular problem than allopurinol.
Exactly.
Allopurinol is preferred even in renal, not in renal failure exactly, but both febuxostat and allopurinol can be given in renal compromised patients. But febuxostat is certainly causes cardiovascular problem. In 37% cases are recorded.
And still now the textbook teaching is the first molecule is allopurinol so far anti-hyperuricemic agent is concerned. Febuxostat is definitely a good molecule if patients do have some renal compromisation.
That's right. Even in sir, just one. Even in patients with renal failure, allopurinol is safe up to CKD3. The patient should be started at a lower dose, maybe even at 50. So 1 tablet alternate day, and gradually titrate. So it's not contraindicated in renal failure. But febuxostat would be an easier option, and that's what we all people do. Dr. Rishabh, sir was asking some questions.
Actually, I'm a dermatologist. Actually, I want to tell that allopurinol hypersensitivity is not rare. Because as you are prescribing, we are getting the cases. That is the problem. Sometimes we are not correlating between us. And this usually appears after 6 to 8 weeks. That's why sometimes the diagnosis is missed. Most of the drug allergy are immediate. But this drug hypersensitivity syndrome is totally peculiar. And it comes after 6 to 8 weeks. That's why the diagnosis is missed. So any patient on allopurinol getting fever, having arthralgia, or having skin rash should immediately stop the drug because it's sometimes to be life-threatening. We get lots of cases, eosinophilia, that is called DRESS. Drug hypersensitivity and with eosinophilia. Sometimes may not get eosinophilia. So we should keep watchful.
Absolutely.
Prescribing, this is where we dermatologists are definitely seeing such cases, not frequently, but we are seeing definitely.
Absolutely, sir. Point absolutely well taken, and this has to be told to the patient. Just as we do for sulfasalazine. We do the same thing for sulfasalazine, and people are not afraid of using sulfasalazine in any case of arthritis. But the same thing happens, and as it is aptly pointed out, it's not immediate. It might be delayed for 6 to 8 weeks. Mostly it is delayed. Yes.
Whatever he has said, absolutely right. And majority of anti-hyperuricemic agent allopurinol, when we are putting, majority of them didn't have an indication for that molecule.
That's right.
And whenever they are coming with hypersensitivity to them, they are stopping that, and they, when they know that this molecule could be the one of the culprit molecules, they stop it, and they don't have any gout, so they don't come back to us.
They rightly stop it. They rightly stop it.
They rightly stop it, and they don't have it. These patients, those who develop delayed hypersensitivity, they have usually underlying HHV6 infection. That infection leads to this drug hypersensitivity, especially this allopurinol. So
Yes.
we are not always aware which patient have, so we should be always watching.
Absolutely, absolutely. Dr. Rishabh, how do you titrate the drugs, either of the drugs? What is the target? How do you go with in the long term?
So across all the guidelines, whether it's a BSR or the ACR guidelines, the overarching principles for management of hyperuricemia will be to start slow and to start at lower doses. And along with that, the dose titration has to be done as per the calculated serum urate levels. So the idea is most of the guidelines, they suggest that to keep the serum urate levels below 6, and the BS, the British Society of Rheumatology, typically goes for a much stricter correction to less than 5 milligram per DL, and it is warranted in those patients who are experiencing greater number of flares and have tophaceous gout, and have a poor overall quality of life.
That's right. So for tophaceous gout, the recommendation had been that keep it below 5, although the recent guideline says that keep it below 6 for all.
Yes.
But please let us remember that tophaceous gout patients actually take a longer term, and even after getting down the uric acid level below 6, one should not immediately venture in just reducing the drug dosage.
Yes,
the patient would, because there is a high urate pool inside the body.
So regarding stoppage of the drug, regarding the dose titration, which was the initial question, the dosages, the drugs, they have to be started slow, and then after every 2 to 4 weeks, depending on the serum urate levels, the initial level has to be titrated by making small increments.
So you mean to say it is not the drug dose which is important, it is the target serum urate which is important. So a patient might require a 200 milligram of allopurinol or a 400 milligram of allopurinol,
yes.
that doesn't matter. The thing that should be taken in care is the uric acid level below 6 at whatever dose.
And once it has stabilized, then you can go for every biannual testing.
Can you stop it?
Generally, it is not recommended to stop once if the diagnosis has been correctly made. It is not recommended to stop the uric acid
Right,
leakage.
because it's a metabolic error.
Yes.
It's not corrected. Yes. And that is a mistake. Most of the times it is being made. Stopped and then having a flare, then restart, again given for 3 to 6 months and again stopped. That's how actually patients actually experiment by themselves.
May I
Yeah,
comment,
sure.
sir? So yes, that is the guideline. As per guideline, it should not be stopped. But if patient does have risk factors like obesity, sedentary habits and everything, that time hyperuricemia is there. Though if patient can control of these things, central obesity, other metabolic syndrome related parameters, and if your medicine has brought it down to 4 or something like that, we can try for some drug holiday under close observation, whether it is going again above 6 or not. I think so. That could be done clinically. So what is your take, sir?
Professor Kormukar has wonderfully chosen a word of drug holiday, not drug stoppage. Thank you very much for this wording. It's exactly called a drug holiday. So patients who are doing well, so they may be rewarded with a drug holiday for some period of time, maybe months, maybe years. The statement by itself means that the drug needs to be started again once the uric acid level starts shooting up.
Sir, the issue with a drug holiday in certain studies it has shown that whenever the flare up recurs, it becomes much more difficult, and there is an underlying silent destruction of the bones and cartilages.
Absolutely, absolutely. So in most of the patients, the drug needs to be continued, maybe at a lower dose in which the urate is below 6. Dr. Kormukar, can you give some advice on the diet? Because that's a much overhyped area. Both you and Gautam sir.
Yeah. So regarding diet, I really get astonished about the belief of patients as well as some of the doctors. Misconception prevails among the doctors, some of the doctors of course, and among the, general population at large. It's really astonishing. So whenever patient has come to us, majority of us have experienced that, sir, as I am having hyperuricemia or I am on anti-hyperuricemia agent, I don't take tomato, legumes, red lentils, lady's finger, and many blah, blah, blah. So this way they continue, they stop all these foods which we really need for our proper nutrition. So to cut short my story, so what are the foods that should not be taken? Just divide it into 3 classifications. One is your red meat and organ meat, that is liver, brain, kidney, red meat, that is the first. Second is your sea fish, and third is your in relation to some liquids. That liquid is liquor, beer is more than whiskey, whiskey is more than wine. That way they produce hyperuricemia, liable to produce hyperuricemia. And third class of liquid is fructose rich, that Dr. Gautam Bhattacharya has already, fructose, corn syrup, rich any cold beverages. These are the things. In moderation, you can take cauliflower, mushroom, and your broad beans, something like that. In moderation, you can jolly well take. They are not going to increase your uric acid level to that extent that you have to be very much cautious of.
Thank you.
Sir, I will just add one thing. He's perfectly has said everything. That the urine source outside from outside is only 1/3 of the total purine
Right, sir.
load, and 2/3 is endogenous.
Right, sir.
So diet is not very important, except that what he said that these things are better to be avoided, because
Right.
lifestyle is important.
Right, more of a genetic disease than a nature and nurture, so possibly
So,
nature.
allow me to raise a practical
Right.
consideration. Say we have a patient who is hypertensive and he's on a thiazide diuretic, and now comes not with with symptoms of hyperuricemia, but on routine testing the uric acid levels are elevated. Do we stop thiazide diuretics?
Your take.
We are treating patients with diuretics, not only the thiazide diuretics, some other thiazide-like diuretics. If patient does have hyperuricemia, or patient is likely to develop hyperuricemia in months to come, if you do think, so for clinical scenario of that patient is concerned, better to avoid diuretic, especially thiazide diuretic in that patient to reduce hypertension in the normal level.
Unless it is absolutely necessary
Absolutely
for some
indicated,
other
right.
reason. Absolutely. Loop diuretics also.
80% of cases of hyperuricemia.
No, actually, thiazide diuretics are co-prescribed. Most of the preparations of antihypertensives which are available in the market, they have some sort of loop diuretics in addition. And we love that. Regarding the last but one topic, asymptomatic hyperuricemia. Dr. Kormukar and Dr. Vaid.
So, asymptomatic hyperuricemia.
Should you treat or should you not? Asymptomatic hyperuricemia.
In special cases.
In special cases.
Say that if the patient has especially a cardiovascular morbidity, and if the patient has chronic kidney disease.
Okay.
That's when we treat asymptomatic hyperuricemia. Otherwise, I would not go for pharmacology.
Any other point from any of the panelists?
Sir, may I say something?
Yeah, sure.
Okay. So far hyperuricemia is concerned, out of all hyperuricemic prevalence, only 1 to 2% of hyperuricemic people will develop gout in long run or time to come. So 95 to 98% of patients, hyperuricemic patients, will not develop gout in their lifetime. So for that reason, as Dr. Bed has said, in some special proportion of patients, we may have to consider whether we will use that or not. One is that if hyperuricemia is greatly increased, that is above 13 in male, above 11 in 10 or 11 in female, their uric acid excretion through kidney is too high. So there is possibility of development of uric acid nephrolithiasis. So to prevent that thing, hyper excretion of uric acid through urine, in those cases, or if patient has kidney function to a great extent, that is also a little bit doubtful. So in that case, I think in that special case, we may
So you mean to say CAD, CVD, CKD?
CKD.
In these three situations, we might be at a
more,
lower level.
malignancy also.
That's a separate issue. That's a completely separate issue. I would not call that gout, but hyperuricemia only. Obviously, it is mostly symptomatic, and they have to be treated. Tumor lysis syndrome. And what else to do in asymptomatic hyperuricemia, Dr. Vaid and Dr. Rishabh?
Lifestyle modification.
Lifestyle modification.
One, and second is if one common belief which a patient will always come up with if you start discussing with about hyperuricemia with the patient, especially when it is asymptomatic, is he will say in last few days he has drank and ate a lot of meat.
Yeah.
So that's why there is hyperuricemia. So first of all, we have to make him understand that hyperuricemia is not merely an alcohol and a meat disease. We have to take this as an opportunity to evaluate him for especially metabolic syndrome, because it can be a strong constituent of the metabolic syndrome. We have to look at the lipids, we have to look at the fasting blood glucose, triglycerides, blood pressure, and treat metabolic syndrome if it qualifies to be a metabolic syndrome, and weight reduction is another important aspect of asymptomatic hyperuricemia.
I think Dr. Ved has mentioned it. Another thing which we should keep in mind is that pharmacotherapy in asymptomatic hyperuricemia is generally not required for prevention of urolithiasis. However, if on imaging we detect the presence of stones, in that case, they can be given some primary therapy, prophylactic therapy in the form of hydration and alkalinization of urine. For that purpose, we need to calculate a very simple, it can be done bedside. We need to calculate the fractional excretion of urate and to differentiate between under-secretors versus overproducers.
Yes.
So once that happens, and if we detect radiologically if there is any detection of stones, then we can give them, we can ask them for hydration therapy as well as alkalinization. There are some schools of thought which says that despite this therapy, if the patient is undergoing recurrent nephrolithiasis due to urate crystals, then those individuals may be offered urate lowering therapy. In special populations like I mentioned, those who are having those rare genetic disorders, in those individuals, usage of allopurinol is warranted, specifically in like Lesch-Nyhan syndrome.
Right, right. Sir, how commonly
We do not. It's mostly from children. It's in a pediatric population. It's an excellent.
No.
The milder forms generally they do tend to reach the adulthood, but the severe forms of this deficiency they do not move beyond adolescence.
Yeah, I think. Yeah, ma'am, exactly. And that's why we should not be bothered about all these syndromes in an adolescent and adult. So what we have learned for the last half an hour with wonderful discussion, I will just summarize in 5 minutes, one of the shortest presentations. So the first point is this: hyperuricemia is not equal to gout. Slide 1. Slide 2. Acute monoarticular attacks of lower extremities, rapid development of severe pain, swelling within 12 hours, especially with overlying skin erythema. The clinical diagnosis, as aptly pointed out by all of the panelists, is gout. The gold standard for diagnosis is crystal, but this is what gout is, in the joint and around the joint. Young lady and children, as aptly pointed out, don't have gout. They may have hyperuricemia. Please search for secondaries, like hematologic malignancy and CKD and drugs I have put in red, while psoriasis patients can have, because of the high cell turnover, they can have hyperuricemia. So that actually happens. Imaging is not always necessary. X-ray, a late picture with all those tophi and the overhanging edges. DECT, I have written gold is crystal. So silver is possibly USG, which we do. It's the double contour sign on USG, which is done. It's a good test. It's a sensitive and specific test. In fact, we have also done a paper which is published on it. And the platinum test would be DECT. So just like platinum is costlier than gold, so we are not going to do DECT unless it is absolutely a rare presentation. Urate lowering therapy should be started if there is more than equal to 1 tophi or the patient is having gouty attack more than 2. The treat to target is 6. So we would not remember all these levels, 5, 7, 7.5 or 6. It's 6 for all. And titrate the drugs to achieve this. I've written in ash color in down that check for drug interaction. That's extremely important in today's time. Very easily done. I do it on Medscape. You can do it on UpToDate or anything, any software, the apps. Allopurinol is the first recommended drug, as the panelists have already mentioned, and the dose they have aptly pointed out. Febuxostate an alternative, especially if there is hypersensitivity or there is renal disease. Asymptomatic hyperuricemia below 10 should not be treated, but should be searched for causes. Lay praise and media on diet is overhyped, so just avoid alcohol, sugary drinks, seafoods, and red meat. That's all. And please ask your patients to avoid fatty foods, because gout patients don't die of gout, they die of coronary artery disease. That has to be remembered. Acute gout, I think we could not finish in time. Acute gout should be treated with colchicine, NSAIDs, and prednisolone, depending on the age and the comorbidity. So in a young healthy adult, colchicine or NSAIDs. In an elderly, non-diabetic, maybe NSAIDs are not preferred, either steroid, short course, and plus minus colchicine. And please, last but not the least, take care of the comorbidities and concomitant medications, like switch hydrochlorothiazide to an alternative if it is possible, as it has been pointed out. Losartan would be preferred for hypertension control if it is a single drug only. Please do not stop low-dose aspirin if it is given for appropriate indication. So any patient of coronary artery disease on low-dose aspirin, although we know it can increase uric acid level, let us not stop it. And lastly, adding or switching to fenofibrate in hyperlipidemia is not recommended because of obvious reasons of drug interactions. Thank you very much. Let's treat gout responsibly. If we have time, we can take questions from the floor, or else we would close. So organizers, questions? Sir. Absolutely. Absolutely, sir. And that's why I put it there. We have seen many cases. They were actually psoriatic arthritis. They're being treated with management of gout. Any questions or any comments from anybody? Sir. Yes. All may have hyperuricemia. True. So thank you all the panelists. Thank you audience. Thank you very much. I hope my presentation was very short, really. Very informative and very nice. Very privileged.
Hello.
Thank you all our panelists and moderator for such an enlightening discussion. We now move toward the next segment of our today's presentation, which is case presentation, titled Clinical Approach to a Patient with Suspected Normal Pressure Hydrocephalus. I humbly request Honorable Chairperson for commencement of this case presentation session. Dr. Ashish Shah, sir, Professor and HOD, Department of General Medicine, from Jagannath Gupta Institute of Medical Sciences, Baj, and Dr. Anirban Chakravarti, sir, Professor and HOD, Department of Psychiatry from Mata Gujri Memorial Medical College and Lion Seva Kendra Hospital, Kishanganj, to come up on the stage and lead the proceedings.
This is the last but one session. Last but. So, I know, she was my PGT. She, Madhurima Ghosh, Mrs. Madhurima Ghosh, she passed from here. She was my PGT and she passed also through me. And now she is doing DNB in neurology in Apollo Clinicals, men. Now she is, well, sugar.
Thank you so much, sir. A very good afternoon to all of you. So topic for today is clinical approach to a patient with suspected normal pressure hydrocephalus. So starting with the case vignette. So a 83-year-old gentleman presented with complaints of gait imbalance, recent memory decline and new urinary incontinence. He had history of diabetes and hypertension. Examination showed a broad-based short-stepped gait, mild rigidity, and an MMSE of 16. Rest neurological examination was unremarkable. So we have gait, cognition, and bladder dysfunction. So the classic triad already coming into your focus. So coming to normal pressure hydrocephalus. So NPH is defined as ventriculomegaly with normal CSF pressure presenting with the Hakim-Adams triad. Importantly, it is one of the few causes of cognitive and gait impairment in the elderly that is potentially reversible. So coming to the types of NPH, so we classify NPH into idiopathic and secondary forms. Secondary cases follow SAH, trauma, meningitis. Idiopathic NPH progresses gradually and requires careful exclusion of mimics. So coming to the epidemiology, NPH affects around 0.2% of people ages 70 to 79, but as you can see, nearly 6% over age of 80. So it is actually a disease of elderly, and what happens, it is often overlooked because the symptoms overlap with aging and vascular disease. It's often misdiagnosed or underdiagnosed. So coming to the pathophysiology, I'll just sum up. The key issue here is impaired CSF absorption and altered CSF pulsatility, so leading to ventricular enlargement and periventricular ischemia. So simple formula, CSF misbehaves, ventricles enlarge, subcortical circuits malfunction. So wet, wacky, wobbly triad. NPH, so wet for urinary incontinence, wacky for reduced attention span, that is dementia, wobbly for ataxic gait, broad-based short step. I would just like to summarize this. So what happens when I describe the triad, that cognitive disorder, gait disorder, urinary dysfunction? So what are the other conditions where we can confuse with that? So cognitive disorder, definitely Alzheimer's disease, Parkinson's disease, vascular dementia, dementia with Lewy body, progressive supranuclear palsy, FTD. Then gait disorder, peripheral neuropathy can lead to gait disorder, osteoarthritis in hips and knees, myelopathy, drug-induced. So we have to rule out these conditions. And urinary dysfunction is very common, especially in elderly, in men BPH and in female pelvic floor weakness. So coming to the patient evaluation, so a clear history, a structured neurological examination, and supportive imaging followed by physiological confirmation with a CSF tap test is a gold standard. Most patients present with this triad, but not necessarily everyone presents with this triad. So what happens? Sometimes patients present with only isolated symptoms. So that's how it feels that a clinical puzzle where the pieces arrive out of sequence. So we don't know what to do. So gait impairment, the classical gait in NPH is described as magnetic gait or gait apraxia. So what happens? The patient says that my feet are glued to the ground. Steps become short, initiation is slow, and turning requires multiple steps. What we have to differentiate is, it is typically symmetrical, unlike Parkinsonism. Actually, this condition NPH is also called as like lower body Parkinsonism. But here what is happening, unlike Parkinsonism, here we have a symmetrical gait, a broad-based gait, and as we can see in this diagram, in Parkinson's disease, they have a narrow-based gait. And gait is very important because it is the earliest and the most reversible symptom. It is very shunt responsive. So gait assessment tools in NPH. So we have the 10-meter walk test, the INPH gait scale. We have the timed up and go test. I will show you the video. Then, so basically we are assessing the parts of the gait cycle, the stride length, the cadence, the step height, and number of steps.
So if a 20% improvement of or 20% improvement of gait is observed after CSF removal, so that means that this patient will be a very good candidate for shunt surgery. He might respond very well to shunt surgery. So one of the rare times in neurology where a single test can predict a future therapeutic win. So cognitive dysfunction. So the cognitive profile of NPH is more of frontal and subcortical. Patients become slow in processing, they lose their flexibility in thinking, they struggle with attention and often appear apathetic. This can easily be mistaken for depression or aging unless we actively look for it. Unlike primary dementia, here the memory loss is not the earliest feature or complaint. So coming to the cognitive testing. So I have mentioned here, so we do the digital span test for attention and working memory. We do the trail making A and B for processing speed. We do the Stroop test for executive control. We do the grooved pegboard for quantifying fine motor and psychomotor slowing. These tests also help document improvement after the TAP test, because we evaluate this also pre and post TAP, so which can be quite striking in some patients. So urinary dysfunction, basically it starts with the urinary urgency and then ultimately it can lead to incontinence due to, basically it is loss of central inhibitory pathways controlling the bladder. This is sometimes the symptom which family members notices, and it might be the only feature that the patient might come to the doctor. Early shunting improves bladder control in almost 80% of the cases. So the diagnostic criteria, we have probable NPH, and next slide I will tell possible NPH. Probable NPH, age more than 40, insidious onset, duration more than 3 to 6 months, gait disturbance is mandatory, along with plus cognitive or urinary dysfunction, and I will show in the subsequent slide. Evans index is very important, it is more than 0.3. Possible NPH, the criteria is, we classify patients as possible NPH when the onset is not unclear. When comorbidities create diagnostic ambiguity, there are a lot of vascular comorbidities are there, or when CSF opening pressure is not documented. The category still warrants further evaluation, especially when imaging is suggestive. So this is the brain imaging essential. CT or MRI is must. Ventriculomegaly must be present. There should not be any obstruction of CSF flow. We have to evaluate the Sylvian fissures and convexity very well and assess the white matter changes. I will come to that. As you can see, this is the normal ventricle. This is the NPH ventricle. Okay, so Evans index. So Evans index is basically we have to calculate the ratio of the frontal horn width with the highest diameter of the brain width. So that is more than 0.3, suggesting a ventriculomegaly. This is a very simple and reproducible test, useful screening marker, but it should only be measured in axial CT or MRI, as I have mentioned here. Dash pattern is very important. As you can see, we can see the Sylvian fissure, and it is disproportionate to the amount of atrophy. That is very important. So disproportionately enlarged subarachnoid spaces, widened Sylvian fissures, and as you can see in the contrast, the midline, the compressed high-tide, is called tight brain. The compressed high-tide convexity is there, but the Sylvian fissures are widened. So strongly suspicious of NPH. Other MRI features, I'll just quickly go through. Temporal horn enlargement. Here we can see this is called the callosal angle. In NPH, it is hyperacute, that is less than 90 degree. Here we can see dash. Here we can see periventricular oozing, which we might think it is ischemic changes. Because even ischemic changes look like this, hyperintense, but we have to carefully look into it based on the history and examination. So phase contrast MRI also we do. We basically measure the aqueductal CSF stroke volume. High flow correlates with shunt response. So this is the main thing what we do in our setup, what we do, that CSF tap test. So we have to basically remove at least 30 to 50 ml of CSF, and we have to reassess this gait and cognition after a few hours and again after 24 to 72 hours. A more than 10% improvement in TUG, timed up go test, I will show you, that is suggesting the patient is likely to benefit from shunting. ELD, it is not done, only reserved for cases where you have a very high suspicion of NPH, but tap test is negative. And these are also, they're not done regularly, ICP monitoring CSF infusion. So what is the management overview? Surgical treatment is preferred. The treatment is VP shunt. Acetazolamide doesn't have any role. We use programmable shunt these days. Shunt outcomes improvement in around 80% of the probable NPH. Actually, if the patient has underlying dementia, then it is mostly shunt and unresponsive, the patient will be. But gait improves very reliably. So coming back to my patient, this is the MRI finding of my patient. So as you can see, the ventricles are grossly enlarged. I told you the temporal horn is enlarged. If you calculate the Evans index, it is definitely more than 0.3. You can see dash here. Then periventricular oozing. Okay. Again, callosal angle I already described, that is hyperacute. So I'll just say the pre-tap and post-tap findings. So I have the video. So this is the pre-tap timed up and go test. Just quickly go through. If you can see, he's pretty slow. I'll come to the post-tap. We did 2 hours after the tapping. It's pretty fast. So I even have the duration. So the pre-tap TUG was done, and which was around 40 seconds in duration. Post-tap TUG was done, which was around 27 seconds in duration. Definitely it is more than 20% actually. So the pre-tap MOCA was also done. That was 19/30, and post-tap MOCA was 22/30. So conclusion, I just like to conclude that INPH is a treatable idiopathic non-operational hydrocephalus, is a treatable cause of gait disturbance. Diagnosis requires clinical plus imaging plus CSF test. TAP test remains the key predictor. Early intervention improves outcomes. Consider NPH in any elderly with gait decline. Thanks for listening. Thank you so much.
Thank you, Madhurima. Any question from PG, postgraduate students? They are only looking and taking photos. Any question? No. So, no question means you are not reading. Okay. They understood very well. Another point. Any question, Partho? Dr. B.K. Singh, any question? Okay, sir. Thank you, Madhurima.
Thank you so much.
Thank you, ma'am. We extend our heartfelt gratitude to our esteemed faculty speaker of the session for their insightful and enriching presentation. We also sincerely thank our honorable chairperson for his valuable time, guidance, and conducting the session with such an academic rigor. So, please collect your memento from the registration counter.
We now move into another session titled Cardio-Diabetic Insight. We kindly invite our distinguished chairperson for this session, Dr. M.L. Jain, Director, Dr. Jain's Maternity and Diagnostic Center, Kishanganj, Dr. Vandana Kumari, Associate Professor, Department of General Medicine, Mata Gujri Memorial Medical College, Dr. Upendra Kumar Yadav, Assistant Professor, Department of General Medicine, Mata Gujri Memorial Medical College.
So good afternoon, everybody. I know post-lunch session, it's very difficult to register anything, at least if it is related to academics. It's time for, but Suman. So we know this actually exposing one of the biggest blind spots in diabetic care. We focus on sugars, HbA1c, creatinine, lipids, but the one thing that predicts ulcers, amputations, morbidity, and finally the mortality, the feet in a diabetic, is often never examined. Today's session is about fixing this very gap because diabetic foot complications are common and catastrophic, but fortunately completely preventable if only we look at the feet. So before I begin, let me remind you of a powerful symbol we all have seen, or most of us, if we have ever had the opportunity to go to Switzerland, Geneva, this famous broken chair outside the United Nations office in Geneva. It stands tall on 3 legs with a 4th leg shattered, which is a global reminder of the human cost of landmines and preventable suffering. And this amputated foot you see on my slide is our own version of that broken chair. It's a silent reminder of preventable disability, not caused by war, not caused by bombs, but by something far more common, far more neglected, that is diabetes, and our collective failure to examine our feet. Let me now bring to you our own data from rural Bihar. This is a study we did last year, 205 patients we studied. 1/3 of these patients already had numbness. That means they already had an early neuropathy, but hardly anyone used a protective footwear. 88% of the patients were never counseled regarding appropriate footwear, and 91%, a staggering 91%, that means almost none of the patients ever had a foot exam. And these findings are compatible with studies across India. So why do we need to worry about the foot in diabetes? India already has 70 million diabetics, which will probably rise to 109 million by 2035. This is the data from ADA. That means right now we have 140 million feet to protect. And once a diabetic patient develops diabetic foot complications, the treatment cost of diabetes escalates to 4 times. And today's data is that every year in India, we lose around 40,000 legs every year due to diabetic foot complications. This is our reality. Almost every medicine OPD, the residents will very clearly relate to this. Busy OPDs, long queues, limited time, and in this rush, something very important silently gets ignored, the foot. Why do we need to evaluate foot of every diabetic? Half of all the diabetics develop foot problems, a quarter develop ulcers. Once they develop diabetic foot complications, the costs shoot 4 to 5 times. Amputations are common, disability is severe, and most importantly, people die from diabetic foot. Foot ulcers cause 85% of amputations in diabetics. After one amputation, half of these patients will get a serious lesion in the contralateral limb, and mortality after amputation is around 80% at 5 years, which is worse than many cancers. Now just look at this. This is an old data from Armstrong, where he compared 5-year mortality after in patients with diabetic foot ulcer and compared this with various cancers. The 5-year mortality of a diabetic foot ulcer is worse than breast cancer, worse than colon cancer. And if a patient develops an ischemic cancer, the mortality is higher than prostate cancer, breast cancer, Hodgkin's disease. So a big problem which cannot be ignored, it is actually the elephant in the room. We talk about big things, but it is the ordinary things, if done extraordinarily, become extraordinary. So now, this large multi-centered Indian study, it followed around 4,300 patients with neuropathic foot ulcers for almost 9 years. And this Kaplan-Meier, it very clearly shows the survival, a comparison of survival between 2 groups of people with diabetics, those with a neuropathic foot ulcer and those who were diabetic but they did not have a neuropathic ulcer. The green line, the top line, it represents the people with diabetes with no foot ulcer. The survival remains high and stable over time. The lower line, the blue line, is very different. These are the patients with neuropathic diabetic foot ulcers, and as you can see, survival steadily declines. This was another prospective South Indian study that looked at the mortality in 260 patients with Charcot's neuroarthropathy and compared them with over 500 matched diabetic controls, almost double the cases. The Kaplan-Meier curves clearly show that in patients with Charcot's have significantly poorer survival over time. And after adjusting for the baseline factors, Charcot's neuroarthropathy was associated with nearly threefold higher mortality with an odds ratio of 2.72 with strong statistical significance. So Charcot's, which occurs very commonly in diabetics, is not just a foot deformity, it is also a marker of systemic risk and increased mortality, not to be missed. But amongst all this gloom, amongst all this negative data regarding mortality, disability, how we miss, there is one silver lining. The diabetic foot is very clearly preventable. And prevention lies in early identification by examining the feet of the patient. Our eyes see, our hands feel, our ears hear only what we know. So knowing is very important. Whenever a patient with diabetes comes, these are the patients among diabetics we must watch very closely. Those with past ulcers, deformities, neuropathy, poor control, smoking, peripheral vascular disease, inappropriate footwear, and remember diabetic kidney disease. It's a very, very important cohort of diabetics where it is very important to look at the feet, especially the patients who are on dialysis. They are among the highest risk of developing amputation. So this study from South India shows patients with diabetic foot ulcer. So there were 4 groups of patients: the patients with type 2 diabetes without complications, the patients with chronic kidney disease but without foot ulcers, the patients only with diabetic foot ulcers, and the last group, the patients who were having CKD, were on dialysis and they developed foot ulcer. So it is very clearly seen that while eGFR in uncomplicated type 2 diabetes falls gradually, those with diabetic foot ulcer, especially when CKD is already present, show a steep downward trajectory. In short, a foot ulcer is not just a local problem, it signals systemic inflammation and predicts accelerated kidney deterioration. So it's a very interesting relationship between chronic kidney disease and diabetic foot ulcer. Chronic kidney disease is a risk factor for diabetic foot ulcer. If a patient with chronic kidney disease develops a diabetic foot ulcer, the eGFR decline gets accelerated. The aim of the foot examination is simple: identify who is normal, who is at risk, and who already has a neuropathy, ischemia, or lesions. A simple 3-minute foot exam in every visit, 1 minute to ask, 1 minute to look and feel, and 1 minute to classify, can prevent years of disability. So first of all, what to ask? Ask the basics: duration of diabetes, meticulously record them. Ask for the sugar control, look at the A1C, fasting, postprandial, past ulcers, history of any Charcot's, or any history of vascular symptoms. History of claudication is very important in patients with diabetes, and other complications like kidney or eye disease. History of retinopathy is very important in patients with diabetes. Now on inspection, look for swelling, redness, callus, nail changes, fungal infection, ulcers, deformities like claw toes or Charcot's. Now look at this. This is a normal foot. God has given us beautiful plantar arches, medial longitudinal arches that distributes pressure evenly. Now what happens in pes planus that occurs due to neuropathy in diabetes? The arch collapses, causing the entire sole to touch the ground, increasing pressure points, and then there is a risk of ulceration in diabetics. Never ignore any deformity, because every deformity means abnormal pressure, and abnormal pressure means ulcers, and ulcers means amputation, and amputations means early death. Hallux valgus, if present in a diabetic, it will shift the big toe laterally, causing pressure on medial bunion, on the medial bunion. Hallux rigidus is a stiff arthritic first metatarsophalangeal joint, leading to altered gait and forefoot overload. Charcot foot is the most destructive, neuropathic collapse of the midfoot, leading to a rocker bottom, typical rocker bottom deformity you can see here. Specifically look at the areas that are risk. Ulcers occur exactly where pressure concentrates. Identify these zones early. Never forget to examine the footwear of the patient. Educate the patient regarding a proper footwear and examine the patient's footwear itself, because there have been studies where an inappropriate footwear itself was the cause of an ulcer. Look at the footwear, check if it is worn out, too tight, narrow, or has a low toe box. Put your hands inside the shoe and inspect the insole. Also look at the outsole and strongly discourage Hawaii chappals. So these are typical examples of an inappropriate footwear: too tight, too loose, wrong shape, wrong support, no insole, and you can see a Punjabi juti with a nail popping out, which the patient will not know because of the insensate focus. You can see the patient having hallux valgus, still using a slipper with a toe support. A shoe that's too tight compresses the forefoot, increases pressure over the metatarsal heads, and invites callus and ulcers. A shoe that's too loose allows the foot to slide forward with every step, causing shear forces and friction blisters. So the right feet supports the heel, gives space for the toes, and distributes pressure evenly. In a diabetic patient, footwear is not a fashion, it's a therapy. Always take a moment to explain the science of footwear. Explain the patient the science of exercise, the science of diabetes. Exercise किया करो, इतनी किया करो, 150 मिनट हर हफ्ते चला करो, क्यों चला करें ये भी बताना ज़रूरी है. So take a moment to explain the science of footwear to the patient. Explain them about the pressure redistribution and tell them that normal shoes is equal to pressure concentrated, and that imposes a risk for ulcer. When there are therapeutic shoes with proper offloading, pressure gets redistributed and the feet are protected. On palpation, check pressure points, temperature, temperature differences, edema, joint stiffness, pulses, and whether an ulcer reaches a bone. A simple probe to bone test done at the bedside can identify osteomyelitis at a very early stage. Now, monofilament testing, these are some bedside tests, very basic tests that should be done in a diabetic. Monofilament test is mandatory for loss of protective sensation. The others like pinprick, vibration, ankle reflex, and biothesiometry help assess small and large fiber neuropathy, and both should be checked in patients. Monofilament test is a simple, quick, and about 95% sensitive for detecting loss of protective sensation. The vibration tests large fiber loss, while the pinprick checks small fiber damage, and both should be assessed. That's how we do a tuning fork test, very important pinprick test for small fiber. It will be great if you can have this automated neuropathy analyzer. It quantifies vibration, perception, and temperature sensation, giving an objective assessment of the large and small fiber function. Quick, reproducible, and more sensitive than bedside tests. Always, always look for color, capillary refill, and pulses. Ankle brachial index for screening, and when in doubt, toe pressure, pulse wave velocity, TCPO2 for real perfusion. And that's how we look at the dorsalis pedis and the posterior tibial. Even the residents go wrong at times. We have now, since MBBS first year time, we have become mechanical. All the pulses are all the peripheral pulses are palpable. That's not how it goes. Especially look for absent pulses in a patient with diabetes, and never ignore if there is a weak pulse or an impalpable pulse. So ankle brachial index with a handheld Doppler is your vestibular stethoscope for the foot. Quick, objective, and essential in every diabetic. This platform performs objective vascular assessment beyond just palpating pulses. It measures ankle brachial index for peripheral arterial diseases, penile brachial index for vascular erectile dysfunction. Many patients with type 2 diabetes, especially who are on beta blockers, will present with impotence. So this platform can serve that purpose also. So we often ignore small lesions on the foot, but in diabetes, nothing is trivial. A callus is not just hard skin, it marks a pressure point. Underneath that callus, tissue is dying. If we do not remove the callus and correct the pressure, it becomes a deep ulcer. Fissures and heel cracks look harmless, but they are only entry points for infection, especially in dry neuropathic skin. Many episodes of cellulitis and osteomyelitis start from a simple crack. Interdigital mycosis, extremely important. The skin becomes between the toes, breaks down due to fungal infection, becomes macerated, and creates a nidus for infection and ulcer. So don't ignore the interdigital space. A simple rat bite case. Patients with diabetes having neuropathy may not even know when after a rat bite, because for them, absence of pain is absence of problem. Do not forget dermatophytosis, ingrown nails. So at the end of the examination, you must know exactly what you are dealing with, from a healthy to high risk to unsalvageable foot. And remember, space is not a hurdle. You don't need a big setup for a diabetic foot establishment. A complete foot lab fits in just 40 by 40 square feet room. You should have a basic podiatry set. It is essential for routine diabetic foot care. Early debridement, proper nail clipping, and callus removal can prevent ulcers and amputations. Foot care education is the most powerful tool we have. Patients must understand the warning signs and follow the 5 C's of foot care: clean, condition with a moisturizer, clip the nail properly, cover the foot, never walk bare feet, and caution. If there are any pre-ulcerative changes, they should report to the doctor immediately. And we can enforce all of this with a simple audio-visual aids that they can easily follow at home. So at the end of the day, the message is simple: examine the feet of every diabetic. A good history, careful inspection, and a proper palpation catch problems early. Regular neuropathy and vascular checks are essential to prevent complications. A good glycemic control is the foundation. Set up foot clinics and prioritize patient education, prevention, and starts at home. Managing diabetic foot needs a team approach, and keep improving your services. Fewer ulcers means fewer amputations. So I would conclude by saying that in diabetic foot care, disasters don't arrive suddenly. They grow from neglect. Our job is to anticipate them, prevent them, but never wait for them. Thank you.
Thank you, Dr. Atul sir, for a wonderful presentation. Any question from the audience side? No?
Thank you, sir.
Next. Welcome Dr. Sudipta Saha, HOD and Professor, Department of the General Medicine, Raiganj Government Medical College. What is the topic? The recent advantage in management in atrial fibrillation.
So good afternoon, respected doctors and students. So first of all, I would like to thank ICP-CON MGM Medical College for giving me the opportunity to speak on this platform on this very important topic of atrial fibrillation, recent advances. So European Society of Cardiology 2024 guideline is the latest available guideline on atrial fibrillation. So I have prepared my presentation mostly based on this presentation. So firstly, atrial fibrillation is one of the most common heart rhythm disorder, which is a supraventricular arrhythmia with uncontrolled atrial activation. And it is diagnosed in ECG by absence of discernible and regular P waves and irregular activation of ventricles. This slide shows the different temporal classification of atrial fibrillation. First diagnosed atrial fibrillation, that has not been diagnosed before, paroxysmal AF, that AF that terminates spontaneously within 7 days, persistent AF, AF that lasts for more than 7 days and is not usually self-terminating, long-standing persistent AF, AF that lasts for at least 12-month duration, but where rhythm control is still a treatment option, and permanent AF, AF where no further attempts at restoration of sinus rhythm are planned. So what is new in this European Society of Cardiology 2024 guidelines? So this slide shows what are the newer changes that has been made in this ESC 2024 guideline compared to the 2023 ACC, AHA and CCS guidelines. So first of all, the AF care. It is a patient-centered approach, and here stress has been given to discuss the treatment modalities with the patient and his or her family before implementing it. So the care stands for, C stands for comorbidity and risk factor management, A stands for avoid stroke and thromboembolism, R stands for reduce symptom by rate and rhythm control, E stands for evaluation and dynamic reassessment. Next change is in the diagnostic and treatment of comorbidities part. Nowadays, there are many non-ECG wearables like Apple Watch, etc., which can detect arrhythmia, but again, stress has been given on documentation by ECG for documenting a AF before treatment is started. And also stress has been given to do a transthoracic echocardiogram in all cases of patients attending with AF, and transesophageal echocardiogram to be done in special circumstances. Also, stress has been given for management of comorbidities like hypertension, heart failure, diabetes, obesity, physical activity, because proper treatment of these also helps in better outcome in AF management, and alcohol consumption to be reduced. Nextly, CHADVA score has been modified and S gender has been omitted to include non-binary, transgender, or patients undergoing sex hormone therapy. This is the newer CHADVA score, and oral anticoagulant recommendation is now for a CHADVA score of 2 or more in all cases of AF with hypertrophic cardiomyopathy or cardiac amyloidosis, regardless of the CHADVA score, and oral anticoagulant should be considered in those with CHADVA score of 1 with risk factors for thrombosis. About the choice of anticoagulant, direct oral anticoagulants are preferred over the vitamin K antagonists, except in patients with mechanical heart valve and moderate to severe mitral stenosis, where VK is preferred. And specific antidotes of DOACs are to be used if there is life-threatening bleeding or bleeding into the critical sites in a patient who is on DOAC. Next important change is in the rhythm control within first year of diagnosis of AF. So what are the rhythm control indications in AF? First diagnosed AF with hemodynamic instability or persistent symptoms, paroxysmal AF with persistent symptoms after rate control, heart failure exacerbated by AF, and fourthly, uncertainty of the presence of symptom due to AF, but an attempt can be done to restore it to sinus rhythm within the first 12 months has been considered as a rational first step approach. So the different methods of rhythm control are electrical cardioversion, antiarrhythmic drugs, ablation, percutaneous catheter ablation, endoscopic and hybrid ablation, and open surgical pulmonary vein isolation. Pre and post-treatment with antiarrhythmic drugs improve cardioversion rate even with electrocardioversion, and so AED are to be given. Next important change is AF ablation as a first-line management. So the different catheter-based ablations are that can be done can be used as first-line management option in resourceful setups in patients with paroxysmal AF, patients with persistent AF intolerant or does not respond to AED, and patients with AF and heart failure with reduced ejection fraction with high probability of tachycardia-induced cardiomyopathy, because rhythm conversion helps in better lifestyle and reduction of morbidity and mortality in AF patients. So the different methods of catheter ablation are radiofrequency ablation, where there is delivery of thermal energy, cryoballoon ablation, which delivers extreme cold, and pulsed field ablation, where high voltage short duration electric pulse is given to damage cell membrane of the atrial myocardium, and it is the best method currently because it has high specificity for myocardium and it spares adjacent structures, thus reducing damage. So the site of ablation is pulmonary vein isolation, and other sites are posterior wall of atrium. So in this picture, I have shown how the balloon cryoablation and infrared ablation are done. And here the pulse field ablation is done in this way. And the newer modalities are 3D electroanatomic mapping, high density mapping catheter. They are used for better localization of arrhythmogenic sites. Other newer modalities are contact force sensing catheter, intracardiac echocardiography. They give us better idea about catheter tissue contact, and also use of artificial intelligence and machine learning. Second mode of ablation is the endoscopic ablation. It is a minimal invasive surgery where catheter ablation fails, and also hybrid ablation can be done, which combines the minimal invasive endoscopic ablation with followed by catheter ablation. Ablation can also be done during cardiac surgery, especially mitral valve surgery. Next change is in the surgical left atrial appendage closure during cardiac surgery, and it has been recommended as an adjunct to oral anticoagulant in patients with AF undergoing cardiac surgery, in patients of recurrent stroke with AF, in addition to oral anticoagulants, and in patients with AF who have contraindication for long-term oral anticoagulant. And nowadays, modification has been done by using epicardial clip, which does not require oral anticoagulant in the postoperative period. So this image shows how the left atrial appendage closure is done. So next is the cardiac resynchronization therapy and AV node ablation, which is indicated if a patient has continued AF-related symptom and rate not controlled with medicine. So this is mostly used for permanent AF patients and patients who are severely symptomatic and having at least one hospitalization for heart failure. So commonly used for elderly patient, and pacemaker should be implanted a few weeks before the atrioventricular node ablation. Next is device-detected AF management. So DOAC has been recommended even in asymptomatic device-detected subclinical AF with elevated thromboembolic risk patients. Next is the patient-reported outcome management. This guideline recommends to use standard questionnaires like atrial fibrillation effect on quality of life, atrial fibrillation severity scale to assess patients on AF therapy from time to time. And this is a part of the AF EQT questionnaire. And next is the recommendation for primary prevention. Different conditions like hypertension, diabetes also increase the incidence of development of atrial fibrillation, and hence proper treatment of them is essential for reduction of atrial fibrillation. So to summarize the recent changes of AF management, firstly, documentation of AF in ECG is essential for correct diagnosis. CHADVA score of 2 should be given OAC, preferably DOAC, and score of 1 should be considered for oral anticoagulant instead of antiplatelet, especially if other risk factor of thrombosis are present. Rhythm control in AF to be attempted in all symptomatic cases and also in cases where symptoms due to AF are uncertain, especially within first year of diagnosis of AF. Ablation of arrhythmogenic region to be considered as first-line management in available setup. Left atrial appendage closure to be considered for patient with AF undergoing surgery as an adjunct to oral anticoagulant. CRT followed by ablation to be done in severely symptomatic patients with permanent AF requiring hospitalization. Oral anticoagulants to be considered in high-risk patient with device-detected AF even in asymptomatic state. Symptomatic improvement to be assessed from time to time by standard questionnaire. Timely and guideline-based management of risk factors like diabetes, hypertension, heart failure, etc. reduces the risk of development of atrial fibrillation. So with this, I end my presentation. Thank you for present listening.
Thank you, sir, for a wonderful presentation.
So far 2024 guidelines. ChatVas score previously equal to 2 or more than 2. Okay. Now it has been further reduced, 1 and above. That means anyway it is positive, you should put.
Yes,
if patient does have any history of thrombosis.
Almost like that.
That is the main important amendment.
And also antiplatelet was there in ChatVas 1, so that has been removed.
That has been removed. That is the two most important recent advances.
Absolutely.
Okay, thank you.
We have a lot of valvular AF here. Non-valvular AF is there, but valvular AF because of the high prevalence of rheumatic heart disease, mitral stenosis. Now these patients, the issue with these patients is that they are not ready for INR monitoring. DOCAs are not indicated for valvular AF.
In moderate to severe mitral stenosis only.
Otherwise?
Yes, they are recommended. In
DOCAs?
Yes. Mitral regurgitation, even mitral regurgitation or aortic, all the valvular disease, DOC are recommended.
But what's the harm if we can also give apixaban in RHD severe MS with AF?
Increased risk of thromboembolism and bleeding.
Despite apixaban?
Yes.
Okay. You mean to say hemorrhagic stroke?
Yes, yes. Thank you, respected chairperson.
We sincerely thank our learned speaker for their valuable presentation and our honorable chairperson for their guidance. With that, we have come to end of our all scientific session for today's medical conference. Each sessions have to truly enrich with knowledge, insight, and inspiration. A warm thank you to all our esteemed speaker, chairperson, and attendees for making this academic journey so meaningful. Now, I would request our respected registrar sir, Dr. Ichit Bharat sir, Dr. Uttam Kumar Paul sir, Dr. P.S. Karmakar, Dr. Atul Bhatt sir, and Dr. Deep Bala ma'am to come on stage. I would also request our I would request Dr. Sudipta Saha to come on stage.
Please come forward first.
Come forward, everyone come
Valedictory session of any conference is very, very important. So this is the session for self-analysis, not to be overwhelmed with the success of the conference, but we have to go for self-analysis so that we can arrange any conference in future. If we can arrange, that should be in a better way. That's why self-analysis is very important regarding any conference. So be very careful, be very free, be very, feel free to say what are the loopholes of this conference. That is utmost importance. With these few words, I like to hand over the mic to Dr. Ichit sir. What is his own opinion regarding how the processing has went on since 2 days.
A big congratulations to the Department of General Medicine for organizing this type of national conference. What I observed, I basically observed too much. So what I observed, PGTs of medicine department are really interested in doing all the works related to this conference. And a big clap for all the PGTs and Department of Medicine. And I would request Unit 1, General Medicine, they will meet me on 15th in my office. Those who have directed the stipend, I will release that one for your performance in the conference. So a big congratulations again, especially HOD sir, PS Karamkar, Dr. Atul Baid, Dr. Bandhana, and all the teams, Dr. Deepmala, HOD Microbiology, सभी लोग जिन्होंने भी इस कॉन्फ्रेंस को इतना अच्छा करवाया. और सबसे इम्पॉर्टेंट ये है कि एक मैसेज जाता है. हमारे इंस्टीट्यूशन में जो भी फैकल्टी मेंबर्स आए डिफरेंट मेडिकल कॉलेजेस के, वो जाके आज बात करेंगे कि उस कॉलेज में हम गए थे, वहाँ हमने ये देखा, वहाँ का ये अच्छा था, वहाँ का इसका ये बिहेवियर बहुत अच्छा था, वहाँ की हॉस्पिटलिटी बहुत अच्छी थी, वहाँ का खाना का चिकन का क्वालिटी अच्छा नहीं था. तो सभी बात करते हैं. हम लोग भी जब भी किसी कॉन्फ्रेंस में या कहीं पे भी जाते हैं तो जब वहाँ से लौटते हैं तो बेसिकली एयरपोर्ट तक तो या फ्लाइट तक तो पक्का ही बात करते हैं. और जब भी ग्रुप डिस्कशंस होते हैं कॉलेज में तो बात करते हैं कि उस कॉलेज में हम गए थे. तो ये बहुत इम्पॉर्टेंट होता है, जो भी गेस्ट आते हैं उनको प्रॉपर रिस्पेक्ट मिले और प्रॉपर सपोर्ट मिले. तो एक बिग कॉन्ग्रेचुलेशन सभी लोगों को, जनरल मेडिसिन को. और एक इस तरह के कॉन्फ्रेंस से दूसरे डिपार्टमेंट को भी मोटिवेशन मिलेगा. और मुझे लगता है कि मेरे चैम्बर में कुछ लोग आएंगे दूसरे डिपार्टमेंट के जो अपने डिपार्टमेंट का कॉन्फ्रेंस कराने के लिए. तो हम लोग जो है एज ए मैनेजमेंट पूरा सपोर्ट जो है सभी लोगों को हम लोग करेंगे. थैंक यू.
Yes, now felicitation program. Most of the college authority, there is the college authority, help from the first day onwards. His help makes this conference a big success. We want to felicitate our college staffs. Dr. P.S. Karmakar sir will felicitate.
He is from outside, right?
Yes, sir.
He has observed
Yes.
everything.
First, I am calling in the dais.
Dr. Sudipto Saha.
Sudipto
Dr.
Saha.
Sudipto Saha, HOD, Raiganj Medical College. He is all the way from Raiganj, and he is, didn't have any objection to be the last person, but not the least, to be one of our most respected faculties. So I do call upon over here to felicitate our office staff. Okay, please. Dr. Rita Di,
Mrs. Rita,
Mrs. Rita Di, Jyoti, and another person?
Rajkumar.
Manish, please come over. Mr. Manish, आपको फेलिसिटेट करेंगे. रायगंज से आए हैं. Dr. Ved, please come this side.
Come. Dr. Baid, felicitate. And yeah, Sudipto, felicitate. All.
Please. Yeah, definitely.
Thank you to you all.
Big clap.
Big clap.
They are powerless.
Sal, Rita.
तुम उठाओ. मधु उठाओ.
Help
कर दो.
Their tireless dedication and work has really made this conference successful.
Yes. Thank you. Now, yes.
Now the PGTs for what they are waiting for. Now this is the time for revealing results. So first of all, one important thing, that you have competed in your platform or your poster presentation. That is the most important part. Who has won the match or who has lost the match, that is not the important. Okay, you have to take it sportingly so that your performance will be better next time. Yes. Do you have anything to say?
No, no.
Dr. Ved, regarding PGT's performance?
So you already said. No, the students who have not won any award in poster presentation or case presentation, it's only it's a simple appreciation. But all of you who have, like for example, this topic को आपने prepare किया, so you should take it in a very positive that right now you are a master in that topic. So it's a never-ending process. Even till now we are learning. So
Dr. Sudipto, you are HOD, you do have many students. So if you have anything to say in 1 or 2 words.
So all who have presented, I would like to congratulate you all, because this is a very good step. You should always use all the platforms you have, and you have used those who have presented. You have used the platform very well, and those who have not participated, I would also request to participate in future by presenting, because this is an opportunity. Getting fast is not anything, but it is a learning opportunity. So thank you.
Thank you. Regarding platform presentation on 5th, first everybody knows, because her presentation was an excellent one. She is none other than Dr. Arju from the Department of Surgery. Yes, our registered sir also declared prize money for platform presentation first 10,000 and for poster presentation 5,000. So yes, Dr. Arju. Yes, second day platform presentation. It is joint venture like Bihar Bengal, like it is Dr. Bhiblin Kaur and Dr. Sunita Roy. So you will divide the money. They have secured same marks. For poster presentation on 5th, Group A, 5th of December, Group A, Dr. Hornur Preet Kaur Bajwa. Your department, please. Ophthalmology. Yes, your presentation was also excellent. No, I am searching one boy. Group B on 5th of December, Dr. Arnav Gorai, probably from North Bengal Medical College, probably. You will give Arnav Gorai? Arnav Gorai? Yes, you will give this message to him. On 6th, poster presentation, again in Group A, Dr. Arju, Department of Surgery. And the judges said that, again, her presentation was an excellent one. With diabetic, probably in poster presentation, that was diabetic foot, management of diabetic foot. And Group B today, Dr. Kumari Bhavana. From which department? Community medicine. Very good. What was your topic? Good, good, good. Blood donation. I will request Dr. Atul Boyd, sir.
One thing, general medicine is a very vast subject. It is an ocean. So general medicine does have a very broad heart also. So they have sacrificed many of their prizes and they have allowed others, they have won the match, and probably due to their broad heart, they won't mind the general medicine that we have lost the match this time. The next time will be yours.
Surgery is there, medicine is there, community medicine is there, ophthalmology is there. Yes, thank you.
So I thank you all for your gracious participation. Special thanks to the Honorable Registrar for attending our valedictory as well as inaugural, and special thanks to postgraduates for working so hard for this conference. Thank you so much.